standards of oncological practice in Sri Lanka. It has been an amazing journey for the college through multitudes of challenges and obstacles to gain strength day by day, and now has become one of the leading professional bodies of Sri Lanka.
During challenging and tumultuous times, which engulfed the whole world, we had our annual sessions as a fully virtual Congress last year. This year, we are fortunate to have our sessions using hybrid platform, and many delegates around the globe join us in virtual platform in addition to our audience present at the venue. We extend our sincere gratitude to our international faculty, and we are very privileged to have you with us all. And equally, we are extremely thankful to our local fraternity for their enormous contribution in these turbulent times.
The academic sessions this time consist of a pre-Congress workshop, which was successfully concluded yesterday, and also 4 symposia, 6 plenary sessions, 6 teaching capsules, and a free paper session.
Without further delay, in order to commence the sessions, please rise for the national anthem. Thank you very much.
In order to commence the annual academic sessions, let us move on to our first event, which is the keynote lecture. It is a great privilege for me to introduce Professor Shankar Shiva, who is a radiation oncologist and leads the stereotactic ablative body radiotherapy program at the National Cancer Centre in Australia. He is the current Cancer Council Victoria Colbatch Fellow and is internationally recognized for his work in high technology radiation therapy delivery. He leads multiple clinical trials in the fields of oligometastasis, lung and genitourinary cancers, and has a special interest in SABR and immunotherapy combinations. So without further delay, let me invite Professor Shankar Shiva to deliver his speech.
I'd like to thank the organising committee of the Sri Lanka College of Oncologists for the opportunity to present to you today. My talk is entitled Radiotherapy for Oligometastatic Disease. My particular focus will be on stereotactic body radiotherapy. As a background, the curative approach for metastatic disease is in fact long held. In fact, the first lung resection was reported for renal cell carcinoma in 1939 by the surgeon Barney. The patient had a solitary kidney primary disease and a large metastasis to the lung. This lung metastasis was treated with a short course of radiotherapy and then subsequent pneumonectomy. And this patient died 23 years later without any evidence of cancer. The theory for metastasis-directed therapy is really threefold. There are three rationales. One is for potentially curative treatment, but we're becoming increasingly aware that this is a very small subset of the population. One is a potential for debulking of macroscopic disease to allow more effective systemic therapy. And this is the Norton-Simon hypothesis of Gompertzian growth. And finally, to prevent metastasis to metastasis seeding of disease. And this is a newer concept that we're becoming more and more aware of. So where do we get the idea of metastasis to metastasis theory? This may be actually evidence from some work from the Swanton Laboratory tracking the evolution of non-small cell lung cancer. By looking at subregions within clones of the primary non-small cell lung cancer, we can tell that there are genomic areas that are private and not shared between other regions of the same primary. So subregionality within the same primary disease. This can lead rise to private mutations that are not shared between even different regions of the primary, and potentially these subregions of the primary itself can lead to different forms of metastatic disease. The idea that metastasis can give rise to other metastases is largely from an evolutionary process. We used to believe that most of the metastatic events are on the right-hand side of this pictorial graph, which is a single event, a metastatic cascade, and a shower of metastases at one point. We're becoming increasingly aware that there are other points on this map that can be describing the evolutionary process of metastatic disease, including parallel evolution of clonogens from one site to another, polyclonal seeding from lymph nodes or primary disease into other sites of disease, or cross-metastatic seeding from metastases to metastases. This is a theoretical framework, but do we have evidence of this approach? And there is increasing evidence from whole genomic sequencing of rapid autopsy series. This is an example published by Gunderman et al. In Nature in 2015 that was demonstrating the idea that metastasis to metastasis seeding can occur in prostate cancer. And this is an example of whole genomic sequencing of different sites of disease, indicating, for example, in panel A, that the primary was metastasizing to other sites of nodal disease. In panel A22-2, that there are multiple sites of nodal metastatic disease giving rise to other sites of disease. And finally, crossed and branching patterns of spread from metastases back to the primary and also from metastasis in the node and vice versa. In this kind of scenario, the theory for local therapy is largely to address local sites of disease before they continue to cross-metastasize to other sites. This is an example of a pictorial hypothetical case of a patient with the primary large bowel cancer. In this case, the tumour initially begins to grow in the primary until it becomes detectable as a primary disease using conventional imaging. And at this point in time, the patient has developed metastatic disease, with the first metastatic event in the liver with M1A disease. In this theoretical framework, the M1A disease gives rise to other metastases within the liver. The primary then gives rise to other metastases in the humerus. And subsequently, the humerus metastasis give rise to a brain metastasis. And finally, the terminal event is a multiple shower of seeding events in the lung with pulmonary metastases. This is the idea that one metastasis can evolve to seed other metastases in rapid succession with little seeding and little interventional evolutionary time. It's not necessarily an immediate metastatic shower that occurs to the body. In this scenario, the potential effect of local ablative therapy is to address these areas of established metastatic disease prior to eventually causing that seeding and final showering of metastatic event. We don't know whether the best approach to prevent this terminal seeding event is either radiotherapy or surgery, and this is still yet to be discovered. To give an overall framework of the best way to address oligometastatic disease, I draw the audience to the attention to this recent publication in Lancet Oncology. And to simplify the approach, there are basically three different ways I look at oligometastatic disease. That is the de novo or upfront setting, in which there is synchronous oligometastatic disease or metachronous oligorecurrence after a period of treatment of the primary and recurrent disease. There is induced oligoprogression, and this is a rarer event, which has limited data for, in which case a patient has active systemic therapy, all of the disease is controlled, and unfortunately one area in the blue, which is indicating a growing or progressing site of disease despite an otherwise effective systemic therapy. There is a concept of induced oligopersistence, where a patient presents with widely metastatic stage 4 disease and has an effective systemic therapy, but then has isolated residual disease, which can be addressed by local therapy. In the first instance, let's address the de novo or upfront setting of synchronous and metachronous oligometastatic disease. One of the seminal papers in this area is the SABRE-COMET study, and this is a randomized phase 2 trial that enrolled patients with up to 5 sites of metastatic disease and randomized to a 2-to-1 ratio to either standard of care therapy, including palliative radiotherapy to symptomatic sites, versus standard of care therapy with SABRE to all sites of known disease. The progression-free survival data showed a significant benefit in favour of the arm that received SABRE on top of standard therapy, with a long-term 16% progression-free survival versus 0% in the standard arm. This resulted in a doubling of the median progression-free survival from 6 months to 12 months, which was highly statistically significant. More importantly, from an overall survival perspective, this study was a screening phase 2 study with a p-value of 0.09. Did actually found that this is a positive study for overall survival, in which case there was a 46% long-term overall survival as compared to a 24% in the control arm. This is an interesting and provocative data, but it still is a randomized phase 2 study which needs further evaluation. Our own data at Peter Mac and throughout the Trans-Tasman Radiation Oncology Group was focusing on the TROG 1301 study, addressing the use of single versus multifraction SABRE in the specific scenario of pulmonary oligometastasis. This particular study was run across multiple centres in Australia and New Zealand. The background to this trial was that there is actually no randomised data of SABRE for patients with pulmonary oligometastasis. And our particular study was designed to address the question of single versus multifraction SABRE. We hypothesised that each arm had acceptable adverse event profiles, efficacy and quality of life effects, but that single fraction SABRE was cost effective. The primary outcome data was presented at ASTRO 2021, and these outcome data was no different at this stage when it was presented at ESTRO just a few months ago. We found that the multifraction arm had a severe grade 3 or higher adverse event profile of 5%, and the single fraction arm of 3% with no significant differences. The design of the study was to pick the winner phase 2 randomised design, in which the secondary endpoints were all evaluated individually, including patient-reported outcomes using the severity index of MDASI lung cancer specific criteria, the health-related quality of life using the Europol 5D visual analog scale, addressing freedom from local failure, overall survival, disease-free for survival, and resource utilisation. This trial was a multi-centre, open-label, phase 2 study in which patients had 1 to 3 oligometastases of less than 5 centimetres to the lung from any non-hematological malignancy. They were non-central lesions located 2 centimetres away from central airways, and all patients had a good performance status of between ECOG 0 to 1 and all primary and extrathoracic disease controlled with local therapy. There were 90 patients recruited across 13 sites in Australia and New Zealand, with a total of 133 metastases treated. Patients were randomised with stratification factors and balanced by the presence of colorectal versus non-colorectal metastases, and the number of metastases being 1, 2, or 3. Time to event outcomes were described using Kaplan-Meier methods with a 95% confidence intervals, And the randomization was between 4 fractions of 12 gray to a total dose of 28 gray versus a single fraction of 28 gray to each lesion. The median follow-up was 3 years. The headline results from an efficacy perspective were that there was no significant difference between single fraction and multi-fraction for overall survival, freedom from local progression, or disease-free survival. The overall survival in the top left panel had a hazard ratio of 1.5, favouring the single fraction arm, which was not statistically significant. The freedom from local failure had a hazard ratio of 0.5, favouring the multi-fraction arm, which was not statistically significant. And the progression, disease-free survival in the bottom left panel and modified disease-free survival were not statistically different. Modified disease-free survival speaks to the idea that these are events defined as progression that could not be salvaged with local treatment. And so it talks to this group, a subgroup of population that did not require palliative intense systemic therapy, but continued with local salvage treatment options. From that perspective, the modified disease-free survival in both of the treatment arms was approximately 40% at 3 years. We also had a look at the optimal SABRE fractionation schedule for immunogenicity, and the exploratory observation in the subset of 18 patients who had multiple blood draws and peripheral blood mononuclear cells analysed for peripheral tumor T cell subsets showed that the SABRE alone induces changes in the composition of circulating immune cells and also potentially altered their functional status. We saw an increase of percentage abundance of CTLA4 and PD-1 expressing CD4 and CD8 T cells in the periphery. We concluded that SABRE alone, both single fraction and multi-fraction to pulmonary oligometastasis, drives systemic immune activation. And we wondered also whether this approach could actually be augmented with the addition of immune checkpoint blockade. And both of these single fraction and multi-fraction approaches would likely engage the immune system in this manner. So in conclusion, the results of TROG 1301 found that both single fraction and multi-fraction SABRE met the primary endpoint of safety, and there was no significant differences in patient-reported outcomes, efficacy, survival, and both arms were able to induce systemic immune activation. The single fraction arm was picked as a winner based on a favourable cost-effectiveness profile of this study, and the findings were consistent with other randomised phase 2 trials, albeit in the context of primary non-small cell lung cancer, which is the RTOG 0915 study, which tested single fraction 34 gray versus 48 gray and 4 fraction, and the Roswell Park study that tested single fraction of 30 gray versus 60 gray and 3 fractions. And in all 3 randomised trials, the single fraction arm was chosen to escalate in future trials. This study is now published online, and I direct the audience to have a look at this in JMR Oncology. Our own approach to the Peter MacCallum Cancer Centre has been to largely use single fraction radiotherapy or SABRE in the context of oligometastatic disease. And this particular audit was performed and published in March 2021 of the Red Journal. Our own experiences addressing patients from February 2010 to June 2029 who received single fraction SABRE for oligometastatic disease. In total, we analysed 371 patients with 494 extracranial metastases, and this was a mixed histology basket population with up to 5 metastatic sites of disease. The median follow-up was 3.1 years, and this study was found that single fraction SABRE was quite safe, with 12 patients or 3% developing a grade 3 to 4 treatment-related toxicity, with no grade 5 toxicities recorded. This should be taken with the reservation this is a retrospective study, and high-grade toxicities can be sometimes underreported. From an outcome perspective, the median overall survival was 5.4 years, and the median progression-free survival was 1 year. We also looked at the idea of widespread failure-free survival, which is the same concept as that modified disease-free survival, which indicates in patients who had not had any systemic therapy, but were being treated with local ablative therapies. And in this context, a quarter of the patients at 5 years were free from any systemic therapy, but had received more than 1 course of SABRE. From a freedom from systemic therapy perspective, this translated to approximately 43% of patients who did not require any systemic therapy in 3 years, and 35% of patients at 5 years not requiring systemic therapy. The 5-year local failure-free survival after our approach of single fraction SABRE was approximately 8%. Interestingly, distant failure is, as expected, to be the predominant cause of failure after SABR for oligometastases. But the second most common pattern of failure was actually local regional to the primary. And that means that our study findings have suggested that potentially we should consider maximising local control of the primary and ensuring that this has had adequate treatment and adequate control when embarking on metastasis-directed therapies. So the conclusions from the Peter Mac experience is that single fraction SABR is highly tolerable, but less than 3% high-grade toxicity rate, that 43% of patients are free from systemic therapies at 3 years and 35% at 5 years. And this is really an interesting approach to maintain quality of life in patients who have a very brief visit, a single treatment for their oligometastatic disease without ongoing systemic therapy and their associated toxicities. There is also a subset of cure at 5 years, 14% without any repeated treatment, and approximately 24% with repeated SABR or local therapies. And this is very provocative. An example case is this case of a patient who presented in 2015, 62 years old, very fit and well, and a full-time manual labourer. He had high-grade 85 millimetre clear cell carcinoma of the left kidney that was resected in January 2015. He also had a synchronous solitary right lung metastasis resected at the same time. In September 2015, he presented with a recurrence in his lung with 2 further lung metastases. He was sent to myself for an opinion regarding SABR, and we delivered single fraction SABR of 28 grade to both of these lung metastases that were close by. This is an example of what happened after the treatment in 2016 in February. There was a PET scan showing there was post-treatment inflammation at the sites of disease. And then in April, he had a growing adrenal metastasis on FDG PET scan that was confirmed as showing some increasing activity consistent with the adrenal metastasis. In this scenario, he underwent further SABR with 26 Gray in a single fraction delivered into this left adrenal metastasis. He also had PSMA PET scans, which intriguingly is actually quite useful for renal cell carcinoma, particularly in oligometastatic disease. And I won't go into too much detail here, but these are the example PET scans of before lung SABR, showing after lung SABR, showing the development of bulky disease in May 2016, and after the adrenal SABR, showing complete metabolic or complete PSMA resolution of disease in the October 2016 scan. But unfortunately, 6 months after this treatment, he had further lung metastases noted. So at this point, this is the general timeline of this patient. Presenting in January 2015 with a nephrectomy, right upper lobectomy in April 2015, SABR to 2 left upper lobe lung metastases in 2015, October, SABR to a left adrenal metastasis in May 2016, further SABR to the right lung in November 2016, and then further SABR 6 months later in July 2017, and finally to a spinal metastasis in May 2018. This patient eventually had, over the course of 3 years, metastasis-directed therapy to 6 lesions, 5 times SABR and 1 lung metastasiectomy. From a patient experience perspective, his quality of life was maintained, and he did eventually start systemic therapy in July 2018, and is still ongoing on second-line systemic therapy today. Let's look at a different approach, which is local consolidation SABR as a treatment strategy. And this is in the idea that not of synchronous oligometastatic disease, but moving across to the idea of using systemic therapy first and then giving induced oligopersistence with SABR to residual sites of disease. In this oligopersistent pattern, we have the pattern on the left where patients progress despite of systemic therapy, and the pattern on the right where they have oligopersistent disease, good treatment outcome to the systemic therapy, but residual disease on scans. There are some multi-center randomized phase 2 studies in this design, in this setting. And this is an example from a collaboration between MD Anderson, University of Colorado, and London, Ontario. In this multi-center phase 2 study by Daniel Gomez, the Independent Data Safety Monitoring Committee actually halted the study early at 49 patients due to futility of the control arm. And in this context, the control arm was basically induction systemic therapy and ongoing systemic therapy, which is the standard of care for stage 4 disease. The experimental arm had a local consolidation therapy after 3 months of induction therapy. And in this context, it's also important to note that SABR was not the only treatment approach. There was a mixed bag. There was 48, almost half the patients having SABR, but a combinations of radiotherapy and surgery, and chemoradiation therapy. The results were published in June 2019, and importantly, the arm that received induction systemic therapy and then local consolidation treatment to up to 3 sites of disease resulted in a tripling of the median progression-free survival from 4.4 months to 14.2 months as compared to the standard of care arm, which is ongoing systemic therapy. The authors intriguingly pointed out that this was likely due to the benefit of a reduction in time to the new lesions forming, so new metastatic disease. This median time to new metastatic disease was 14.2 months in the experimental arm versus 6 months in the standard arm. And this may speak to the idea that treating macroscopic sites of disease may result in reduction of development of new metastatic sites. The overall survival was also much improved in the group that receiving metastasis-directed therapy, with a median overall survival of 41.2 months in the experimental arm versus 17 months in the standard of care arm. And this is despite the fact that almost half the patients in the standard of care arm received some form of local consolidation therapy at progression, and speaks to the idea that this early intervention of metastasis-directed therapy, perhaps after 3 months of induction systemic therapy, proving that the systemic therapy works, is really an optimal approach rather than waiting for progression down the track. This study also was similarly conducted in a similar fashion from UTS Southwestern by Iyengar and colleagues. And in this study was also stopped early in this term for slow recruitment. There were 34 patients that were enrolled and 29 patients randomized, and again showing an improved progression-free survival with the idea of SABR consolidation therapy after induction treatment versus systemic therapy as a standard of care. And this has led to the NRG LU002 study, which is looking at this very same approach in patients who had systemic therapy and no evidence of more than 3 sites of disease after induction 4 cycles of systemic therapy. And they're randomized to either maintenance systemic therapy versus maintenance systemic therapy and stereotactic radiation to all visible sites. The study is ongoing and recruiting. For interest, lung cancer is probably the field that is most up to date and most advanced in this field of use of oligometastatic disease in the upfront and persistent cohorts. Direct you to this study looking at local ablative therapies upfront or outback. This particular narrative shows all the current studies in the table form of consolidation treatment that are recruiting, and these include phase 2 and phase 3 studies that are ongoing, and with a sample size numbering in close to 1,000 patients. Finally and briefly, I want to just touch on the idea of induced oligopersistence and induced oligoprogression, and this is the middle column here. This is the group that we probably see in clinical practice quite frequently, at least locally at the Peter MacCallum Cancer Centre. The evidence for this is quite sparse and there's very little prospective data. This is the idea that a patient has active systemic therapy and has a long course of systemic therapy and has had a successful treatment, but then eventually develops solitary sites of disease or limited sites of disease up to 3, for example, that then begin progressing despite the systemic therapy controlling all other sites of disease. And this is an example of a blue area there, which is growing, or a red area, which is regrowing after initial systemic therapy. There's one particular study I'd like to highlight from Dr. Chung and colleagues from Sunnybrook in the renal cell carcinoma setting. It's just impressed now. And this is a phase 2 single-arm study that has been recruiting and stopped early due to poor accrual. However, recruited 37 patients who had oligoprogression on a tyrosine kinase inhibitor in the first line setting in renal cell carcinoma. And these patients progressed with 1 to 5 sites, predominantly one site. These authors, in a multi-centre fashion, were able to report a 1-year local control rate of 93% and a median progression-free survival of 9.3 months after the use of SABR. And this resulted in a median time to switch of systemic therapy of 12.6 months, as opposed to consideration of immediate systemic switch of strategies, and no grade 3 to 5 toxicities. And this is the idea that potentially we can eke out more time on an otherwise effective systemic therapy before moving to another line. So with that, I'd like to thank you for your attention and again for the kind invitation to present to you today. And I look forward to the panel discussion. Thank you.
Thank you, Professor Shiva, for that very interesting talk on treating oligometastatic disease. We have a little time for questions. Does the audience have any questions for our speaker?
Congratulations, Shankar. That was an excellent informative talk. My question is, have you after offering 28 gray single fraction to the lung, and if there was an infield recurrence, have you retreated?
That's a great question. I think that's Krishy. I can't exactly tell, but we haven't needed to necessarily. There have been localized or marginal recurrences that we have treated with repeat SBRT or SABR, and that has not been a great issue. So on occasion, we may see a lesion that's nearby and within the high dose region. But infield recurrences, when they do occur, my general preference is to look for a different modality of treatment approach, and that's often surgery rather than repeat radiation.
Shankar, and for marginal recurrences, what was the dose used?
So marginal recurrences, I think are probably in that kind of geographical within a centimetre or two, not exactly at the edge of the tumour, so not an infield recurrence, but just outside. I often find that that's in the context of fibrosis and retraction of lung. So full dose radiation is often used again. So other fractionation schedules like 28 gray in 1 fraction, or again, a fractionated 48 gray in 4 like we used in Saffron 2. But generally speaking, it's not a reduced dose of radiotherapy. It's around that ablative BED 100 gray that we use.
Great, thank you. And even immunotherapy, we know that it has lots of side effects, but I know that you have done studies where you combine immunotherapy with SABR. Would you mind sharing your experience, please?
That's a really interesting area. So we did actually show some data at the World Lung Cancer Congress in 2019, where we reported some data on pulmonary oligomets from renal cell carcinoma and the use of SABR in that context. So in this particular protocol, we did 6 months of pembrolizumab and used SABR to multiple sites of disease. And on average, there were about 3 pulmonary mets per patient, so quite a significant burden. We found that there was additive toxicity. So each pembrolizumab and SABR had around about 5% rate of pneumonitis. Together, it's about 15% in that cohort, specifically for lung. So my general feeling is I don't think it's a synergistic toxicity with the addition of radiation and immunotherapy, but they're both independent and additive. So there's increased risks, but not a multiplying approach.
Thanks. Thank you so much.
Thank you, Professor Shiva.
So let's move on to the first symposium of the day. All our speakers are joining from United States of America. This symposium updates us on defeating hepatobiliary cancers. Let me have the honor of inviting Professor Rahul Pannala. Professor Rahul Pannala is an associate professor in medicine and the director of Pancreas Clinic at Mayo Clinic, Arizona. Professor Pannala is a fellow of American Gastroenterology Association and the American Society of Gastrointestinal Endoscopy. His clinical practice is primarily focused on pancreatic diseases, including pancreatic cancer, cysts, and acute and chronic pancreatitis, in addition to therapeutic interventions in pancreatic and biliary diseases. His research is currently focused on clinical significance and assessment of fatty pancreas and novel imaging modalities for pancreatic neuroendocrine tumors. He also has a strong interest in medical innovation and international health. Over to you, Professor Rahul Pannala.
Hello, everyone. My name is Rahul Pannala. I'm a consultant gastroenterologist at the Mayo Clinic in Arizona, and it's my distinct pleasure to be able to present over the next 20 minutes or so on indeterminate biliary strictures and approach to diagnosis and management. At the outset, I really want to thank the organizers for the kind opportunity to present on this topic. So we're going to basically talk about the definition of an indeterminate stricture. What is an indeterminate stricture? What the differential diagnosis to consider? We'll define the dominant stricture in primary sclerosing cholangitis and what the best strategy to approach that is. How we manage these endoscopically, primarily related to endoscopic sampling and assessment, and then the overall summary of how to approach these indeterminate strictures. So what is an indeterminate biliary stricture? It's defined as a biliary stricture without a tissue diagnosis or a clear evidence of a mass lesion on imaging. It really can be a challenging step, as the lack of a diagnosis can really impede next steps in terms of management. And it ends up being a probability or a risk stratification of the possibility of an underlying malignancy. And there are several new technologies that are available that are being quite helpful in trying to determine whether a stricture is malignant or from a benign etiology. So we divide biliary strictures into benign and malignant. I won't go over all of the differential diagnosis here, but it's there for your review. Primarily, it comes down to, especially as it relates to indeterminate biliary strictures, what is the probability of malignancy? And these are the usual malignancies that we consider. Cholangiocarcinoma and pancreatic cancer end up being the 1 and 2. But definitely have to consider metastases, hepatocellular carcinoma, gallbladder carcinoma, and periampullary cancer. And really, from an inflammatory perspective, the primary differentiators are going to be pancreatitis, especially chronic pancreatitis, and primary sclerosing cholangitis. So how do we differentiate strictures just based on morphology? I think MR imaging or CT and ERCP can be quite helpful. Some of the features that point towards a more benign etiology include multiple strictures, especially skip strictures involving either the extrahepatic duct and the intrahepatic duct, either a very short stricture or a very long stricture, a smooth transition to a normal sized duct, the lack of a abrupt cutoff or a shoulder, and smooth regular margins can point towards a benign stricture, whereas the opposite of all of these can point to more of a malignant stricture. These are obviously general guidelines, but they can be helpful when one is assessing these strictures in ERCP or on imaging. So where does imaging fall? I think imaging is very, very critical in terms of our approach to indeterminate strictures. The maximum amount of information that we can get from cross-sectional imaging would be very helpful in terms of differentiating these strictures. And primarily our go-to imaging modality of choice is an MRI with the MRCP sequence. CT imaging can be quite helpful, both in looking for metastases, but also to look for any evidence of chronic pancreatitis, especially where it can be quite helpful. Transabdominal ultrasound can be quite helpful and is usually the first line of the imaging spectrum. You can evaluate the common bile duct, the thickness of the bile duct wall, any degree of duct dilation. But many times we end up going to an ERCP, especially to clarify some of the findings on MRCP or for primarily sampling. And ERCP obviously can be very helpful to define a stricture and to sample it. ERCP obviously comes with its own risk that we, especially pancreatitis, bleeding, cholangitis, things like that. So these have to be taken into the risk benefit analysis. So what are the endoscopic tools that are available to further evaluate an indeterminate biliary stricture? Starting from less invasive to more invasive in a sense, is endoscopic ultrasound is a very useful tool. ERCP with intraductal ultrasound, brushings, biopsy, ERCP with direct cholangioscopy, and some of the newer techniques that I'll briefly touch upon, which are the confocal and volumetric laser imaging. These can also be helpful to further differentiate these strictures. So let's touch upon a few of the clinical conditions, like I was mentioning before, which are the primary clinical conditions to think about when faced with an indeterminate biliary stricture. Starting with chronic pancreatitis, it's something that's very common. Typically, a biliary stricture in chronic pancreatitis is a distal biliary stricture of the intrapancreatic portion of the common bile duct. As you all know, there's an increased risk of pancreatic cancer in chronic pancreatitis, and that's where the catch becomes, how do you differentiate a biliary stricture from true chronic pancreatitis versus pancreatic cancer? And CT can be quite helpful, especially a pancreas protocol, well-done pancreas protocol CT, which can look for a pancreatic mass in the setting of chronic pancreatitis, and endoscopic ultrasound. But again, ERCP with brushings and biopsies can also be very helpful to exclude malignancy. But having said that, even with all of these tools, it can be quite challenging to differentiate or to pick up an underlying malignancy in the setting of florid chronic pancreatitis. I think the most important take-home message there is that if there are associated clinical features, or if there's a strong suspicion, repeated sampling and repeated evaluation of the patient can be very helpful. So this is an example of a distal bile duct stricture in chronic pancreatitis. For folks who are not endoscopists, this is my duodenoscope in the duodenum. I'm injecting contrast through a small catheter in the bile duct. And as you can see, there's tapering of the intrapancreatic portion of the common bile duct all the way through here, and the upstream bile duct is quite dilated. So this we usually treat with endoscopic therapy. In chronic pancreatitis, we've gone more and more towards placing biliary metal stents that we leave in for a long period of time that essentially remodels that area. And then here we are doing pancreatic therapy with placing pancreatic stents also. Now, as you can see, this is a patient with pancreatic cancer. And if I didn't give you the title and the diagnosis, it'd be very hard to differentiate. So it also forms a distal bile duct stricture. And again, here we're treating it with a metal stent. But I think this case is put in, I wanted to illustrate really how challenging it can be to differentiate between these strictures. And it's important to really sample, have a high degree of suspicion, correlate with cross-section imaging, correlate with tumor markers before dismissing these strictures as simply from chronic pancreatitis. As we were talking about, pancreatic adenocarcinoma is the main differential. Pancreatic adenocarcinoma will cause a double duct sign, where you can see the pancreatic duct and the common bile duct are both obstructed. This can be quite helpful and can be quite a telling sign for pancreatic cancer. And obviously, if you see a mass on cross-sectional imaging, as you see here, that would lean you more towards more towards pancreatic cancer. Changing gears a little bit when moving on to primary sclerosing cholangitis. A dominant stricture is seen in about half of the patients with primary sclerosing cholangitis, as this cartoon here illustrates. The location is typically at the hilum or in the common bile duct. Occasionally, it can be in the intrahepatic ducts here, but typically we see it either at the hilum or in the extrahepatic duct. And a dominant stricture is defined as, in the extrahepatic duct, a stricture diameter of less than 1.5 millimeters, and usually a stricture length of greater than 2 centimeters. But in the intrahepatic ducts, a stricture diameter of less than 1 millimeter and a stricture length of usually 1 centimeter. So these are some examples of cholangiograms in primary sclerosing cholangitis with dominant strictures. As you can see, this patient has a fairly long stricture in the distal common bile duct and also at the hilum. This patient also has a fairly long stricture in the extrahepatic bile duct and multiple intrahepatic strictures. There's also marked dilation of the left hepatic duct, possibly with some intraductal debris and filling. So these are the kind of dominant strictures that we see in primary sclerosing cholangitis. And the question always becomes, is there an underlying cholangiocarcinoma here? And a benign entity that can clearly mimic any of these conditions that we talked about is IgG4-related disease or IgG4-related cholangiopathy. Obviously, we don't have time to go into detail about this, but it can present as extrahepatic strictures or intrahepatic strictures, and this usually responds to steroid treatment. There's another example of a patient with IgG4 cholangiopathy. You can see a marked and a very irregular extrahepatic stricture, multiple intrahepatic strictures that's gradually responding to steroid treatment. You know, the intrahepatic strictures here are still persistent, but the extrahepatic strictures are somewhat improved on steroid treatment. And here, the intrahepatic duct has completely resolved. This patient was finally started on rituximab, but you can see that gradual improvement and normalization of the biliary tree. Now, it can be very easy to confuse this with PSC, or in the distal bile duct stricture to confuse it with either pancreatic cancer. But again, we look for other features, other clinical features, and make a diagnosis based on that. The dominant stricture in primary sclerosing cholangitis is what I call a wolf in sheep's clothing. You all have to have a high degree of suspicion for cholangiocarcinoma. And the dominant stricture is usually at initial diagnosis, makes the patient symptomatic, or can develop subsequently in the disease course. The obstructive symptoms such as jaundice, pruritus, and ascending cholangitis are the typical features that one sees in in patients with dominant strictures. Why these are important? These are directly correlated with reduced survival free of transplant. So if the patient has a dominant stricture, we want to know if there is a cholangiocarcinoma, and at least in some places, such as ours, we want to get this patient to a liver transplant. So as we were talking about, cholangiocarcinoma should be considered in every patient with primary sclerosing cholangitis and a dominant stricture, have a high index of suspicion because half of cholangiocarcinomas are diagnosed within the first 4 months of diagnosis of PSC, and the challenge is to differentiate it from an inflammatory stricture. What are some of the clinical clues? Older age of diagnosis, it leans more towards a cholangiocarcinoma. Pediatric patients are unlikely to have a cholangiocarcinoma. Rapid clinical deterioration or decompensation of liver disease is a very telling sign. And a progressive dilation in the setting of a dominant stricture obviously should raise concern for cholangiocarcinoma. Again, MRI and MRCP are the test of choice. A well-done and high-quality MRI is invaluable in evaluating this. A mass lesion with a venous phase enhancement can be very specific for cholangiocarcinoma. Look for enhancement on the delayed phases, and look for new bile duct wall thickening, nodularity, lymphadenopathy, anything that would point to the presence of a cancer. PET scan can be helpful, but can be associated with quite a lot of false positives in PSC. So in patients who have a persistent concern for cholangiocarcinoma, a PET scan can be quite helpful. So this is an example of a hilar cholangiocarcinoma, what we call a bismuth-4 cholangiocarcinoma. You can see a large infiltrating mass invading multiple right and left lobar ducts and secondary radicals. Again, this is a different view of that, and this is an MRCP sequence showing that shelf with a tight stricture extending into the lobar ducts. So this would be consistent with a bismuth-4 cholangiocarcinoma. So how do we sample these strictures? We do either cytology or fluorescence in situ hybridization, intraductal biopsies, cholangioscopy-guided biopsies, or sometimes endoscopic ultrasound-guided fine needle aspiration. Breast cytology is something that we do all the time. So a lot of data, the sensitivity is low, but specificity is quite high. In the Mayo series of quote-unquote suspicious cytology, about 30% develop cancer over 2 years. And typically here, we would use supplemental techniques that are such as FISH, tumor markers, things like that. And when it's reported as atypical, it's usually due to inflammation. So these are some examples of a good cytology that you would get from the intraductal brushings. As you can see, this shows an obvious adenocarcinoma. Again, When it's positive, it can be quite helpful. When it's negative, it's not. You have to resort to other techniques, especially if you have a high degree of suspicion. Fluorescence in situ hybridization can be incredibly helpful. We use this routinely in patients with PSC. We look for either a fully negative, either trisomy, tetrasomy, or polysomy. Tetrasomy and trisomy have outcomes that are similar to FISH negative patients. But polysomy is something that one has to pay attention to, as this graph shows. And about 55% of patients who have polysomy on FISH are diagnosed with cholangiocarcinoma eventually. And especially if you add a dominant stricture and polysomy, the number goes up to 73%. And then other supporting features such as a CA19-9 and polysomy, or patients who have multifocal polysomy, if you're able to demonstrate that, that establishes a field defect that can be quite high or a good predictor for potential cholangiocarcinoma. For example, this is a patient who has a dominant stricture in the hilum extending into the right hepatic duct. This patient had atypical cells, but has a high CA19-9 and FISH positive, and is being treated as a cholangiocarcinoma and is on the transplant protocol at our institution. So finally, in the last couple of minutes, what are some of the newer tools that can really help in terms of advanced imaging? Cholangioscopy is not really that new, and we use this routinely, but it can be quite helpful to really understand the segmental distribution, to really evaluate the stricture. So this is done at the time of ERCP, and we pass what we call a baby scope through the regular scope and into the common bile duct. As you can see, this shows a normal biliary epithelium. This is a patient with cholangiocarcinoma, and this is a patient who has an inflammatory stricture. Here you can see a mass lesion within the common bile duct. Here you can see a fairly long inflammatory type stricture, and we have the ability to take selective biopsies. And many times we'll do segmental biopsies throughout the bile duct to really give the surgeon and the oncologist an idea of the extent of disease, so that further treatment can be planned. Next is intraductal ultrasound. This is also a wire-guided catheter that is done at the time of ERCP. It's not widely available, and criteria are somewhat are still being developed because the inter-observer agreement can be quite suboptimal. But one place where it can be really helpful is IgG4 cholangiopathy and differentiating PSC from IgG4 cholangiopathy. So if you do have access to this, I think it's worthwhile to use it. But it's not that widely available. What are some of the newer kids on the block is volumetric laser imaging. This is optical coherence tomography of the bile duct. As you can see, the scattering of the biliary signal here that can be very characteristic for cholangiocarcinoma. Whereas here in PSC, you see the classic onion skin fibrosis, where you can see the multiple layers. Unfortunately, this has been taken off the market in the US, but this was a very valuable tool, and we hope that this will come back. There's several other tools such as confocal endomicroscopy, which can be helpful, but again, the criteria for them are being developed, and I think that once those criteria are developed and validated, those can be helpful. But right now, the problem is the inter-observer variability. So in summary, we talked about what is the differential diagnosis for a biliary stricture, especially an indeterminate stricture where there's concern for malignancy. We talked about dominant strictures in primary sclerosing cholangitis, where nearly half of patients with primary sclerosing cholangitis will have a dominant stricture, and discriminating an inflammatory dominant stricture from a cholangiocarcinoma can be quite challenging. There's several tools that are available, sampling techniques, but cytology, FISH, and intraductal biopsies are the most commonly used. They do have limitations. Some of the newer techniques can be helpful, but the criteria and the inter-observer variability are some of the limitations of the newer technique. Thank you. Thank you very much for your attention.
Thank you very much, Professor Pannala.
The next speaker from our expert panel on hepatobiliary cancer is Professor Amit K. Mathur. Professor Mathur is a consultant in the Division of Transplant Surgery, Department of Surgery, Mayo Clinic, Phoenix, and an Associate Professor of Surgery in the Mayo Clinic, Alex School of Medicine. Dr. Mathur is the Fellowship Program Director of the Abdominal Transplant Surgery at the Mayo Clinic in Arizona. He also serves as the co-chair for transplant quality and compliance locally and at the enterprise level. He serves as the director of the Mayo Clinic Hispanic Transplant Program. Over to you, Professor Mathur, for your next speech.
Hello. My name is Amit Mathur, and I'm a liver transplant surgeon here at Mayo Clinic in Arizona. I'd like to thank the Sri Lanka College of Oncologists for the opportunity to participate in the 2021 annual academic session. I'll briefly be presenting on controversies and challenges in management of HCC in the setting of liver transplantation. As everyone is aware, hepatocellular carcinoma is a significant global health problem with significantly high prevalence across the world, but particularly in Asia and Southeast Asia. There is a growing incidence globally, and this curve shows the growing incidence of the disease over the next 2 decades. And this is not just reflected in Western countries, but also across the world and we expect to see disease rising for years to come. When HCC is present, its management is variable, but guideline driven. The guidelines that support the management of hepatocellular carcinoma are, of course, those from the Barcelona Clinic Liver Cancer Staging System. While there are controversies in managing patients at each stage of HCC, from stage 0 all the way through stage D, we will focus on early and intermediate stage disease. Now, for early stage disease, the mainstay of treatment is surgical resection. However, this can only be applied in a certain select group of cases. It is the treatment of choice for non-cirrhotic patients, and it can be applied in select cirrhotic patients who have adequate hepatic reserve and an absent or minimal portal hypertension, or when the portal hypertension is clinically quiescent. For those with multifocal disease, or difficult tumor locations, inadequate hepatic reserve, or other challenges, liver transplant offers a safer option to patients and maximizes local regional control with total hepatectomy. So with that in mind, we will focus on 3 areas of controversy in the treatment of hepatocellular carcinoma in the setting of liver transplant. First, our discussion will be focused on downstaging. Can patients with intermediate stage disease be downstaged to a hepatocellular carcinoma burden within what we call Milan criteria to make them transplantable? Second, does the graft type for liver transplant in the setting of HCC matter? This is particularly relevant in areas of the world where both deceased donor and living donor liver transplant are available, such as what is available in Sri Lanka at this time. Third, we will discuss post-transplant care of the HCC patients, especially with regards to our approach to surveillance, controversies in how to survey patients, and what systems to use to justify the intervals of surveillance, as well as management of immunosuppression. The Italian group in Milan established the first criteria for liver transplant for HCC. In their initial series, published in 1996, they performed local regional therapy in 26 of 48 patients in their randomized controlled trial. The outcomes of liver transplant were excellent for these patients with small hepatocellular carcinomas, and their criteria and approach became the gold standard for the rest of the world. But the criteria didn't account for important factors. These factors were related to the explant pathology. For example, vascular invasion is a predictor of poor outcome after transplant, but it was not evaluated in that study. The tumor histology was not evaluated in that study. And based on these studies from other groups, there are many patients who are beyond Milan criteria who still did well with liver transplant. So was Milan criteria too conservative? Further, there was a only limited evaluation of local regional therapy transplant or local regional treatment effects in the transplant group in that study. And so it was relatively inadequately evaluated. So in terms of theory, why do we use local regional therapy prior to liver transplant? Well, it's really driven by the fact that tumors progress when they are untreated, and this rate of progression is difficult to predict and is probably driven by a variety of biological characteristics. Local regional therapy allows treatment of the primary tumor by an ablative or extirpative strategy, and it allows an observation of the tumor biology while liver transplant logistics can be arranged, whether that be for deceased donor liver transplant or for living donor transplant. Aside from the Mazzaferro trial, there really are no recent randomized controlled trials to justify local regional therapy use, but observational data and data from centers on waitlist dropout for HCC patients related to disease-specific and cancer-specific progression really do make the case that local regional therapy is effective. We also have supporting data from center-based studies and multi-center studies that demonstrate that there is actual imaging characteristic changes based on local regional therapy, based on LIRADS criteria. There is a significant percentage, up to 3 to 5% of cases, where patients will have a complete clinical response on imaging by LIRADS criteria after local regional therapy. And further, and probably most importantly, we do see eradication of tumor on explant pathology in tumors that were treated with local regional therapy after the liver transplant. It is important to know, and is an area of controversy, but it needs to be accepted, that based on the fact that we have such significant experiences in centers across the world with observational data on local regional therapy, it is unlikely at this point in time that there will be a randomized controlled trial looking at its to determine whether or not it is useful. The burden of evidence supports it. So when it comes to downstaging, multiple international studies have been performed to evaluate the efficacy of downstaging. And these are some of the studies that are noted here. Some are from Western countries, from the United States, and Europe, but also from Seoul, Korea. In these studies, there was a variety of downstaging criteria that were used, and a variety of downstaging therapies. However, the success rate was maximized around 65 to 70% of patients had a successful downstaging based on objective imaging criteria. When we look at the outcomes of the successful downstages, what we see is that if you compare downstage patients to Milan criteria patients, patients who were always in Milan criteria at the time of the diagnosis with hepatocellular carcinoma, you see that patients who were downstage had similar intention to treat survival, similar post-transplant survival, and similar recurrence-free probability. And this is based on the best data that we have available on the treatment of HCC and the downstaging of patients with intermediate disease. So what has that led to? Well, it has led to the expansion of HCC eligibility criteria beyond what was originally described in the Milan paper in 1996. The UCSF group has published criteria on what they use and has spread to many other centers for liver transplant eligibility for HCC. The Milan group has revised their criteria to an up to 7 protocol, and more recently, the Toronto group has been able to demonstrate that with the use of clinical and imaging criteria as well as biopsy data, they have been able to show similar oncologic outcomes for patients beyond Milan who are downstage to Milan criteria patients. And so in this context, local regional options seem to be effective in assuring that more intermediate stage patients can be treated effectively with liver transplant. Perhaps the most recent controversy And where we have really the least data on is in the use of immune therapy or checkpoint inhibitor therapy to downstage patients with HCC. So at this point in time, only multiple case reports are really the data that support using this and really have just demonstrated feasibility. While this is a promising area of treatment for patients with more advanced stages of disease, it is critical for all of us in the transplant and oncologic communities to assess the potential negative fallout of checkpoint inhibitors on organ function. What has been reported has been rejection, hepatic necrosis, and graft failure after checkpoint therapy. At this point in time, it's clear that we need more than just a few case reports and case series to demonstrate the feasibility and long-term durability of this treatment in the neoadjuvant setting. Because it is clear that PD-1 inhibitors can react against the graft, and without randomized controlled trials, we will be unable to answer this important question as to whether or not we can use this novel and impressively effective therapy for HCC in the neoadjuvant setting without causing long-term harm after transplant. So does downstaging work? Well, for the most part, based on local regional therapy data, we believe that success is reported in 65 to 70% of patients, and it may benefit patients in two ways. First, it limits progression of disease prior to liver transplant and allows patients to comfortably wait. However, if patients do progress after local regional therapy, what local regional therapy additionally does is help clinicians select patients for liver transplant with favorable biology that will optimize and ensure durable oncologic outcomes after liver transplant, which is an incredibly resource-intense and clinically intense therapy for any patient. There's not been a single modality that's been shown to be dominant for the use of local regional therapy, and decisions to use those are made in a multidisciplinary setting in best case scenarios and are driven by anatomic location, expertise, previous treatment, liver function, and a host of other factors. And again, immune checkpoint inhibitors as neoadjuvant therapy prior to liver transplant need to be evaluated further in rigorous clinical trials. The second controversy is related to graft type. So for liver transplant, we have multiple graft options here in the United States. The most common form of transplant for liver transplant in the United States is, of course, deceased donor liver transplant, with a small percentage of living donor liver transplant here in Western countries. However, in Asian countries, this is flipped, and in some parts of the world, deceased donor transplant isn't even a possibility. So graft selection for HCC patients has been previously controversial in areas where it is available where both entities are available. And so why is it controversial? Well, there have been previous studies that have demonstrated that after adjusting for the presence of vascular invasion, there is some data that indicates that living donor liver transplant actually has lower recurrence-free survival for HCC versus deceased donor liver transplant. And again, this is controversial because it is impossible for us to conduct a randomized controlled trial in this regard. There's no equipoise for for performing living donor or deceased donor transplant in most parts of the world, and it particularly to improve on the risk of disease-specific mortality without transplant. So in this context, it's important for us to understand from studies that do exist, what is the data on HCC behavior after transplant with each type of therapy. So with deceased donor liver transplant, the challenge, of course, is waiting time. HCC patients compete with non-HCC patients when a living donor is not available. And prioritization of HCC patients and the controversies therein could be the focus of an entire hour of lecture. But suffice to say, HCC patients in most parts of the world get lower priority than other patients who have advanced liver disease and cirrhosis. And in the absence of living donor liver transplant options, non-traditional liver allografts must be used to make sure that patients can get the therapy that they need. However, what we have found based on a few studies is that utilization of marginal liver transplant allografts, meaning those that are from donation after circulatory death donors, steatotic livers with macrosteatosis more than 30% on biopsy, or older age donors, or those with prolonged cold storage, are not associated with worse oncologic outcomes. As in other areas of oncology, tumor biology is king in HCC, and the predictors of recurrence when marginal livers are used are really related to the tumor itself, whether or not there is vascular invasion and if there is poor differentiation of the tumor. When we look at DCD specifically, we know that across multiple studies that DCD liver transplant has similar graft survival in HCC and non-HCC patients, and that when it comes to HCC specific outcomes, the DCD and DBD liver transplant recipients have demonstrate similar recurrence free survival and long-term survival as well. So this is important because if in the absence of a massive proliferation of live donor liver transplant in Western countries, DCD liver transplant will need to continue to be an important opportunity for HCC patients to receive a liver transplant, particularly when you weigh that risk against waitlist mortality without a transplant. The final controversy is on post-liver transplant care. And I will focus on two areas. First is surveillance for HCC recurrence. Does one size fit all? Do all HCC patients who have a liver transplant need the same surveillance? Inherently, you would think that a patient with more tumor burden might be at higher risk for recurrence. And this has been indeed correct and borne out in multiple studies. The retreat score is one of the best scoring systems that we have to assess the risk for HCC recurrence, and the retreat score can be used to drive surveillance strategies. And it is centered on the presence of three factors: the alpha fetoprotein level at the time of the liver transplant, the largest tumor size and number of viable tumors in the explant specimen, as well as the presence of microvascular invasion. As the score increases, the risk of tumor recurrence increases both at the 1-year time point and also in the 5-year time points. But one thing that is clear in the literature now is that better biomarkers are needed in HCC. But based on the information we have available, the retreat score does pretty well. When it comes to immune suppression management, the most liver transplant patients receive calcineurin inhibitor-based therapies. However, in patients who are at high risk for recurrence, there has been some interest in using mTOR inhibitors, which do have anti-tumor effects and also have a side benefit of reducing nephrotoxicity. mTOR inhibitors are drugs like sirolimus and everolimus, and based on systematic reviews, we see that there is some potential benefit for use of mTOR inhibitors. However, in randomized controlled trials that are small, there's been similar recurrence-free survivals. And so what most programs are moving towards is using explant pathology to drive immunosuppression decisions. At Mayo Clinic, we use mTOR inhibitors in patients' high retreat scores where we feel that the risk of recurrence is high to avail ourselves and our patients of whatever benefit they can get from the anti-tumor effects of the drug. So these are the three areas of controversy that we've discussed in HCC. And suffice to say, there are many other key areas of controversy. But for 2021, the key areas are centered on can we downstage into Milan? I believe we can, and still show durable, appropriate oncologic outcomes with liver transplant. Is there a controversy in graft selection? Well, I think for patients who have both options available, either option is better than not having a transplant at all. And then post-transplant surveillance needs to be driven by the clinical data from explant pathology, and that should help inform how frequently patients are surveyed, as well as what types of immunosuppression to use. In liver transplantation for HCC, there will continue to be controversies as there is a complex interplay of tumor biology, immune suppression, graft selection, and donor availability in a very, very aggressive and growing disease process of hepatocellular carcinoma. Once again, I'd like to thank the Sri Lanka College of Oncologists for allowing me to participate in this annual academic session. I wish that I could be with you in Colombo, but I hope that you enjoy the rest of the conference and look forward to seeing you all soon. If you do happen to be in the United States, please come visit us at Mayo Clinic at one of our 3 campuses across the country. This is my campus in Arizona, and I believe that you would love to see what we are doing here. Thank you.
Thank you very much, Professor Mathur, for that very interesting talk.
It's a great pleasure to invite our next speaker, Professor Jonathan B. Ashman. Professor Ashman is a radiation oncologist at Mayo Clinic, Arizona campus, where he specializes in caring for patients with sarcoma, gastrointestinal malignancies, and tumors of brain and spine. He is an assistant professor of radiation oncology at Mayo Clinic College of Medicine and Science. Professor Ashman is an associate editor for Advances in Radiation Oncology magazine also. Over to you, Professor Ashman.
Hi, I'm Dr. Jonathan Ashman. I'm a radiation oncologist at Mayo Clinic in Phoenix, Arizona, and it's a pleasure to join you today to talk about radiation therapy for hepatobiliary cancer, although I wish I was joining you in person. When thinking about radiation therapy for hepatobiliary cancers, we face both biologic and technical challenges. Hepatocellular carcinoma is a tumor that's sensitive to radiation. However, patients that are cirrhotic are at high risk for treatment-related toxicities, and both intrahepatic and extrahepatic recurrence is common. Cholangiocarcinoma requires higher doses of radiation, but again, recurrence, both intrahepatic and extrahepatic, is also common. And here, patients are at greater risk for biliary complications, both from tumor and treatment-related biliary obstruction. Technical challenges include the tolerance of the liver. Because the anatomy of the liver is organized in parallel, it's very dependent on the volume of liver exposed to or spared from radiation. And small volumes of liver can actually tolerate very high doses of radiation. But we also must keep in mind the tolerance of adjacent stomach and bowel, and the fact that we're trying to hit a target that's moving with respiration. I do believe we are seeing an increasing role for radiation therapy in the modern era in treatment for hepatobiliary cancers because of the developments of intensity modulated radiation therapy, image-guided radiotherapy, management of patient and tumor motion. And these have led to advances such as stereotactic body or stereotactic ablative radiation therapy and proton beam therapy, which we'll talk about. Stereotactic body radiotherapy, or otherwise known as stereotactic ablative radiotherapy, uses high dose per fraction over a relatively small number of fractions to achieve biologically ablative treatment. This requires high precision of dose to the target with very sharp dose gradients to protect normal tissue outside of the target. And this is facilitated by both modern hardware and software with sophisticated treatment planning algorithms, high output linear accelerators, and onboard real-time image guidance. Unlike X-rays that travel through and through the body, protons deliver a relatively small dose at shallower depths and then slow down as they travel deeper in the body. And depending on the energy of that particular proton, will deposit most of their energy over a very narrow range called the Bragg peak, and then stop, delivering no exit dose. Therefore, protons are a volume-sparing modality. You can see here that for both photons and protons, the conformality of the high-dose region around the target is excellent for both. However, photons deliver a much greater low-dose bath to the non-target liver than do protons. On the other hand, protons are much more sensitive to the respiratory motion of the liver, and therefore greater care must be taken in terms of managing motion for proton beam than for X-rays. And let's not forget that brachytherapy is also a proven treatment for hepatobiliary cancers, even in the era of sophisticated external beam treatment. Low dose rate and high dose rate brachytherapy can still be used effectively for these tumors. So when should we consider radiotherapy for cholangiocarcinoma? Well, for unresectable intrahepatic cholangiocarcinoma, as a postoperative treatment for extrahepatic cholangiocarcinoma and gallbladder cancer, and as pre-treatment for patients on their way to transplant for hilar cholangiocarcinoma. As a representative study of stereotactic ablative radiotherapy for cholangiocarcinoma, this is a recent and one of the larger multi-center retrospective analysis of 64 patients with 82 lesions treated with SABR, both for intrahepatic, perihilar, and even extrahepatic cholangiocarcinomas. Toxicity was quite low, with only 5% grade 3 GI bleeding. And you can see that local control and overall survival was correlated with higher dose treatment. And the conclusion was that SABR is an effective treatment for cholangiocarcinoma, and that higher doses correlated with both local control and overall survival. In the postoperative setting, we have evidence for chemoradiation for extrahepatic cholangiocarcinoma or gallbladder carcinoma from the prospective phase 2 SWOG SO809 trial. Patients with locally advanced disease, node-positive disease, or positive margins were treated with 4 cycles of gemcitabine and capecitabine, followed by standard fractionation, chemoradiation. This trial met its pre-specified endpoint for overall survival with a 2-year overall survival rate of 65%. Therefore, postoperative chemotherapy followed by chemoradiation should be standard of care for this population. Mayo Clinic in Minnesota pioneered the use of preoperative chemotherapy and radiation prior to liver transplant for unresectable perihilar cholangiocarcinoma. Patients do need to be highly selected for this treatment. Although tissue confirmation is not required, when it is obtained, percutaneous biopsies should not be used, but only transcatheter intrabiliary biopsy. In the absence of tissue confirmation, a malignant appearing stricture and an elevated CA99 is sufficient. Tumors should be less than 3 centimeters above the cystic duct with no evidence for regional lymph nodes or distant metastatic disease and no prior history of attempted biliary resection. Treatment prior to transplant includes external beam radiation therapy over 3 weeks, twice daily with concurrent capecitabine or 5-FU. This is followed by a boost, traditionally with low dose rate brachytherapy. Now, more recently in Minnesota, high dose rate brachytherapy in a single fraction is used. In Arizona, we have been boosting with external beam radiation. This is followed by maintenance capecitabine until the patient is able to proceed with transplant. Results from using this preoperative regimen followed by transplant have been excellent. This is a multi-institutional review with patients contributed from Mayo Clinic in Minnesota and several other high-volume institutions, showing that overall survival in all patients after transplant was excellent, with a 5-year 50% overall survival and more than 40% at 10 years. When we look at overall survival based on patients with either primary sclerosing cholangitis or no primary sclerosing cholangitis, we see that patients with PSC do exceptionally well, with a 5-year overall survival of over 70%. We have looked at our own experience at Mayo Clinic in Arizona using radiation for patients with hilar and extrahepatic cholangiocarcinoma, recently submitted for publication. We identified 65 patients. 20 patients underwent neoadjuvant chemoradiation followed by transplant. 16 patients were treated with radical surgery followed by adjuvant chemoradiation, and 29 patients were treated with definitive chemoradiation. You can see that the outcomes for patients who underwent the neoadjuvant chemoradiation followed by transplant protocol was excellent at approximately 60% long-term survival, which is equivalent to what has been shown from Mayo Clinic in Minnesota. Survival outcomes for patients who undergo surgery and postoperative chemoradiation are not as good, but still quite acceptable, with approximately 40% 5-year survival. Unfortunately, patients who undergo definitive chemoradiation still have suboptimal outcomes, with no patients alive at 5 years. For hepatocellular carcinoma, we can use radiation in both the unresectable and bridge to transplant scenario. One of the largest and earliest prospective trials supporting the use of SABR for hepatocellular carcinoma included 102 Child-Pugh A patients treated in 6 fractions. They demonstrated a high rate of local control and favorable overall survival, although there was some concern over toxicity, with a decline in Child-Pugh status seen in almost a third of the patients at 3 months. This table summarizes major series using SABR for HCC, consistently demonstrating a high rate of local control of around 90% at 1 year. However, toxicity was seen in these studies, with approximately 20% rate of grade 3 complications. There's also been significant evidence supporting the use of proton beam for hepatocellular carcinoma. This was one of the most significant trials, which is a multi-institutional trial from the United States for hepatocellular carcinoma and intrahepatic cholangiocarcinoma. 83 patients with good liver function and about half with no previous therapy were treated with a 15-fraction regimen. Toxicity was quite low, and local control at 2 years was very high at 94%. And for hepatocellular carcinoma, the local control was long-lasting, with some late failures in the cholangiocarcinoma. The conclusion was that proton beam was effective for both hepatocellular carcinoma and cholangiocarcinoma. A more recent study was published from Japan, again, prospective phase 2 trial, looking specifically at solitary, newly diagnosed, untreated hepatocellular carcinoma. Again, good liver function, treated with 10 or 22 fractions, and excellent local control and overall survival was seen, and very low toxicity, again suggesting that proton beam therapy is effective as primary treatment for hepatocellular carcinoma. At Mayo Clinic in Arizona, we have looked at our initial experience using the next generation of proton beam technology, which is pencil beam scanning. We retrospectively looked at 37 patients treated with either a 15-fraction regimen or our initial experience using 5-fraction stereotactic ablative radiation therapy with protons. We found an excellent 94% local control rate at 1 year and a favorable overall survival of 78% at 1 year. This treatment was generally well tolerated, with about 16% increase in Child-Pugh score of 2 in 3 months. Our conclusion was that pencil beam scanning proton beam is effective for hepatocellular carcinoma, and delivery with a 5-fraction proton saber regimen is promising. This table summarizes studies using proton beam for hepatocellular carcinoma. Local control is excellent, also in the 90 to 95% range, whereas toxicity is very low in the few percent range for grade 3 toxicity or increase in Child-Pugh score by 2. These early promising results encouraged us at Mayo Clinic in Arizona and in Minnesota to initiate a phase 2 single-arm trial of stereotactic body proton therapy with pencil beam scanning for patients with hepatocellular carcinoma. This trial is ongoing. In summary, modern techniques have expanded the role for radiation therapy in hepatobiliary cancers. Chemoradiotherapy prior to transplant is the most effective treatment available for unresectable perihilar cholangiocarcinoma. There is a growing body of retrospective and prospective evidence supporting efficacy of both stereotactic ablative radiation therapy and proton beam for hepatocellular carcinoma and cholangiocarcinoma. Future challenges include increasing access to modern radiation therapy, optimizing radiation techniques for a highly variable hepatobiliary patient population, and the selection of appropriate hepatobiliary patients for radiation therapy among the multiple options available. I want to thank the organizers for inviting me to speak and hope to see you in Arizona, or I hope to visit you in Sri Lanka soon.
Thank you, Professor Ashman, for that insightful presentation. Actually, Dr. Ashman is joining us live now. If you have any questions, he's more than happy to answer those questions. And you can also direct questions through our chat box. So there is a question in the chat box. I will start with that one. What was the dose constraint maintained to liver during SABR and proton therapy?
The most important dose constraint when you're doing SABR with photons is really mean liver dose. But for protons, it's the sparing of approximately 700 cc's of liver from somewhere around 15 to 20 gray. So it's really about how much liver can you spare from the high dose region. So it's very similar to thinking about as a surgeon when you're doing liver resection, you're thinking about a functional liver remnant, how much liver is left behind. And especially with protons, the idea is to make sure that you leave enough liver that is spared. And that constraint has to be tailored to the patient's underlying liver function. So if the patient is Child-Pugh class A, you have a bit more flexibility. Whereas if you're treating with a patient with Child-Pugh class B, B7 you can generally treat safely, but B8 or B9, you're going to have to be very careful with how much liver you spare. And Child-Pugh class C is generally very difficult to treat. We try not to treat those patients. The dose constraints are a little bit different for photon SABR, where it really is the mean dose that you're trying to minimize.
Okay, now it's open to the audience for the questions.
Thanks, Jonathan, for that excellent talk. And you said for cholangiocarcinoma, you do surgery and adjuvant chemoradiation, and the outcomes were moderate. And what was the selection criteria? Did you irradiate all patients, or did you have a criteria to offer adjuvant chemoradiation?
Adjuvant radiation for cholangiocarcinoma, yes. The main indication is positive margins. Positive lymph nodes are a softer call, but generally patients after radical surgery if they're able to undergo chemotherapy and then are doing well after chemotherapy, then we will discuss with them if they want to continue and sort of maximize local control. If it's positive margins, we definitely favor adjuvant radiation therapy and definitely positive margins and positive nodes. There's data from meta-analysis from Dr. Horgan from Canada that suggests those are the two strongest factors.
Thanks, Jonathan. And what did you consider as clear margin?
That's a good question. It's mainly tumor on ink. If it's less than 1 millimeter, that can also be considered a positive margin, but generally tumor on ink or positive bile duct margin. Most commonly, it's a positive cut margin at the liver.
Thanks, Jonathan. And also you said for transplant eligible patients that you all were continuing capecitabine. So do you give capecitabine maintenance for transplant ineligible patients?
Sorry, so the question was about capecitabine maintenance?
That's right. So you said you give capecitabine maintenance for transplant eligible patients after chemoradiotherapy?
That's correct, yes.
Yeah.
So the protocol is 3 weeks of chemoradiation twice a day, then followed by a boost, either with external beam for another few days or brachytherapy. And then we know that there is going to be a period of time where the patient will then be listed for transplant, but will have to wait for a liver to become available. Now, in some cases, that may be only a matter of a few weeks, but for other patients, it may be quite a bit of time. So that's where the maintenance capecitabine has become our standard. And that's been a part of the protocol for since around its inception to maintain these patients until they have a liver available.
Yeah, thanks. So the question is for transplant eligible patients, did you all still use capecitabine maintenance?
For transplant eligible patients, we use capecitabine with radiation and then as maintenance. I'm sorry if I'm not hearing the last part of your question.
If the patient was not eligible for transplant, did you all still use capecitabine maintenance?
Oh, sorry. If the patient is not eligible for transplant, if for any reason they drop out of the transplant protocol, we have data that was actually written up by my current partner, Dr. Seo, a couple of years ago, showed that they have very short survival. So usually it's no longer a matter of maintenance. They may need more aggressive chemotherapy. It's usually they drop out of transplant protocol because of progression of disease. Or part of the transplant protocol is a diagnostic laparoscopy where they may find node positive disease or peritoneal disease. So patients who start off as transplant candidates and then are not eligible for transplant for whatever reason, unfortunately, do very poorly.
Thank you. Thank you so much, Jonathan.
Professor Ashman, there's another question in the chat box. What is the method you are using to restrict movements in SBRT?
That's a great question. We look at every patient individually. For photon SBRT, if the motion is generally less than a centimeter, then we will often not do any motion management and use an ITV-based target. So that's expanding the target volume to account for that motion. If it is more than a centimeter, then my preferred technique is respiratory gating. So we track the breathing and the beam is turned on and off during the sort of the rest cycles of breathing, usually, and exhalation. Deep inspiration breath hold is another option. That is the preferred option for our proton beam because of the difference between proton and X-ray, gating doesn't work as well for our proton system. And so we will place fiducial markers. We try to place fiducial markers for all of our SBRT patients, whether it be protons or photons. And that allows us to do deep inspiration breath hold. For patients, especially with cirrhosis, sometimes their breathing can be quite irregular, and therefore respiratory gating is often very difficult. And breath hold may not be easy for them either, but breath hold may be the best way. So it really is an individualized technique. We try to do some abdominal compression with our setup, and that usually does help, but is often not enough.
Okay, thank you very much, Professor Ashman, for joining us with in this time of the day. So thank you so much.
Oh, my pleasure. Wonderful to see everyone.
It gives me great pleasure in inviting our final speaker of our first symposium, Professor Ramesh Ramanathan. Professor Ramanathan is a medical oncologist and executive medical director, Division of Global Scientific Affairs, Merck Research Labs in the USA. Dr. Ramanathan has research interest in GI, GU cancers and also new drug development. In the last 20 years, Dr. Ramanathan has been involved in the development of several new drugs, including PARP inhibitors and also liposomal formulations, among many others. And he has also had a pivotal role in the development and approval of oxaliplatin and nab-paclitaxel. Dr. Ramanathan has served on national professional committees and is an editorial board member for clinical cancer research, cancer chemotherapy and pharmacology, gastrointestinal cancer research, and is an ad hoc reviewer for several other journals. Over to you, Professor Ramanathan.
Thank you for the invitation, and I'm happy to be participate by Zoom. I'm sorry I could not be there in person, but I hope to do so in the subsequent years at your meeting. My name is Ramesh Ramanathan. I'm a medical oncologist. Previously, I was at the Mayo Clinic in Arizona campus and currently at MSD, which is Merck Sharp and Dome, or known as Merck in the US. My topic is targeting molecular subsets in bile duct cancer, and I think it's an appropriate and interesting topic because just recently there have been a number of new developments. So bile duct cancer, I'm going to go over this very quickly. It's an uncommon cancer, but incidence does seem to be increasing, and certain parts of the globe have very different incidences, and with gallbladder cancer, it's highest in South America for some reason. And it's the disease has poor prognosis. 5-year survival is poor. Most cancers are diagnosed at a late stage. And this shows the epidemiology and natural history of gallbladder cancer, intrahepatic cholangiocarcinoma, and extrahepatic cholangiocarcinoma. And this is just for reference. And it's increasingly important because these 3 subsets have different outcomes and different treatments available as well. So for metastatic disease, the standard of care has been gemcitabine and cisplatin since 2010, based on this landmark study, which established a median survival of about 12 months for combination therapy. And a large number of studies were presented in the last 10 years, which have been negative, and no advances have been made till about last week when clinical trial with the PD-L1 inhibitor durvalumab added to frontline gemcitabine and cisplatin extended survival over chemotherapy alone. This was a press release. It's called the Topaz-1 trial, 685 patients, and this will be presented in the next 1 or 2 months at one of the plenary sessions. So this will be a major advance. It did increase survival. So durvalumab is a PD-L1 inhibitor. It is a targeted therapy. We don't know yet whether PD-L1 positivity will be important. It usually is. Patients, tumors which overexpress PD-L1 generally do better with these agents. And of interest, Keynote 966, this is a study from MSD. This is a large study with about 1,000 patients. This has completed accrual, and this will have interim analysis in the next few months. So I think this also will be an important study because stratification is by PD-L1 status, CPS scores, 1% versus 10% versus none. So right now, we don't know whether durvalumab will be approved for all comers, irrespective of PD-L1 assay, or it's going to be on PD-L1 status. And I'm sure we are all eagerly awaiting the results. So the other targeted therapy, which is approved for any MSI high tumor, is pembrolizumab. This was based on Keynote 016. And as you can see from this slide, small numbers of patients with various GI tumors were treated. And with cholangiocarcinoma, just a small number, 11 patients. These patients do respond well to checkpoint inhibitors, 27% response. So in the US, pembrolizumab has a tumor agnostic indication. So any tumor that overexpresses MSI high, pembrolizumab can be used. But as you can see, it's based on response rate. We don't have survival data in biliary cancer being such a rare tumor. So increasingly, biliary cancers are of interest because of a number of actionable pathways. And based on next generation sequencing, we can see that various amplifications and mutations are found. It's important to keep in mind, it really has a difference whether it's intrahepatic, extrahepatic, or gallbladder. So for HER2 new amplifications, it's more common in gallbladder cancer. When you look at FGFR fusions, almost always it's seen in intrahepatic cholangiocarcinoma and occasionally in gallbladder. And IDH1, it's basically just in intrahepatic cholangiocarcinoma. You really don't see it in the other two subsets. And this is important because we have targeted agents which have been FDA approved recently. So the first FGFR inhibitor that was approved is pemigatinib. And this was called the FIGHT 202 trial. And in this patients with FGFR fusion rearrangements and other less common FGFR alterations, 20 patients, and patients without any alterations, 20, were treated with oral pemigatinib. So the main study was cohort A, 100 patients, and the response rate was a primary endpoint. So basically, in cohort A, you can see the response rate is about 35% with a few complete responses, and median duration of response was pretty long, 7.5 months. So this was a positive outcome, and based on this, FDA approved pemigatinib for bile duct cancer with these FGFR rearrangements. So another FGFR inhibitor was recently presented at a meeting, and in 108 patients, the other FGFR inhibitor is infigratinib, and the overall response rate was 23%. This was presented recently and also got FDA approval recently. So we have two FGFR inhibitors, and you have to keep in mind, this is for FGFR fusion or rearrangement, not overexpression by immunohistochemistry. You need fusion or rearrangement, otherwise these drugs don't work. So IDH alterations are also seen in intrahepatic cholangiocarcinoma. It's really not seen in the other two subtypes, and it's an interesting mutation, and the mechanism of action is shown on this slide. And we do have an IDH1 inhibitor, which is ivosidenib, and this was a randomized phase 2 study in the second-line setting, and crossover was allowed. So this is another oral drug, and the results were that the primary endpoint was PFS, and that was met 2.7 versus 1.4 months, statistically significant. And based on this, it got FDA approval. The median survival was 10.3 for ivosidenib versus 7.5 months for the placebo group. It did not reach statistical significance. Numerically, it is increased, and the effect likely was minimized because about 40% of patients did cross over. So this is also FDA approved. The other alterations that we see are BRAF mutations, which are seen in around 5%, and it's spread over intrahepatic, bile, and extrahepatic, as well as gallbladder cancer. And in this study, patients with biliary cancers were treated with combination dabrafenib and trametinib, and the main endpoint was response rate. And you can see the response rate was 50%. So that's pretty robust. We don't have a median survival was 14 months. So look pretty impressive. But this was not meant for registration. So this is not FDA approved. And then we have HER2 amplification or overexpression. So in this study, patients were treated with pertuzumab and trastuzumab, which is what you would use in breast cancer. 39 patients, response rate was 23%. Looks active. So the eligibility for this study was HER2 amplification or IHC 3+. IHC 1+ or 2+ has to be confirmed by amplification. So a reasonable response rate, but again, not meant for FDA registration. So it's not an approved, FDA approved regimen, but it's widely available in clinical practice, at least in the US. So in summary, the first line therapy for good performance status as of today is cisplatin and gemcitabine. We expect that durvalumab plus gemcitabine cisplatin will be approved in the US for first line for good performance status very soon. It may be in early 2022. We don't know whether it's going to be for all comers, so FDA is going to restrict it to PD-L1 expression. The follow-up study is pembrolizumab plus GemCis. That also will be available soon, and that is stratified. Patients are stratified by PD-L1 expression, so that would be an important study to consider. So if your patient progresses on first-line chemotherapy and a patient has a good performance status, next generation assays, molecular assays will certainly be necessary. MSI high in bile duct cancers, it's a very low percentage, maybe 1 to 2%, but pembrolizumab would be an option. If the patient has FGFR2 fusion or rearrangement, pemigatinib and infigratinib are available, at least in the US, and for IDH1, it's ivosidenib. Not FDA approved, but could be considered for HER2 new amplification is dual HER2 inhibitor therapy, and for BRAF mutations, dabrafenib plus trametinib. So in summary, there's a lot of interest in bile duct cancer. We have found that bile duct cancer clinical trials now accrue extremely quickly because of the heightened interest of molecular subsets. And hopefully there are a number of other new drugs in clinical trials which will help extend life of patients. So thank you for your attention. I'm sorry I can't answer any questions, but I will provide my email. If you have any questions, please email me. Thank you very much.
Thank you very much, Professor Ramanathan. That concludes our symposium on hepatobiliary cancers.
Let's move on to the first plenary of the day. Let me have the honor of inviting Dr. Lanka Jayasuriya Disanayake to the stage. Dr. Lanka Jayasuriya Disanayake is the chairperson of Indira Cancer Trust, an organization set up to support patients with cancer and their families, and currently operating 23 projects, including launching Sri Lanka's first cancer helpline. Dr. Lanka Jayasuriya Disanayake is also the director of Surya Foundation, registered charity in Sri Lanka operational since 1992. The aim of Surya Foundation is to support social integration process of country through various programs targeting the underprivileged of the society with equal opportunities of learning, employment, and healthcare, amongst others, and have supported the efforts of foster a shared national vision for the society for all, founded on Sri Lankan values and belongings and equity. It is a pre-recorded lecture, so we will get on with the lecture.
Good morning. At the outset, we would like to thank the organizers of the annual academic session of the Sri Lanka College of Oncologists for giving Indira Cancer Trust this time to speak on the role of civil society in improving cancer outcomes. We have always been very aware of the needs of patients, and the programs that we do at the Indira Cancer Trust is centered around this need. So our motto is supporting the fighters, admiring the survivors, honoring the taken, and never ever allowing anyone to give up hope. The beginning of the trust also rests on a story of a mother's love for her unborn child, a story of courage and determination. A young mother who was diagnosed with terminal cancer when she was 28 weeks pregnancy, and the way she carried on with the pregnancy, delivered a baby boy, and 1 year later, she passed away from cancer, still with a beautiful smile on her face. This prompted the family to initiate an organization which today has grown into an organization that supports many patients and their families. This is her story.
विशेषी जीवित अवस्था कवदावन नतुन लोटन विशेषी जीवित विशेषी अम्मिकता देगी सुविशेषी तारुणे इंपसु जीवित गेन उतरा हेल्न कुतुहले सौंदर्य सुविशेषी तारुणे ඊළඟ මොහොතේ තවත් එක සාමාන්‍ය ගැහැණියක් විතරක්ම වෙන්නේ හිතු සුවිශේෂී පිරිතක් අනපේක්ෂිතම මොහොතක පිළිකාවට එරෙහි සුවිශේෂී සටන්කාරිනියක් කප්පරත් දුක්විඳ ජීවිතයෙන් ජීවිතයක් ඉපැද්දූ සුවිශේෂී මවක් අවසානයේදී දරුවෙක් වෙනුවෙන් ජීවිතය පරිත්‍යාග කළ පරිත්‍යාගශීලීත්වයේ सुविशेषी मुहूर्तक लोटानो एवरीथिंग एक एटानो ए सहायक बेनामी सत्कम जीवत करवन सहायक सिद्धि कने धैर्य आय उपद्रवकन सहायक बैठती नेगेटिव धरण उत्साहයට सहायक अंतिम बलापुरुत्वन अत्नहरें सहायक මුළු මහත් රටක ජනතාවට පිළිකාවට එරෙහි සටනට සහායක් ඉන්දිරා සහාය පිළිකාවට එරෙහි සටනට සහාය
So the work of the trust began in 2016, and today, 5 years later, we were registered as a non-governmental organization in 2016, and this year, the process of being registered as a charity was initiated, and now in the last stages, and this is in Parliament. Our programs have always rested on the national program, and our support as an organization rests on the gaps that are there and also the needs that are highlighted through the national program. So our strategic priorities are in line with the national effort for cancer control, and it rests on prevention, early detection, diagnosis, palliative care, and most importantly, quality of life. When you talk of the role of civil society, and I think the most important thing as civil society is to look at the overall national program, which basically is initiated after much dialogue and in line with WHO priorities as well, and look at the strengths of the civil society, and wherever possible, look at the gaps and support those gaps or support the national efforts to enhance their programming levels. So this is what we have done, and we have looked at all the programs that we do are in line with this concept. We started with the helpline, and today we have over 20 programs that support patients, their families, in various ways. And also, the work of the trust rests on volunteers, and we have over 600 volunteers. And we also have a small team of staff who help in everything that we do. Our strategic partnerships, which have been initiated from the beginning, has always helped us to implement the programs in support of patients and their families. Our work always falls in line with the government's effort, the Ministry of Health. We also look at the professional bodies for help and guidance on implementation and also priorities. We have a range of partners for implementation, including the corporates, other NGOs, PR companies, and media partners. Our main effort in the work that we do is that we review all the work, even of other organizations, and we aim not to duplicate or replicate what is already there, but to fill up the gaps whenever possible. The helpline, this is the first program that we started in 2016, and this is Sri Lanka's first helpline for cancer. We had a physical helpline up until the COVID situation, and now we have moved on to a mobile platform. We get about 30 phone calls every day, ranging from information up to various requests. And this is the nodal point to obtain services and information from Indira Cancer Trust. We also, there are many calls also for about volunteering. And we again, we encourage volunteers, we register them, and we also request them to come and support us in implementation process. When we look at the cancer outcomes and improving cancer outcomes in patients and families, one of the main things that we see is that cancer, the disease, the word in itself causes fear. And also it basically causes a major issue in terms of their finances and livelihood. Many of the patients that we see have been compelled to leave the work that they have done. Or if it is a family member, they have been compelled to stop that work because they have to accompany the patient to the hospital, stay with them during their inpatient days. So these are issues which causes major financial constraints on the family. And this is where we come in as an organization. We have a livelihood development program, which consists of financial aid. We have a platform for sale called Viriyahala. And we also provide training on vocations that are basically things that vocations that patients could do at home. In the livelihood development program, it's a financial grant program where we give 5,000 rupees for a period of 6 months. But it's not only the money, because we allocate a counselor for each patient who contacts the patient on a monthly basis, reviews their work, see how they are doing, builds up a relationship so that after 6 months, we get a success story of financial independence for them. And we are so happy that to date, over 250 families have been supported like this and are financially viable. Viriyahala is a concept that was initiated by the counseling unit of the Apeksha Hospital, Maharagama. This is a platform for sale of goods done by patients with cancer. Unfortunately, due to COVID, the physical presence of these sales platforms are limited, but we do go in for exhibitions and as and when the invitations are there with the patient to highlight the Viriyahala products. We have also moved into branding of TLC, which is the breast cancer awareness program that we run, and everything is branded pink. And these are products that are made by Indira Cancer Trust and also other partners in support of breast cancer and highlighting the need for self-breast examination through the TLC range. Now, when we talk of improving cancer outcomes, the quality of life is extremely important. And one of the things we find with breast cancer patients is the trauma they go through after they lose a breast. Again, something to think about, because in this era, there are patients who opt for reconstruction, but there's also a proportion of patients who don't undergo this. And this is where we come in. We have a customized bra according to the size, and we give it out free of charge. Now, we're in discussion with the College of Surgeons also to discuss a mechanism of issuing these breast prostheses soon after they have surgery from the place of surgery itself, so that they don't have to come all the way to Indira Cancer Trust, which is in Maharagama, to get this. So this is under discussion, and hopefully a national program should be started at least the beginning of next year. Sponsor a child program. And I think, again, when you talk of improving cancer outcomes in a patient, the children in that family poses a great concern for the parent. Majority of the time, due to financial constraints, due to many other constraints, the children of cancer patients tend to they face a lot of hardships in terms of continuing their education. So this program is a special program. It's not only money that we look at a foster or we look at a family to support this patient and the child who is a child of a cancer patient. It's basically a small amount of 1,000 rupees a month that goes to the child's account. But in addition to that, the most important thing is that a relationship is built up with the family, with the child. A phone call goes out from the family who supports the child. And in addition, we do have a set of volunteers as well who give a phone call to that family every month to see whether there are needs. And if there are needs, we intervene and we help. And I must thank some of the sponsors. We do have about 285 children under this program at the moment. And we are still waiting for more children, because we have a waiting list of 50 more donors who are waiting for children. So this is something that even some people like to do, to support a child and also to look into their well-being on a monthly basis. And I must thank some of the sponsors who have gone out of their way to help, especially during COVID situations, sending them dry rations, helping them financially. And also some sponsors have gone above and beyond and have even helped with accommodation, building houses, building toilets. So a big thank you to all of them for the support extended, which is much appreciated by the patients. Counseling support is again something that we can provide. We have a volunteer pool of counselors. We do it on request because there's already a system within the Apeksha hospital for counseling, so we don't want to duplicate any of that effort. But we do have telephone counseling also available through the helpline. So this is supported by the pool of volunteers. Now, breast cancer awareness program. This is a recent program which was started. Actually, this was started last year in 2020 for the Breast Cancer Awareness Month. And because we see so many patients walking in to the trust, and majority of the patients are breast cancer patients. And when we see them, we feel very sad because they are at either the last stages, they have neglected themselves, and then necessitating extensive treatment, including surgeries. And we always think, why didn't you do this earlier? Why didn't you go to and see a physician before all this, where things need not have been this complicated? So the TLC campaign is a very scientific campaign which has been done globally. It was initiated in UK by Breast Cancer UK, and this campaign has been replicated in many countries. And they have shown, scientific research has shown that this campaign has managed to initiate a behavioral change in that every woman over 20 years is supposed to do a self-breast examination on a monthly basis. So this is a behavioral change that we are looking for. And we are also very fortunate that Mr. Roshan Mahanama, former Sri Lankan cricket captain, as well as the ICC match referee, is supporting this effort through his own campaign of We Wear Pink on Wednesdays. This is a campaign that he started many years ago, even before we started our TLC campaign. And this is a best way of taking the message of breast cancer awareness through TLC, not throughout the year. So we don't keep it just for October. It needs to be a message that is consistent and continuous throughout the year. Simple message of requesting all women above the age of 20 years to examine themselves. We promote volunteers, and we are also very proud of our young volunteers, the junior arm of our volunteer teams, where we start a leadership program with them. And as part of their volunteering journey, we initiated the Stand by a Child program. So a young volunteer is someone above the age of 13 years up until 21. So they get linked up with a child with cancer. And these volunteers help them by being a friend, a tutor. They support their education, they support livelihood. They help them to draw the services from Indira Cancer Trust. And also above and beyond everything is that they are their friend and they give a monthly call, they look at their well-being. So that again is a beautiful program and much appreciated by not only the child, but also the family. The Children's Birthday Program, again, a very simple program, but brings a lot of smiles onto the faces of the children and the family members. And this in turn is definitely something that improves cancer outcomes. So 2 volunteers every day visit the ward. And then we look at children who have birthdays, we give them gifts. But because of the COVID, we have not been able to do that. But still, we do get consultants call us. They tell us that a child on their ward has a birthday and we send a gift. Or the children themselves, when they are discharged or after a clinic, walk in to our office to get that gift. And the smile that they give us and the thoughtfulness that comes into the parents' faces. They say, you remembered my child's birthday. So these are little words that goes a long way. And again, shows that one cares. So a beautiful, simple program that brings a smile on many faces. COVID situation in Sri Lanka and worldwide as well changed the whole setup of our thinking, our programming, and the needs of the patients and their families. And we were inundated with requests, especially from the Sponsor a Child program and also Stand by a Child program, asking for devices, because many of the schools had started online education and there was a problem with getting the online devices. So many of our donors and our sponsors have handed over their respective child or donated tabs, smartphones. We've given about over 100 phones and tabs to children of cancer patients through this program. Again, COVID changed the landscape of the needs of the patients. Many patients used to walk into our office saying they needed something to, they didn't have anything to eat, they wanted some dry rations. So this was again a program which was accelerated during the time of COVID and which we continue to do. So we give a pack of dry rations worth 3,000 rupees. And during the COVID, also there were hampers, food hampers that were given by donors who were sent directly to the children that they supported. Relaxation programs were something that we initiated some time back at the Apeksha Hospital program, a beautiful program where art therapy, yoga therapy, and music therapy was done on a regular basis. This was done together with the counseling section of the Apeksha Hospital Maharagama, where art therapy was done on a Monday, yoga on a Wednesday, and music therapy on a Saturday. So it was done in groups, also individual ones were done. There's the feedback from the patients, the family members were amazing. But again, due to COVID, this had to stop. Art and craft camps were conducted. Again, these are activities that improves cancer outcomes in patients. This is done on a monthly basis at the Apeksha Hospital Maharagama. Again, something different because we used to have a themed month and according to the theme, we used to do the session. In addition to those major services, we also see many patients walking into the office requesting for other services. Now, things like transport allowed. Now, with COVID, the transport cost has gone up. They had to pay for 2 seats instead of 1. So then public transport was not working. So whatever how we help transport is patients come in and we reimburse their travel costs on public transport. We also help them with medication. But again, medication support is limited up to 20,000 per patient, and we are unable to go beyond that. Investigations. We actually do regular blood investigations on children. Before they start their treatment, we do the genetic profile, we do various tests from the private sector. Nutrition support is provided. Any support that is needed, we immediately give them. And things even like funeral support. So sometimes families are in so much of difficulties that they are unable to even conduct their own child's funerals or the family members' funerals. So we help them out with that. Either the body is sent to their home place or we help them to conduct the funeral in Maharagama itself. I mean, other requests for equipment like diapers, wheelchairs also are entertained. And everything is done in a very transparent manner. When a request is sent, as a generic request form, once that is sent to us, then immediately we provide the necessary services to the patient and their family members. I think hair and wig donation program, a much talked about program in Sri Lanka, because actually this is the world's first program for continuous hair and wig donation. And so many stories are here in this program. This was started on the 17th of July. We had a collaboration with the leading salons, Ramani Fernando Salon. So they used to cut the hair, they used to style the patient's hair, and then all the hair that was cut was sent back to us. So we've had about over 120,000 people donated their hair, and that came up to about 14,000 kilos. So that was the beginning. And we've had many camps, so still the demand for hair donation is there, and then people want to donate. So it's amazing to see the response of the general public to the calling of hair donation. And from this hair, we make customized wigs. Now, wigs in itself are basically, these are natural human hair wigs, which are customized. So we get a patient's photo, we do it exactly the same way that they had the hair. So you won't feel a difference at all. This is something that we have seen, just showing you just one story of a lady who came to us. And one of the main things that we faced was the increasing demand of wigs and also the cost of the production. So this we had to do something, and this again is something that we have looked into, and the issues that are faced by patients. I will be very common, all of you are aware of all this, the stigma, how the families break down, how the children don't go to the mother. So all this is there, and we see it on a regular basis. And we are so happy that we've initiated this national campaign called Sunduru Riyavanti with the support of the Lions Club of Aluttama Benthota and Galkissa, and also Kumarika from Hemas. And this is a national campaign. This was launched on the 5th of October. And basically, in this program, what happens is when a patient is starting on chemotherapy, or if the patient needs a wig, if they have lost their hair, or if they're beginning to lose their hair, they can actually get a wig from the same place as the treatment site. So again, we're very thankful to the Sri Lanka College of Oncologists, where we have Indira Cancer Trust. We signed the MOU on the 19th of September to facilitate this process of wig donation at the selected hospitals. Now, these hospitals out of the centers were chosen because these hospitals have the highest number of patient loads in terms of new diagnosis. And what we plan to do is basically to provide 500 wigs to these centers every month, and then we replenish the remaining, so that actually it's about 6,000 wigs a year will be produced. Now, these are the first top 10. And after that, we are hoping to do a nationwide program, and we will definitely include the remaining ones as well. When discussing, I think this is the final project I would like to discuss in terms of improving cancer outcomes. When we talk of pediatric cancers, much has been done in Sri Lanka, and pediatric palliative care. again is at the infancy, but there's a lot of emphasis and a lot of importance placed in this. And Indira Cancer Trust is really proud to start this project, Suvarana, which is a place for healing. This was started in February 2021. It's located in the land just next to the Apeksha Hospital, Maharagam. It's actually walking distance from there. It's a 6-story building. And so what we are looking at now is the ground floor, the administrative floor, where the kitchen, the dining room are there. The whole building has 32 individual suites for the children and also their family members. It will also house the Indira Cancer Trust office, and therefore the daily work that the trust does in supporting patients and the families will continue to happen from this site. The work here, basically the 32 roomed ones, this is the Indira Cancer Trust administrative floor. It will have all the facilities, and also it will have the newly established wig production unit. Because earlier the wig production was done by hand and now it's done by machine. Now this is basically what a room would look like. It's like we had the rooms to be very airy. It needs to have a very calm and serene environment where the family and the child could spend a lot of quality time together. So all the facilities are there, the bathrooms are there, the attached bathrooms are there in each room with disability access. Each room also has a balcony, which has a lot of greenery and a soothing view. So there will be 4 floors of rooms. Each floor will have 8 bedrooms, family suites. And some of the rooms will also have movable walls, so that if large numbers of family come, it can be accommodated. This is the rooftop, the area where many activities can happen. Because this place, Suvarana, is not only it's a place for healing. So other than the structure that is there, there will be many programs for spiritual development, for physical psychosocial well-being. There will be many programs like art therapy, yoga therapy, music therapy. So all that will happen on the rooftop, which is seen here. And this will be the first pediatric palliative care in Sri Lanka. And we thank each and every one members who are involved in this project. And we hope to open the doors in February 2023. So our trust, I think the whole purpose of this discussion today is improving cancer outcomes. So our role as the civil society organization has always centered around patients. And again, our motto has always been this. And the support that we give is basically supported by our team of volunteers. So our volunteers in the heart of our organization, and everything we do is actually supported by a very small team of staff and a small team of volunteers. And the support we get from the large pool of volunteers is always so welcome. But unfortunately, COVID has not allowed us to have the bigger programs we do with the larger portion of the volunteers. but we also have converted our volunteering onto virtual volunteering. So there are over 100 volunteers at the moment who are very active and supporting the current programs of the Indira Cancer Trust. I just want to end with this quote, which we have been repeatedly using. And this is something where we emphasize, all the time, the trust, the work of the trust is centers around the patients. So too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of sharing, all of which have the potential to turn a life around. I think improving cancer outcome is something that all of us can do. And as a civil society, we feel very privileged to be in this position to support these patients at a difficult time in their lives and to improve and support them so that their cancer outcomes and their lives are enriched. So thank you so much for the time given. And again, I'd like to thank the organizers. And I would like to end by please asking you to look at our Facebook, our Instagram profile. We keep up to date on everything we do, and the support and encouragement that is given by the College of Oncologists, the teams there, the consultants, is greatly appreciated. And we thank all of you for your great service towards the patients with cancer. Thank you so much.
Thank you very much, Dr. Lanka Jayasuri Dissanayake, for that very interesting thoughts. And thank you for fulfilling the vacuum of social care for the poor cancer patients. So I would like to invite Dr. A.J. Hilmi, President, Sri Lanka College of Oncologists, to present a token of appreciation to Dr. Lanka Jayasuri Dissanayake.
I think there are some questions from Jacinta. Jacinta, there are questions from the audience.
Okay. Sorry for that. We welcome the questions from the audience as well.
My question is, we understand there are other non-government organizations who are trying hard, but we can see your organization, the Indira Cancer Trust, is well organized, very transparent. Is there any way that you have, you all thought of joining the other organizations to like to have one umbrella in Sri Lanka to uplift the quality of life?
Thank you so much, Dr. Sachini. Actually, this was something that the Ministry of Health, the National Cancer Control Program started, getting all the civil society organizations under one umbrella, which I think makes a lot of sense. So what we do on an individual level is we reach out to the different organizations. And actually next week, there is a mission coming from Geneva, where Colombo has also been chosen as a city for cancer control. So in that as well, we've invited all the other civil society organizations who are working in this area. And in addition, we have also with the Sri Lanka Cancer Society, which is the oldest non-governmental organization working in Sri Lanka, we've signed a MOU for breast cancer awareness. So we as an individual organization are reaching out. And one of the main things is I think we should not be duplicating each other's things. So what we do is we connect with them. And if there are expert areas, we would then channel the patients there. But it needs to be done on a more formal level. And I think for that, Sri Lanka Cancer Society, we support Sri Lanka Cancer Society in doing that effort. And I think ministry is also doing that. So we'll support them to get them under one umbrella.
Are there any more questions?
Dr. Lanka, this is a suggestion rather than a question. I'm one of the hemato-oncologists, and hemato-oncology patients do need this genetic testing, which is not available in the government sector. So what we usually now do is either asking the patient to get them from either a different country or private sector, or else we get the support of individual donors or some NGOs. So if you can start a project, that would be really great and helpful for our patients to do these genetic tests, which are the dire need for our patients in the management of hematological cancers, the conditions. So that would be a great thing if you can make an initiative on that.
Like actually, at the moment, we do genetic tests, but we have restricted it to pediatric cancer patients. And we have formed a MOU with Lanka hospitals. So we get the test at a lower rate. So if it is 20,000, we get it at about 15,000. So we have, but definitely we'll look into it because we do understand the need for it. But if you feel that the patient is quite poor and they are not able to support, please feel free to send them, because we do on individual basis, although our policy is only supporting pediatric for genetic tests, we do look at occasions and then we try and support others as well who are in dire need of it. So on a policy level to support I think the cost will be a bit more, but it's something we will definitely look at in the future.
Yeah, probably like, restricted to young patients probably. Yeah. And don't forget the adults. Not only the pediatric patients, don't forget the adults.
Definitely.
Thank you.
We get requests for BRCA gene and also that's a bit, I mean, it's about 50 to 60,000. So as the pediatric ones are cheaper. So yeah, definitely. I think if there is some criteria and then we should be able to, also, I think, if the transparency and if there's a system in place, I think getting people to support is also not an issue. So we do have a system in place. So it's something we'll definitely look at.
And this is just a small comment. Actually, we are very thankful to you to do this sort of well-organized activity on memory of your sister. And otherwise, because you are really helping for unfortunate and unaffordable patients who have no other help. Actually, I would say your sister Indra is still living with us. Thank you.
Thank you so much, actually. Thanks, Dr. Lanka, for that inspiring and heart-touching talk. Just one question. Are there Tamil-speaking counselors in your organization? Yes, we have two. We have 21 counselors, but we have two who are Tamil-speaking at the moment. But we do need a bit more. But from the requests we take, we don't want to duplicate the system. So there is a system at Apeksha. But the requests for Tamil-speaking counselors have also been low. So we will be contacting you also. Okay. Thank you.
So due to the time limitation, we will stop there. So I would like to ask, invite Dr. AJ Hilmi to present a token of appreciation to Dr. Lanka Jayasuri Dissanayake.
Ladies and gentlemen, let us now go for a short break before the next symposium to refresh ourselves. Let me take this opportunity to invite you all to experience and explore our virtual platform, which contains 6 teaching capsules on a wide array of topics in oncology. These teaching capsules are available on demand throughout the sessions. We will be back in 10 minutes. Please take your seats by then.
And also, you may visit our sponsor stalls in Sponsors Lounge just outside the conference hall. And those who are joining us on virtually can click the icon Sponsor Lounge and visit our sponsors. Thank you so much. Yeah, please be seated at 11:30. It's already 11:30. Please be seated in 10 minutes time. Please be seated at 11:30 for the beginning of the next symposium. Okay.
All right. Oh, oh. 네. Let us now commence the second symposium for the day. It is on management of retroperitoneal sarcomas. Our expert panel consists of 4 members from the UK as well as 1 member from the local faculty. The first speaker is Mr. Dirk Strauss. He is a consultant surgical oncologist and general surgeon in the sarcoma unit and skin unit at the Royal Marsden Hospital, London, UK. He joined the Royal Marsden Sarcoma and Melanoma Unit in 2008. Before being appointed at the Royal Marsden, he trained as a general surgeon and underwent further specialist training in the upper GI surgery and surgical oncology soft tissue sarcomas at the Royal Marsden. He has a special interest in surgery for retroperitoneal and intra-abdominal sarcomas, as well as limb and trunk sarcomas. Mr. Strauss is the national coordinator for the EORTC STRAS-2 study and participates actively in clinical trials within the UK and Europe, and has a principal investigator role as well as sub-investigator roles within the sarcoma unit. Over to you, Mr. Strauss.
Thank you very much for the organizer invitation to talk today at your annual academic session on the role of the surgeon in the management of retroperitoneal sarcomas. My name is Dirk Strauss. I'm a surgical oncologist at the Royal Marsden Hospital in London. In the next 15 minutes, I would like to talk about the general approach to retroperitoneal sarcomas, the role of a preoperative core needle biopsy, and then how do we optimize oncological outcomes, specifically looking at surgical planning and the optimal surgery, and what is the role of high-volume specialist centers in the management of retroperitoneal sarcomas. It's important to remember that there are more than 60 different subtypes of soft tissue sarcomas that occur in the body, but within the retroperitoneum, there are 5 main histological subtypes that accounts for more than 90% of tumors. And these are the liposarcomas, leiomyosarcomas, solitary fibrous tumor, and malignant peripheral nerve sheath tumors, although there are a host of other types as well that can occur. Tumor biology and the completeness of surgical resection are 2 of the most important factors determining outcome when treating retroperitoneal sarcomas. The tumor biology, determined by the grade and the histological type, remains outside the control of the surgeon. However, surgical margins and completeness of resection is within the control of the surgeon and has a major impact on patient outcome. It is important to remember that retroperitoneal sarcomas is not a single disease. This is a group of heterogeneous neoplasms that can occur in different places in the abdomen and can affect different organs and structures. And the biological behavior, the response to treatment, and clinical outcomes vary according to the type and tumor grade. And our management plan, including the extent of resection and new adjuvant treatments, should be formulated accordingly. For example, if we look at the cumulative incidence of local recurrence, as a group, the patient has about a 30% risk for local recurrence. However, if we look at the specific subtype, it's usually the high-grade liposarcomas that occur locally, while the leiomyosarcomas have a much lower risk for local recurrence. For metastatic disease, we see the opposite. We almost never will see a well-differentiated liposarcoma develop systemic metastasis, and it's mainly the leiomyosarcomas that will present with systemic disease. An excellent place to start managing a patient presenting with a retroperitoneal mass is by establishing an accurate preoperative diagnosis. This can be done by image-guided percutaneous core needle biopsy, and this is strongly recommended as standard of care. A pretreatment core needle biopsy of a retroperitoneal mass can identify patients who do not require surgery, so who present with a benign retroperitoneal tumor, such as a schwannoma, or it enables appropriate multidisciplinary treatment planning, where we may consider neoadjuvant chemo or radiotherapy. It also gives you more information about the histological type and grade and how we can adapt our surgical planning accordingly. Furthermore, it will identify retroperitoneal masses from non-mesenchymal tumors, such as metastatic epithelial malignancies or lymphomas. These four CT scans demonstrate nicely when a patient presents with a solid retroperitoneal mass, the advantage of a core needle biopsy. The patient in the first scan has a retroperitoneal schwannoma, a benign tumor on biopsy, which can be left alone or undergo very conservative surgery. The second patient has retroperitoneal lymphoma, which will be treated with systemic chemotherapy. This patient has a Ewing sarcoma, which will be treated with neoadjuvant chemo radiotherapy followed by surgery. And the fourth patient has fibromatosis, which will be treated with surveillance, medical treatment, or surgery. The same goes for retroperitoneal lipomatous lesions. Not all patients presenting with the retroperitoneal lipomatous mass is liposarcoma. The patient in scan 1 has a benign myelolipoma, which can be left alone. The patient in slide 2 presents with a benign hibernoma. The patient in slide 3 on biopsy has proven to be a benign lipoma. And the patient in slide 4 actually has a well-differentiated liposarcoma. So although the imaging may look very similar, the management will be very different based on the biopsy findings. Liposarcomas harbor an amplification gene called MDM2, which is now easy to detect and to confirm the diagnosis of liposarcoma. And this will help us to determine whether surgery is required and what the extent of surgery will be. Our unit and other units have shown that a core needle biopsy is safe for retroperitoneal sarcoma and does not influence local recurrence and does not influence the overall survival. So the core needle biopsy is a simple and safe technique to provide an accurate diagnostic information, which is essential to determine the appropriate treatment plan. The benefits of a pre-treatment biopsy in patients with soft tissue tumors outweigh the potential risk of needle tract seeding, and it should be the method of choice to obtain an accurate histological diagnosis. Surgery for retroperitoneal sarcomas can be challenging because patients usually present quite late with large tumors, which can be situated in a complex space in close relationship to multiple vital structures. And this impacts on the ability to perform a radical wide resection. The anatomy for the retroperitoneum is quite complex, and one has to be familiar with all the major vasculature, nerves, and structures that can occur in relation to the tumors. The anatomy can also be very distorted. If one look at the kidney in the first slide, it's completely pushed back to the posterior. In the second slide, the kidney is encased by the tumor. And in the third slide, the right kidney is completely pushed over to the left-hand side by the tumor. A retroperitoneal sarcoma can also exclusively occur in the posterior abdominal wall or psoas muscle. For instance, this is a pleomorphic sarcoma arising in the psoas muscle itself. And it can also occur in the mesentery or intraperitoneal. For instance, this patient has a well-differentiated liposarcoma of the small bowel mesentery. It is very important to have a careful review of the preoperative imaging to appreciate the potential for extra abdominal extension of these tumors. For instance, in this patient where there's extension into the posterior mediastinum, or in this patient where there's extension through the inguinal canal or through the sciatic notch. When we plan this surgery for these patients, we have to make sure that we place our incisions and perform our surgery to such an extent that the whole of the tumor is resected. The retroperitoneal liposarcomas can also consist of different components within the same tumor. So it's important to remember that this is just the high-grade component occurring in the bigger tumor with low-grade component in the front. And your surgery should be aimed to remove the whole of the tumor. Surgical expertise in retroperitoneal sarcoma resection requires specific anatomical knowledge of the retroperitoneal space. The standard method for staging is a contrast CT scan of the chest, abdomen, and pelvis, and it's important to remember that large tumors can distort the anatomy. Improper planning may lead to inadequate incisions, tumor rupture, incomplete resections, and the risk of catastrophic bleeding. And tumor extent and anatomical relationship with intra-abdominal organs, major vessels and nerves, the parietal wall, and bone must be carefully analyzed and studied before the surgery. So the cornerstone in the management of primary retroperitoneal sarcomas, the surgery should aim at achieving a macroscopically complete resection with a single specimen encompassing the tumor and involved contiguous organs. The concept of adapting our operative approach according to the histology is gaining increased recognition. So we will have a different operative strategy for a liposarcoma compared to a leiomyosarcoma, for instance. For liposarcomas, it is quite difficult often and challenging to distinguish exactly where the tumors start and what is normal fat. And given this uncertainty regarding the margin definition for liposarcomas, an extended approach to systematically resect adherent organs, irrespective of expected microscopic infiltration, should be considered. And a policy where we only resect structures or viscera that is clearly infiltrated by liposarcoma is likely to result in residual disease being left in the operative bed. So the objective to achieve for liposarcomas is this concept of compartmental resection, where we achieve a wide microscopic margin along some surfaces by removing adjacent, easily disposable organs, while we perform essentially a marginal excision along more critical structures of organs. There's very good clinical evidence that more extended resections improve your local recurrence as well as your 5-year overall survival for patients with liposarcomas. So how do we do it in practice? This is a large left-sided retroperitoneal liposarcoma with a colon and the colon mesentery stretched over the tumor. So we resect the left colon with the mesentery covering the tumor in that aspect. At the superior aspect of the tumor, the spleen was sitting on top of the tumor, and we resected the spleen with the tumor to ensure a clear margin, although the spleen was not clearly infiltrated. The pancreas is applied to the front of the tumor, and therefore a distal pancreatectomy will be performed. The lateral margin, the tumor is quite tightly applied to the abdominal wall, and therefore we do a incision into the lateral peritoneum, and we can even resect part of the abdominal wall as required. And then we look at organs that is specifically infiltrated by a sarcoma. For instance, here we see the crust of the diaphragm is infiltrated, and therefore we resected part of the diaphragm for this patient. And the medial margin are usually the major vessels, in this case the aorta. So we do a dissection and include the adventitia of the aorta with the specimen. At the back, the psoas muscle, the posterior margin, so we can either resect the fascia of the psoas muscle, or if the psoas muscle is infiltrated by tumor, then we can resect the whole of the psoas muscle with preservation of the femoral nerve. On the right-hand side, we also have the inferior vena cava as our medial margin, and there we can again do the resection on the surface of the IVC with a clear margin in that dimension. And then organs that is associated when we resect them with a higher morbidity should only be resected if directly infiltrated. For leiomyosarcomas, there's a more clearly defined border, and therefore we usually spare organs that is just adjacent and are not clearly infiltrated, and we only resect organs when they are clearly invaded by the leiomyosarcoma. However, we have to pay specific attention to achieve microscopic and negative margins of the vein of origin in longitudinal aspects. For instance, this is a leiomyosarcoma of the IVC encasing the iliac artery, and therefore we resected the tumor with the iliac artery on the right and reconstructed those with grafts. A further very important prognostic factor predicting outcome for patients is whether they undergo their surgery in a high volume specialist unit or in a low volume unit. Volume outcome relationships in the surgical care of retroperitoneal sarcoma support that the surgery should be offered in a high volume specialist sarcoma unit. It's difficult to define, but we think somewhere between 10 and 20 cases a year of primary retroperitoneal sarcoma resections constitute a specialist high volume unit. At the Royal Marsden Hospital, I do between 50 and 60 cases a year, so we have a very high volume turnaround every year. And there's very good evidence that both the early morbidity as well as the mortality is improved when patients have surgery in the high volume unit. Other studies have also supported that the oncological outcome is improved and that the institutional volume was a significant risk factor for local recurrence, that there was a higher rate for incomplete resection in low volume centers, and that intraoperative tumor rupture occurred more often in low volume centers. This has also been shown by the French sarcoma group, where patients did better when surgery was performed by specialist surgeons. We again, in the transatlantic Australasian sarcoma working group, showed that patients treated in high volume centers do significantly better compared to patients in low volume units. And also in the United Kingdom, we showed that patients have a 66 versus 53% 5-year overall survival when treated in specialist units. And they also have a superior outcome when the specialist unit has a high volume of retroperitoneal cases per year. So in conclusion, the retroperitoneum can host a wide spectrum of pathologies, including a variety of rare benign tumors and malignant neoplasms, which can either be primary or metastatic lesions. The optimal management of retroperitoneal sarcoma is facilitated by a pre-treatment diagnosis and staging established by a corneal biopsy and CT scan. The best chance of curative resection is at the time of primary presentation, and the individual management plan should take into account the imaging and histological findings. The biological behavior, response to treatment, and clinical outcomes vary according to the histological type, and the management plan should take this into account. The current standard of care for retroperitoneal sarcoma is extended en-bloc complete resection of the tumor and surrounding viscera performed in a high volume specialist center. Thank you again for this invitation, and I'm happy to take any questions.
Thank you very much, Mr. Strauss. So for that fascinating lecture, and Mr. Strauss has kindly agreed to be with us for a while. If you have any questions, please be kind enough to present them.
I think there's a question. Can we have a mic there to Dr. Jayakumaran?
Excuse me. Good morning. I would like to ask about giant cell tumor after surgery, very infiltrative tumor in the around near the spinal cord and so on. We used to give a RANG inhibitor. Is there any other treatment options available? Because RANG inhibitors are a bit expensive here these days. So can you enlighten on that?
Mr. Strauss, are you with us?
Yes, I can hear you. Thank you very much for the invitation.
Were you
Can
able
just
to, did you hear the question?
Can you just repeat the last bit or the question for me? I didn't hear it very clearly.
Giant cell tumor, when it is marginally operable or the debulking done, after debulking, we used to give denosumab, the RANG inhibitor, but a bit expensive here. Sometimes we are not having on regular supply. Have you got any other treatment options? Because these days we are getting few youngsters with giant cell tumor partially operated or debulked, and they are having.
I think it's an excellent question for the next speaker, actually, Dr. Alex Lee, who's a medical oncologist dealing with sarcoma. So we should maybe ask him for other options. I think for retroperitoneal sarcomas, there's a definite role for probably neoadjuvant radiotherapy and chemotherapy. But I think I will maybe ask Alex when he has done his talk to comment on the question.
Mrs. Strauss, I've got a question. So, especially in sarcomas in the pelvis, which are radiosensitive, sometimes when upfront surgery or even after chemotherapy surgery is not possible, we can give radiotherapy to shrink it further and then consider surgery. So, in your experience, so how will you time the surgery after radiotherapy? Especially, I'm talking about things like Ewing sarcoma.
Thank you. I've heard the question. How would the surgery occur after radiotherapy? We participated in the STRUST study, the initial STRUST study, where we specifically investigated preoperative radiotherapy and retroperitoneal sarcoma. And the surgery was not that much more difficult. If we time the surgery within 6 weeks or from 4 to 6 weeks after this radiotherapy has finished, you don't lose your planes. The planes are still very preserved. They're sometimes a little bit more edematous, but the surgery is no more difficult than it was without radiotherapy. We also looked at the complications and the trouble after surgery with radiotherapy, and there was no higher incidence of complications if you've had radiotherapy before surgery. So I think where one are concerned about close margins, especially for low-grade liposarcomas, there's definitely a place to think about preoperative radiotherapy. And surgery is not any more difficult if done 6 weeks after the completion of the radiotherapy.
Thank you. And is your practice to leave the patient without any treatment in the interim time? You are not going to give any chemotherapy in the interim?
Yes, in brief, our practice will be a high-grade sarcoma, like a leiomyosarcoma or a high-grade liposarcoma. We would usually use preoperative chemotherapy rather than radiotherapy. For our low-grade liposarcomas or solitary fibrous tumors or pleomorphic sarcomas, one will more often use radiotherapy. But during the period of 4 to 6 weeks until the surgery, there is no other treatment. It's just waiting and recovering from the radiotherapy.
Thank you.
Are there any more questions? Well, in the absence of any more questions, I thank again Mr. Strauss for this fascinating lecture.
Thank you very much for the invitation. It's very kind.
Okay. Next, it will be, let us listen to our own Dr. Damayanti Peiris, Senior Consultant Clinical Oncologist at the National Cancer Institute, Maharagama, Sri Lanka. She will enlighten you on radiation therapy for retroperitoneal sarcomas. Dr. Peiris has been serving the nation over the years as a clinician and the medical fraternity as a lecturer, trainer, and an examiner. I think almost all of us, including myself, the junior oncologists in Sri Lanka, have been privileged to be trained under her guidance and supervision. She is a founder member of and a former president of the SLCO, former chairperson of the SARC Federation of Oncologists, a member of Children's Cancer and Leukemia Group, as well as International Society for Pediatric Oncologists. She is always commended and remembered for establishing the first ever pediatric oncology unit in Sri Lanka and the training program for pediatric oncology. Over to you, madam.
Place of radiotherapy in retroperitoneal. If you look at the evolution of radiotherapy for soft tissue sarcomas, radiotherapy has been typically added to surgery, especially for high-grade tumors, and preoperative radiotherapy has been proven to have higher rates of local complete resections, and preoperative radiotherapy had been associated with reduced risk of local and distant relapses. Early complications are more with preoperative radiotherapy, but long-term morbidity is much less. And normal tissue complication rate varies with the individual anatomical site of the tumor. And if you look at the radiation doses, preoperative radiotherapy dose is 50 gray, with post-operative radiotherapy dose comes to 60 to 65 gray in 2 gray fractions. And there's a general preference for preoperative radiotherapy. Use of boost after positive margin in selected situations is allowed, going up to 20 gray as a fractionated external beam or bracket. The up and coming is the hypofractionated preoperative radiotherapy with good local control and tolerance, giving 25 gray in 5 fractions and surgery following 2 to 4 days after. And retroperitoneum, every one of us know the borders of the retroperitoneum, and there are several important organs that are situated in the retroperitoneal region. Pancreas, both kidneys, ascending colon, descending colon, and the duodenum, aorta, and inferior vena cava are the important organs. In between these organs, there is a connective tissue and mesenchymal structures from which only these retroperitoneal sarcomas arise. And these are rare tumors. And 1% of all malignancies are soft tissue sarcomas. Out of that, 15% of them are situated in the retroperitoneum. 70% of these retroperitoneal sarcomas are found in the abdomen, and 30% are in pelvis. There are more than 80 subtypes on morphological and immunohistochemical and molecular features, and commonest of them are liposarcomas and leiomyosarcomas. Some of these tumors are high grade, some are low grade, some have uncertain malignant potential. Regional lymph node involvement is rare, and as you will understand, multidisciplinary care is needed for these rare tumors, and therefore, ideally, these should be managed in tertiary care centers. The curative treatment for this group is complete surgical resection. However, in most cases, due to their size and localization, complete resection may not be possible. Radiotherapy has been an important tool in the multimodal management for retroperitoneal sarcomas. Radiotherapy, both in preoperative setting or postoperative setting, has been shown to produce improved overall survival compared with surgery alone. And most of these study groups are retrospective series. So there have been mixed results. And due to the growing interest in preoperative protocols, postoperative radiotherapy has been progressively got abandoned. And there are several reasons for that also. Adjuvant or postoperative radiotherapy has been shown to give a small benefit on local disease control. And some people believe it is just a delay in local recurrence. And there's high morbidity rate. there is lack of survival benefit. However, in certain situations, because of the therapeutic radiation dose cannot, because of the situation of the tumor or certain needed therapeutic radiation dose cannot be achieved in some patients. And some situations where complete resection is done, post-operative radiation is not needed. So because of these reasons, pre-operative radiation protocols have been taken a good stand, while post-operative radiotherapy has not been taken progressively. And pre-operative radiotherapy has shown in certain series tumor debulking is better. And in certain groups, though they have been able to selectively escalate radiation doses to high-risk margins, and which is happen to be safe. And certain series, they have shown intermediate and high-grade radiation retroperitoneal sarcomas have shown survival benefit with preoperative radiotherapy. There were, I told you, there were many retrospective series, but there was one randomized trial started in 2004 comparing neoadjuvant radiotherapy with surgery and surgery alone. Trial was prematurely stopped in 2004 due to low accrual rates. And there was a high treatment toxicity and there was a delay in surgery where they started giving preoperative IMRT combined with intraoperative radiotherapy. So there was no results are not available in this trial. And then the second randomized control trial started, which was named as TRAS-1, which is an international randomized control trial, multicentric, and a phase 3 study done in about 30 countries, transatlantic, and later on even Australia got involved. This was to assess oncological outcome. And preoperative radiotherapy 50-point gray was used in IMRT with surgery or without radiotherapy, surgery alone. And all this, any histological type was included, but they have deemed to be resectable. In 2016, interim results were published without any increased risk of perioperative events in the neoadjuvant radiation group. And the STRAS-1 trial, there were several endpoints about abdominal recurrence-free survival. They looked at radiographic local progression during radiotherapy, distant progression during radiotherapy, peritoneal metastasis at surgery, macroscopic residual disease found at surgery, and local relapse. However, they have changed the analytical points and in the events several times during this analysis. But the conclusion came as conventional preoperative radiotherapy with 50 gray should not be considered as the standard of care in treating retroperitoneal sarcomas. This was reported in 2020. And if you look at in detail, the both groups with radiotherapy and without radiotherapy have shown 3-year abdominal recurrence-free survival similar, 3-year modified abdominal recurrence-free survival similar, surgical fitness similar, and 3-year overall survival similar. However, liposarcoma subgroup has shown a significant difference in survival. But this, to come to a definite conclusion, the liposarcoma group needs a longer follow-up. there were problems of the trial with radiation dose, and there were high rate of protocol violations and toxicity data, and endpoints were confusing and they were changing endpoints at different time points. But however, you can see preoperative radiotherapy plus surgery group and surgery alone group has no significant difference in survival, and confidence intervals are merging in these two groups so that there is no significant survival difference. While these randomized trials were going on, there were two other studies were happening. One is National Cancer Database study having more than 9,000 patients using their conclusion was both preoperative radiotherapy and postoperative radiotherapy are associated with better overall survival compared with surgery alone. And there was another population-based study showing the use of neoadjuvant radiotherapy followed by surgery has a strong correlation with negative microscopic resection margins, leading to better local recurrence-free survival and better overall survival compared to surgery alone. So there's another multicentric phase 2 trial is going on, comparing preoperative image-guided intensity modulated proton radiotherapy or IMRT using photons with simultaneous integrated boost technique for retroperitoneal sarcomas. This trial is trying to escalate high-dose CTV dose, and results are expected in 2025. And still, therefore, efficacy of radiotherapy in retroperitoneal sarcoma is controversial, but still it's used in NCCN guidelines as you can use preoperative radiotherapy for retroperitoneal sarcomas with intraoperative radiation boost for appropriate positive margins. And they have even gone on to mention suggested the doses also. And again, in NCCN, they are suggesting to use preoperative 45 to 50 gray with simultaneous integrated boost doses going up to 57.5 gray for high-risk retroperitoneal sarcomas. So, ESMO, after looking at this 2020 STRAS-1 result, they have changed their guidelines. Neoadjuvant radiotherapy has shown efficacy primarily in low and intermediate grade retroperitoneal liposarcomas. Intraoperative or postoperative radiotherapy is of no proven value in retroperitoneal sarcomas. And they say further, resectable tumors and dedifferentiated liposarcomas, there was no value of radiotherapy. This report was out 2 months ago. And still, the place of radiotherapy is not lost. Still, we are expecting when there is R1 or R2 resections anticipated, clips to be placed in high-risk areas to identify the areas to be boosted. Preoperative radiotherapy is still used with 45 to 50 gray, expecting lower rate of local recurrence and long-term disease-free survival rates. And external beam radiotherapy in 1.8 to 2 gray fractionations. Total doses should be determined by critical organ tolerances. And postoperative radiotherapy is discouraged in retroperitoneal or intraabdominal sarcomas. In the event of a recurrence, preoperative radiotherapy would be better for these recurrent sites. And all radiotherapy technologies have to be used in treating retroperitoneal sarcomas, that is IMRT or SBRT, brachytherapy or intraoperative radiotherapy to improve therapeutic ratio. And preoperative radiation volumes and doses have been defined. All the radiation volumes, gross tumor volume, clinical target volume, PTVs, and the doses are all well defined. And importantly, margins can be changed to save vital organs in this region. And margins, the high-risk margins have to be decided by both by the surgeon and the oncologist. The boost can be either of intraoperative radiotherapy or brachytherapy or external beam radiotherapy in fraction. And the doses are also identified where the boost can be given. And those constraints are due to the limiting doses of liver, functioning kidney, bowel, and stomach. And again, volume expansions should be minimized in regions where tolerance to critical structures will be reached. So critical structures should be protected all the time. And again, high risk CTV should be defined along with the surgeon. But in unresectable disease, where the tumor is unresectable in retroperitoneum, higher doses can be used with radiation. Even up to 63 to 70 grade can be used to control this, treat this unresectable retroperitoneal sarcomas. Of course, for palliation, for pain, for spinal cord compression, radiation can be used. And there is a growing interest in preoperative chemoradiation. And some studies have shown chemotherapy playing a leading role in radiosensitization of retroperitoneal sarcomas. And the chemotherapy drugs that have been used are ifosfamide and apomycin. Up to date, there are no randomized controlled trials. But in late 2020, STRAS-2 trial, again multicentric randomized transatlantic trial, has been started to compare the outcomes of surgery with or without neoadjuvant chemoradiotherapy for high-risk retroperitoneal sarcomas. The results of this trial is expected in 2028. Thank you very much for listening.
Thank you very much, Madam, for that very concise presentation. Our next speaker is Dr. Alexander Lee, Consultant Medical Oncologist at the Christie Hospital, Manchester, United Kingdom. He's a member of the Greater Manchester and Oswestry Sarcoma Service and specializes in the medical treatment of bone and soft tissue sarcomas, including in young adults and adolescents. He's a member of the EURTC Soft Tissue and Bone Sarcoma Group and Pathobiology Group, as well as the Northwest UK Supraregional Complex Neurofibromatosis Type 1 Service. His research interests are focused around the development of novel biomarkers and enable a more individualized approach to drug therapy of sarcomas. Dr. Lee is joining with us live via Zoom from Manchester. Dr. Lee.
Good morning. Thank you for that kind introduction. Me presenting this live, it's been a very recent development, so you have to allow me with me whilst I get the technology figured out. I'm going to try and share my slides. There we go. Can someone confirm that my slides are now presenting? Yes, looks good. Good. Okay, thank you. Yes, so good afternoon in rainy Manchester. I'm very pleased to be speaking to you today about the role of systemic therapy in the management of retroperitoneal sarcomas. We've already heard from two previous speakers regarding, here we are, about retroperitoneal sarcoma, so I'll try and avoid repeating much of what they've said, but just to touch upon some of the fundamental background here. Retroperitoneal sarcomas account for about 15% of all soft tissue sarcomas. The majority of these retroperitoneal sarcomas are liposarcomas, and specifically within the well-differentiated, dedifferentiated spectrum. It's worth highlighting that these are intimately related diagnosis, all characterized by the same pathognomic molecular aberration, which is amplifications of sections of chromosome 12, which I'll come to talk about a bit more. About 20% of these retroperitoneal tumours are leiomyosarcomas, typically rising from great vessels in the area, but not exclusively. And then the other 20% or so are variably accounted for by less common subtypes such as MPNST, undifferentiated pleomorphic disease, and solitary fibrous tumour. About 1/3 of retroperitoneal sarcomas are low grade, with a majority high grade, which is an important distinction given the pattern of disease recurrence, specifically after surgery, with low grade disease often being locally recurrent, whereas high grade disease can recur and be aggressive both within the abdominal cavity, but with much higher rates of distant metastases also. Regarding prognosis, this is a figure about the STRAS trial that we just heard about, which was a now completed phase 3 trial comparing surgery alone versus a course of preoperative radiotherapy for retroperitoneal sarcomas, which spanned a number of different histological subtypes and, importantly, high and low grade tumours. If we look here, the median relapse-free survival in the abdomen here is approaching about 5 years. And as already mentioned, the preoperative radiotherapy did not seem to make a difference to this outcome across the full study population. The table on the right is providing, again, a bit more detail about the pattern of recurrence. Well-differentiated liposarcoma is already mentioned, when recurrence is almost always local and can occur as a late event, so outwards of 5 years can be seen. Whereas more high-grade dedifferentiated liposarcoma, both local recurrence at an earlier stage in the abdomen and distant metastases can be quite commonly seen. Whereas with leiomyosarcoma, local recurrence is seen less commonly, but with a higher rate of distant metastases. As already mentioned, recurrence of these diseases is generally associated with an incurable state. Sometimes salvage surgery for local recurrence can be attempted, although that's typically quite morbid. Distant metastases are almost invariably fatal. So I'm going to come on and talk about the role of systemic chemotherapy for these diseases, which at present is largely limited to the management of recurrence, inoperable or metastatic disease. I'll go through some of the data that informs the choices of systemic agents here, but I'll highlight up front that there is very little data specifically addressing tumours of retroperitoneal origin. The data I'll present is looking at dedifferentiated liposarcoma and leiomyosarcoma, which accounts for the majority of tumours of retroperitoneal origin where one would consider treating with chemotherapy. But the data I'm presenting here is not necessarily limited to effect in the retroperitoneum. So it remains the case that still after probably about approaching 40 years and counting, that doxorubicin is still seen as the international first-line standard, although objective response rates, particularly in dedifferentiated liposarcoma, are infrequently seen, with response in leiomyosarcoma perhaps a bit more common. There's been great interest over the last 10, 20 years or so regarding increasing the intensity of first-line treatment by combining doxorubicin with a second agent, which I'll explore some data. There's some indication the combination of ifosfamide significantly increases response rates in dedifferentiated liposarcoma. Those data are, however, taken from generally quite small numbers. Although in leiomyosarcoma, ifosfamide doesn't seem to improve response rates compared to doxorubicin alone. However, with leiomyosarcoma, the addition of trabectedin or dacarbazine has been seen to be associated with better rates of tumour shrinkage, albeit in comparative series. And just look at some of the data underpinning these combinations. This is related to the EORTC 62012 trial, which in short was a comparison of doxorubicin alone versus doxorubicin plus ifosfamide in first-line treatment of advanced soft tissue sarcoma. Again, highlighting this is not just limited to retroperitoneal disease. The primary outcome of this study was for overall survival, which there was no significant difference between doxorubicin and the combination. The combination, as expected, been significantly more toxic. However, there were improved rates of tumor shrinkage and progression-free survival with the combination, which in some parts of the world has been taken as a basis to approach first-line patients with combinations. Default here in the UK, we tend to reserve that for specific circumstances where tumor shrinkage will be of particular value. If we look at the forest plot here from this study taken from a later trial trying to identify patient subgroups where the combination might be more useful. This is looking at subtype where, if you believe me here, there may be some indication that the addition of ifosfamide, where anything on the left here is improved, may be slightly more effective in liposarcoma, although with a very broad confidence interval which crosses the line of significance, whereas in leiomyosarcoma, much more convincing that there is no difference seen. This is a figure taken from a recently published manuscript, which is reporting a collected retrospective experience from the European network, reporting outcomes of first-line chemotherapy in leiomyosarcoma, reporting outcomes for doxorubicin alone or in combination with ifosfamide and dacarbazine. So if we look at the red line here, the doxorubicin is again associated with the overall survival of only about 2.5 years. Again, this is including extremity disease. Whereas if we look at the blue line here, which is a combination of ifosfamide, it appears outcomes are worse, whereas the combination of dacarbazine is improved. And it's this data, amongst others, which has led to the view that if a combination is used for leiomyosarcoma, dacarbazine is likely more effective than ifosfamide, which, if anything, may be deleterious. Moving on, looking at second-line options, or second-line plus options. The use of ifosfamide as a continuous 14-day infusion has been looked at in a couple of small reports, including by Mr. Strauss and his colleagues at the Royal Marsden, where they've reported quite impressive rates of objective response, albeit again with low numbers and non-comparative. Combination of gemcitabine and docetaxel is seen as being a standard post-first-line option, particularly for leiomyosarcoma. Trabectedin, which is a minor groove DNA binder associated with low rates of objective response, but some survival advantage I'll come to talk about. The multi-targeted tyrosine kinase inhibitor, pazopanib, again associated with low rates of response, and in fact, liposarcomas are excluded from the license indication as given the lack of perceived effect in phase 2 data. Dacarbazine associated with low rates of response as a single agent, but perhaps useful in combination. And then the marine sponge-derived microtubule poison eribulin, again associated with low rates of objective response, but with some survival benefit data, which I will show you in a moment. So first of all, back to trabectedin, which is a DNA minor groove binder, which was investigated in the so-called L sarcomas, which is lipo and leiomyosarcoma, in pre-treated patients, again, not limited to retroperitoneal disease. Compared to dacarbazine, the primary outcome was progression-free survival, with the Kaplan-Meier here showing a clear benefit with separation of curves, suggesting a improved disease stabilization. We look at subgroups here in this forest plot by histological subtype. Again, the indication allowing for small numbers being that in most disease subgroups. trabectedin was beneficial compared to dacarbazine, including non-uterine leiomyosarcoma, of which a reasonable portion of retroperitoneal, indeed differentiated liposarcoma, where most will have been retroperitoneal. So looking at the data for pazopanib again, which is a multi-targeted tyrosine kinase inhibitor hitting primarily angiogenic targets, but also some anti-oncogenic targets. Also, this was investigated in a post-first line setting, again in an unselected mixed soft tissue sarcoma population, although importantly excluding liposarcoma, with a clear progression-free survival benefit compared to placebo. And again, looking at histological subgroups in here, all investigated subgroups appear to get benefit from pazopanib, including leiomyosarcoma. There is no publicly available retroperitoneal specific data for this, unfortunately. Then moving on to eribulin, which was investigated phase 3 trial again in the so-called L sarcomas compared to dacarbazine in pre-treated patients. The initial report looked at both, reported outcomes of both lipo and leiomyosarcoma, which seemed to show a overall survival, not a progression-free survival advantage. The figures I'll show here from subsequent papers, which looked at the individual outcomes between liposarcoma and leiomyo. So this is the liposarcoma data, where the blue lines for eribulin show a significant progression-free and overall survival benefit, where looking at the different liposarcoma subtypes, again, dedifferentiated liposarcoma being the most common retroperitoneal subtype, showed likely progression-free and significant overall survival benefit. And so the licensing of eribulin has been taken on specifically for liposarcoma, whereas when we look at the leiomyosarcoma specific data, the curves are transposed, suggesting eribulin is no better than dacarbazine, with perhaps a slight asterisk that when one looks at the subgroup analysis for this group of patients and looking at the site of origin leiomyosarcoma, it does seem that in uterine leiomyosarcomas, dacarbazine was more effective, with perhaps a slight hint that in non-uterine leiomyosarcoma, eribulin may be more effective. Whether or not that justifies the use of this drug in non-uterine leiomyosarcoma, I think is not conclusive and realistically is unlikely to be concluded anytime soon. So moving beyond the palliative use of systemic drugs, just to examine, is there a role out in earlier phases of treatment? So first of all, as I'm sure many are aware, there is no standard role for adjuvant chemotherapy in soft tissue sarcoma, albeit that most adjuvant trials focused on extremity soft tissue sarcoma rather than retroperitoneal. The Italian group looked at a combination of preoperative ifosfamide with radiotherapy and reported 5-year relapse-free survival of 44%, which compared to the STRATS trial data is perhaps no better than expected. Whereas preoperative chemotherapy is currently under investigation in the STRATS-2 trial, which I'll come to look at some more. First of all, looking at some post-operative adjuvant data. This is from the largest adjuvant study performed by the URTC, comparing combination of doxorubicin ifosfamide versus observation alone after surgery. And again, looking at by primary tumor site, there's no obvious benefit from chemotherapy in central tumors, which included retroperitoneum. And then to talk a bit more about the STRATS-2 trial, which you've already heard about. This is a recently commenced international phase 3 comparing surgery alone with 3 cycles of preoperative chemotherapy, with a focus on particularly high-risk disease or diseases at high risk of distant metastasis in particular, which is limited to high-grade dedifferentiated liposarcoma and high-grade leiomyosarcoma, with some difference in the combination chemotherapy used for the reasons already looked at. Primary endpoint in this trial is disease-free survival, which itself is a composite of endpoints looking at immediate failure of chemotherapy, so progression or non-complete resection, and then later local or distant recurrence. The design of the study is a combination, as already suggested, between immediate on-block surgery alone or 3 cycles of chemotherapy with a recovery period built into the protocol, and then proceeding promptly to surgery with follow-up until enough disease-free survival events have been seen. So to talk about emerging therapies, where the future may lie in these conditions. So first of all, NTRK inhibition, I'll come to a slide here. So as I'm sure many are aware, the notion of NTRK fusion as being a histology agnostic pan-cancer oncogenic biomarker has been cause of some excitement. However, it remains the case that outside of certain really quite rare cancer subtypes, the prevalence of these fusions are very low. This is from a plot of several thousand tumors that were tested in real world data. Whereas soft tissue sarcoma as a group, NTRK fusions are seen in 1.5%, but that's across all different soft tissue sarcoma subtypes. Looking at leiomyosarcoma by itself, only about 1 in 200 were found to have NTRK fusions. Solitary fibrous tumor, even less common, and I was not able to find any specific liposarcoma data. So these patients are out there, but they're few and far between. But as shown by this waterfall plot from early phase data for the NTRK inhibitor larotrectinib, if one is treated with these agents in the presence of an NTRK fusion, the degree of response is really quite remarkable, and that's the case with entrectinib as well. And so it remains the case that until we become better at identifying patient subgroups more likely to have it, that testing for NTRK fusion remains worthwhile, albeit a number needed to test or identify is probably 3 figures. Immune checkpoint inhibitors obviously have made tremendous difference across a growing number of cancer types. As ever, the data in soft tissue sarcoma is somewhat limited, although with an experience that now probably covers several hundred patients across different subtypes. This is the data that I could find for D. diff liposarcoma and leiomyosarcoma, just highlighting that these are generally small numbers in these studies, but the objective response rates are generally low, nothing reported higher than 20%, some as low as 0, with the suggestion being that perhaps D-differentiated liposarcoma, the rate of response is perhaps a bit higher than in leiomyosarcoma. The focus currently really seems to be in developing biomarkers to see if we can prospectively identify which patients are more likely to respond, with the French sarcoma group currently running a number of series focusing on tertiary lymphoid structures, which in the SARC-028 data were seen to be quite a powerful identifier for patients likely to respond. Just finally moving on to touch upon a few more recent developments in these diseases. So XPO1 inhibitors, the drug selinexor, has now completed a phase 3 trial, which has reported a positive primary outcome of progression-free survival compared against placebo with a manuscript imminent. I think it remains to be seen if the extent of PFS advantage with this drug is going to be seen as meaningful, and if the drug will be embraced as a new standard of care in pre-treated liposarcoma. Because of the underlying molecular abnormality in liposarcoma with the amplification of segment chromosome 12p, which almost always includes MDM2 and probably CDK4 in about 95%, there's been much focus on targeting these abnormalities with a range of probably now about a dozen MDM2 inhibitors having been investigated, which so far has been associated with quite disappointing rates of activity and quite considerable myelosuppression, which with CDK4/6 inhibitors, a similar story, quite limited rates of effects so far. Probably with the key question here is how best to combine these agents with cytotoxics or other targeted therapies. And finally, in leiomyosarcoma, there's emerging data that suggests that abnormalities of homologous recombination DNA repair is abnormal in up to 20% of tumours, which is thought likely to confer a degree of brachiness. And so there's interest again in exploiting these abnormalities, with a number of studies looking at PARP inhibitors, as well as DNA damaging cytotoxic agents. So just to draw things to a close, as shown, that unfortunately, as things stand, the role of chemotherapy is generally limited to palliation for retroperitoneal soft tissue sarcomas, with available agents being associated with disappointing levels of response. The STRATO trial will hopefully establish whether or not there should be a role for preoperative chemotherapy, both in terms of reducing local and distant recurrence rates in high-risk retroperitoneal soft tissue sarcoma. And as ever, the way forward is likely to be increasing our understanding of the cancer biology to develop new drug targets and new drugs. But not only that, we'll need to have intelligent, sophisticated trial designs, given the challenges of developing radiological endpoints for diseases that can recur and ultimately lead to patient deaths through a range of different ways. That's the end of my talk. Thank you.
Thank you very much, Dr. Lee, for that comprehensive presentation. And I would like to invite Dr. Damayanti Piris to the head table for the question and answers.
Can I ask one quick? Dr. Lee, good morning.
Good morning.
Question. Say what temozolomide post pasopanib failure, and the second one is, what is the difference between the zoledronic acid use versus antibody against RANK ligand in the giant cell tumor? Because the cost difference is much more, so both are the same mode of actions. So two questions. Can you?
Sorry, the audio was cutting in and out. Perhaps there's some repeat. There was a question about post-pasopanib treatment, and then a question about RANKL inhibitors in giant cell tumor. Is that right?
So the first question is, what is the place of temozolomide post-pasopanib failure? Temozolomide oral tablets, because sometimes patients refuse for chemotherapy, IV. So we go for pasopanib, and later we sometimes go on for temozolomide also. And second question is, in the giant cell tumor, the place of zoledronic acid versus antibody against RANK ligand, because the cost is much different, and we are not having much RANK antibody against RANK ligand here. So for the treatment of giant cell tumor also, can you enlighten us?
Sure. So the first question, on the role of temozolomide. So I'm aware that there are some non-comparative series reporting on that, which for the most part show quite limited activity, although that doesn't really make it stand out compared to much of the things we use. In my practice, I think it's the case in the UK that temozolomide is not widely used as any line of treatment. In terms of oral therapies, kind of historically and still to some extent, the kind of use of oral low-dose cyclophosphamide is still done and will constitute an arm within the upcoming EORTC tolerance trial, which is looking at a three-way randomization between standard doxorubicin, 3-weekly doxorubicin, weekly doxorubicin, or oral cyclophosphamide in less fit older patients with advanced soft tissue sarcoma. So that might be an option to consider for your patients who are reversed to intravenous treatment. As far as giant cell tumor goes, I wouldn't profess to having a tremendous expertise in this area, but I think the data does support activity of bisphosphonates. I think where available inhibitors of RANKL is favourable, not least because I think the speed of effect is much greater, and certainly in my experience is a highly effective treatment. Because we do have denosumab available, I haven't had direct experience of use of bisphosphonates, but I think there's description that it can be effective. So I think in the if denosumab is unavailable, I think use of bisphosphonates is a reasonable alternative.
Thank you.
Thank you very much, Dr. Lee. And now there will be a token of appreciation that will be presented by our president, Dr. Hilmi, to Dr. Damayanti Peiris.
And Dr. Lee, are you still with us?
Yes.
Thank you very much, Dr. Lee. We had to disturb your sleep for our sessions. And sorry for taking all the trouble and joining us all the way from Manchester. Thank you so much. A big thank goes to you. And next time, we would be very happy if you would be with us to enlighten our colleagues at our next session in 2022. So we look forward to seeing you in Colombo next time. Thank you very much.
That'd be lovely. Thank you. Thank you for having me.
We all are very thankful to the panel of knowledgeable intellectuals on behalf of the Sri Lanka College of Oncologists for sharing their expertise and knowledge on the ever-expanding area of retroperitoneal sarcomas. Now it's time to move on to the first plenary session of the day, which is radiobiology. So the next lecture will be delivered by Professor Catherine West, Professor of Radiation Biology at the University of Manchester. She is well known in the field of radiobiology, and her work mainly focuses on measuring radiobiologically relevant phenotypes in cancer patients undergoing radiotherapy. Professor West has been awarded the Weiss Medal in 2016, the Beck and Alexander Award in 2017, and made an honorary fellow of the Royal College of Radiologists in 2019. Ladies and gentlemen, may I welcome Professor Catherine West.
In my talk, I want to talk about biological optimization of radiotherapy. I'm going to introduce the need for biological optimization and illustrate its potential by focusing on the development of genomic signatures to measure radiosensitivity and tumor hypoxia. But the point I want to make here is I'm illustrating using these aspects of biology, but there are other aspects of biology that are of interest and important. I won't be, for example, I won't be covering immunotherapy. Radiotherapy schedules developed somewhat empirically over the years in order to maximize the probability of tumor control while minimizing the probability of toxicity. And these schedules have been derived in order to limit the level of late toxicity generally to below, severe late toxicity to below 5%. But these schedules treat populations, not individuals. And what's needed to improve radiotherapy of the future is to find ways of pulling these curves apart. And there's been a lot of good developments in physical optimization, individualization of physical optimization in patients by the ability to target the radiation more accurately and to use the dose constraints that are important. But biological optimization is required because the schedules treat populations, the same fraction, total dose, dose per fraction, concurrent chemotherapy, whatever the chemotherapy that is used. And is it likely that all patients benefit from the same fractionation schedule? Do all patients benefit from the same multimodality treatments? Does everyone benefit from having cisplatin or whatever concurrent treatments might be given? Or do all patients benefit from having radiotherapy when it's used as an adjuvant treatment? So there is clearly a need for biological optimization for the radiotherapy of the future. And radiobiology can identify areas for optimization. For example, find genomic predictors to tailor the use of specific radiotherapy schedules or combined treatments, or whether radiotherapy should be avoided. So I'm using my example for biological optimization by focusing on genomic predictors. So these are biomarkers, and biomarker development has woven its way through radiotherapy research over many, many years. Many papers look at potential biomarkers and say this could be used to stratify patients in the future. But none of them have progressed to clinical implementation. And there's two main reasons for this. We do not focus on validation. A biomarker must be validated to show that it can be replicated in multiple cohorts. And predominantly because of poor assay performance. A lot of work has been done on the past using protein assays, looking at the expression of a protein in a histological section, and those assays don't seem to reproduce across cohorts. Or there's been functional tests to measure radiosensitivity, and they have very poor repeatability, reproducibility. So the development of tumor genomic signatures is attractive because there's, number one, there's online resources that allow validation in multiple cohorts. But more importantly, I would say, is that you've got very good assay performance. The assays for DNA are very established clinically, very reproducible, repeatable across centers, across labs. And the assays for RNA, again, are also very sensitive and reproducible to use. And genomic classifiers are entering the clinical arena. Oncotype DX, MammaPrint, Decipher, they are entering the clinical arenas. But what we want are classifiers that are radiotherapy specific, that reflect aspects of radiobiology that will be important for optimization. And clearly, there is a need in biomarker research to focus much more on validation. So I've got a little figure here that illustrates what could be done in the future clinical scenario. You have your diagnostic biopsy, you take a slice, you look at RNA, and you could look at multiple signatures. And the assays for that are well developed and could be used. And of course, DNA, you could take an EDTA blood sample and you could look at mutations, multiple genetic changes. Relatively straightforward in terms of the assays. You just need to find the genes that need to be looked at. So I'm going to illustrate that by starting by focusing on radiosensitivity. And this is work done by the Torres Rocker group in America, and he derived a gene signature at the RNA level, a gene expression signature that reflects tumor radiosensitivity. And he did this by looking at the radiosensitivity of 48 cell lines that varied in radiosensitivity here. They had matched gene expression data, that's looking at the whole transcriptome, all the genes expressed at the RNA level. And they identified which genes associated with the difference in radiosensitivity. They identified a network of 500 genes, and they reduced that to a hub of 10 genes. And these 10 genes form their signature. If they look at the expression in a diagnostic biopsy, the expression of those 10 genes as a measure of radiosensitivity, they associated that genomic classifier could identify patients who were more radiosensitive, who would benefit from adjuvant radiotherapy. So in this Kaplan-Meier on the left, these breast cancer patients who had surgery and adjuvant radiotherapy, the upper line are patients with radiosensitive tumors. Those patients really benefited from the adjuvant radiotherapy. But if you look at patients who had surgery alone and had radiosensitive, that's the solid line, or radio-resistant tumors, it didn't make any difference whether they were radiosensitive. The benefit of surgery didn't matter. So this signature could be used for future biological optimization to select patients who really would benefit from radiotherapy or who might not benefit from radiotherapy, and radiotherapy be excluded. The group have subsequently taken this 10-gene signature forward as something called the genomic adjusted radiation dose, GARD. That means they combine the 10-gene biological information with information on dose and dose per fraction to come up with a GARD score. And they recently reported on a pooled analysis of over 1,500 patients and showed GARD as a continuous variable was prognostic for time to first recurrence and with overall survival. And they suggest that this GARD signature, this GARD biomarker, could be used to optimize radiotherapy to either adjust the dose or to avoid radiotherapy. So that's an example of future biological optimization where you have your initial diagnostic biopsies and you look at the expression of RNA. I'm also interested in biological optimization by predicting the risk of toxicity. So a genomic signature, and this is DNA now, not RNA, DNA, where you have a blood sample taken before treatment and you could look at every gene. There are many assays developed over the years to measure individual radiosensitivity, but pretty much all of them had very poor reproducibility and insufficient validation. So I've become interested in recent years in focusing on identifying the genetic determinants of radiosensitivity. And the reason for that is the DNA tests are established in clinical laboratories, so we don't have to worry about assay. Now we know that radiosensitivity is a genetic trait. And the genetic contribution to risk of toxicity will involve very rare variants in the population that have very large effects. And the exemplar there is the ataxia-telangiectasia mutated gene. And ataxia-telangiectasia is rare in the population, occurs in approximately 1 in 100,000 people, but it's associated with hypersensitivity to radiation, and radiation is generally avoided. So that's the extreme. But we know that most traits and diseases are polygenic traits, and radiosensitivity will be the same. So they depend on multiple genes, multiple common variants, each of which has very small effects. So to be able to have a genetic signature, you need to identify a lot of these common variants and use them together. And there's some papers out there that I think suggest how information on being able to predict risk of toxicity using a genomic signature could be used for biologically optimized radiotherapy. I illustrate that with 3 papers here that are case reports of individual cases of patients with ataxia-telangiectasia where radiotherapy could not be avoided. And each of these cases, they gave a reduced dose for radiotherapy based on the biology, the fact that individual cells from individuals with AT are 3 times as sensitive. So they gave the third of the dose and they successfully achieved tumor control. And that shows the potential for biologically optimized dose schedule. But in the radiogenomics field, we want to identify the common variants. We want to identify lots of common variants for people that we don't know are radiosensitive. Individuals with AT, you know, are sensitive. So single nucleotide variant or single nucleotide polymorphism is just a single change in a base. And we need to find a lot of them. And when you've identified a lot of them, you can generate a polygenic risk score. So you will get, you might be homozygote for the common variant, which means you get 1 copy from mum, 1 copy from dad, or you might be heterozygote and get 1 from mum, 1 from dad, or homozygous for the rare variant, in which you have 2 copies. So for that particular variant, if you are homozygous for the rare variant, you would score 2. Then you might have another variant where you score 1. And if you had, in this example here, where I've got a polygenic risk score on the right histogram, and the maximum score is 100, that might be 50 variants, and that individual is has both copies of the rare variant for all 50 SNPs. So we want to generate these polygenic risk scores. Of course, this is just one type of genetic variant. variation, and there's others that might be important that will be looked at in the future, such as copy number variations, epigenetic effects like methylation. But the low-hanging fruit is to look for the single nucleotide polymorph, work towards generating a polygenic risk score. And in other areas, these polygenic risk scores are starting to be used clinically. For example, they've now identified 30 SNPs associated with risk of breast cancer. And those with the highest 1% polygenic risk score had an over 4-fold increased risk of breast cancer. And of course, this is what we want in radiotherapy. We can identify enough SNPs and identify those, the top 1%, that have a 4, 5, 6-fold increased risk of radiation toxicity. Then radiotherapy biologically optimized based on that information. But if you want to identify a lot of SNPs, then you need very large studies. You have to carry out genome-wide associations studies, and they have to be very large. And that led me to being involved in setting up a radiogenomics consortium in 2009, because it's not the sort of work that can be done by a single center. You must work by collaboration. And the first GWAS looking at trying to identify SNPs associated with radiotherapy toxicity was carried out in 2010. Then by 2014, our cohorts, combined cohorts, were increasing. And this example here is just prostate cancer, where we've got done the largest studies. And the 2014 paper by Barnett showed that there were many SNPs, as we expected. There were many SNPs that we should identify, but when your cohort is so small, you struggle to reach genome-wide significance. Our Nature Genetics paper identified 1 SNP, and then our first meta-analysis of about 1,500 prostate cancer cases identified 3 more SNPs. Last year, we reported on an expanded meta-analysis which identified 3 more SNPs, and that was in nearly 4,000 cases. So obviously we're a long way from the breast cancer predisposition field when they've got 300 SNPs, but we are getting there. And recently, an analysis has been done on nearly 6,000 cases. So our cohorts continue to expand. I always feel it's challenging in the radiotherapy field because we deal with real-world data and the fact that schedules vary across centres. And this was our 2020 publication of just over 3,800 prostate cancer cases from cohorts compiled in the UK, Spain, USA, Belgium, and Canada. And you can see there's a lot of variation, and this just reflects clinical practice, a mix of intermediate, a mix of low and high risk disease, prior surgery varied, use of hormones varied, and the actual dose, which is the most important factor that determine risk of toxicity, varied as well. So it never ceases to amaze me that we do identify genetic variants given all this noise, I call it noise in the system. And yet, despite all this heterogeneity, we identified 3 SNPs that reach genome-wide significance. And because you're looking at multiple genes, for a gene to be considered significant, a variant to be considered significant, the p-value must be less than 5 × 10⁻⁸. So we've got 3, a long way from the breast field, but it's a good start. Once you've identified a variant, actually that variant is not a variant that's influencing trait. They're called tagging SNPs. They tag a neighboring SNP that's much more important, that's actually having an effect on gene expression. And you can do fine mapping exercise that identifies the likely causal variant, the credible causal variant. And that's because there's these fantastic resources available that will link a change at that particular position with a change in gene expression. It's having an effect on genes. And we identified a credible causal variant that affected expression of the angiotensinogen gene that's converted to angiotensinogen 2 by ACE, the angiotensin converting. And there's some evidence in the literature that angiotensin signature may influence radiation-induced blood vessel wall injury. And there's some work suggesting that ACE inhibitors could be radioprotective. So Sarah Kearns, who led this work, hypothesized that ACE inhibitors would reduce the risk of late hematuria, blood in the urine. That was the endpoint that the credible causal variant was associated with. So she carried out a small study in Rochester, where she's based, and she showed that the level of grade 2+ hematuria, that's late toxicity, was 0% in patients taking ACE inhibitors versus nearly 14% of those not taking ACE inhibitors, and that had to be during the radiotherapy. She also showed this wasn't related to any effect due to hypertension. And what this highlights is how our work looking at trying to identify genomic predictors to optimize radiotherapy can also identify future strategies for biological optimization, because it will identify targets, another important approach for biological optimization of radiotherapy. And our latest work within the Radiogenomics Consortium, now nearly close to 6,000 patients, and Sarah Kearns produced this data a couple of weeks ago for a meeting, so I'm sharing it with you. You're some of the first to see it. So this is our latest genome-wide association study. And what these plots on the bottom, they're called QQ plots, and they show expected level of association versus the observed level of association. So and each one of these dots is a variant. And if there is no relationship with this endpoint, in this case, rectal bleeding, I'm highlighting on the left, then everything follows this straight line. But when you see this elevation above the straight line, it means there are a lot of variants there associated with that phenotype. So there's a lot of phenotypes, and we just need to get the cohorts high enough so that they reach genome-wide significance. And in this, it illustrates the sort of work we do, and these are Manhattan plots. So each on the x-axis, you've got a different chromosome, all the genes in the chromosome, the variants that are, all the variants that are looked at. And this is the nominal significance level, 5 × 10⁻⁵, and we're looking at dots, variants that go above that significance level. And we replicated previously associated variants, and these arrows indicate the new variants that have been identified because we've increased our cohort size from 3,500 to over 5,500. More variants to discover, still more to do. And in terms of future biological optimization, we're not there yet. We haven't got enough variants. But I want to stress that it will not be genetic variants alone as a genomic classifier. They will be used within some sort of clinical model. And for example, this is work Sarah did to validate a clinical model that she'd shown previously in a previous paper that was associated with risk of toxicity, 2 toxicity outcomes there, urinary stream, hematuria. And that included, in this case, for this toxicity endpoint of urinary stream, there were 2 variants, 2 SNPs, but also history of hemorrhoids, prior surgery, and the dose to the bladder. And this will be the future. We're not there yet, but this is how a risk model could be used for future biological optimization of radiotherapy. So we would have some sort of radiosensitivity profiling, combine it with other information that's important to increase risk of toxicity and improve the therapeutic index by possibly avoiding radiotherapy or giving dose escalation in those that have a very low risk of radiotherapy. Okay, now I've just got a couple more slides, and right at the end, I want to focus on hypoxia as another area for biological optimization. All solid tumors have some level of hypoxia. It is a very well-established adverse prognostic factor. It's targetable, and we know patients with the most hypoxic tumors benefit most from hypoxic modification. And here I feel the genomic signatures are most promising for entering the clinical arena for radiotherapy. So there's ample data to support a high level of evidence for the benefit of hypoxia modification of radiotherapy. So I've given two examples here. We've got the UK Beacon trial in bladder cancer, where giving carbogen and nicotinamide to target hypoxia with radiotherapy increased overall survival by 13%. And then on the right, we've got the Dutch ARCON study in laryngeal cancer, where giving carbogen and nicotinamide with accelerated radiotherapy increased local regional control by 10%. And this is work that I've been involved in to derive genomic signatures, where you take your pre-treatment diagnostic biopsy and you're looking at RNA expression, RNA level. And we derived an RNA signature associated with hypoxia in bladder cancer. And we showed in the Beacon cohort, so Beacon, carbogen and nicotinamide increased overall survival by 30%. But in patients with high level of tumor hypoxia as determined by our signature, that benefit was 30%. Whereas patients with low hypoxia as determined by our signature did not benefit from carbogen and nicotinamide. And this illustrates the future biological optimization of radiotherapy using a genomic signature. And we've done similar work in head and neck cancer. This is the Dutch ARCON trial, where you had 10% benefit in regional control with carbogen and nicotinamide. But if patients had low hypoxia, they did not benefit from carbogen and nicotinamide. You should try something else with them, for example, immunotherapy, whereas patients with hypoxic tumors derived considerable benefit from carbogen and nicotinamide. So in my last minute, I'm just going to summarize. I hope I've emphasized the point that radiotherapy schedules treat populations, not individuals. There is physical optimization in the planning of the dose in meeting dose constraints, but there is no biological optimization, which will be important for the future of radiotherapy to maximize therapeutic ratios. Genomic classifiers, they've entered the clinical arena in other areas, and they will play a role in personalizing treatments. Molecular classifiers are being introduced for some cancers. Alongside them, we need the classifiers that measure radiosensitivity, that measure hypoxia. So these will be based on RNA because the assays reproduce. And I think DNA tests will in the future be used routinely for mutation testing and to identify things like the single nucleotide variants that are associated with risk of radiotherapy toxicity. We have a polygenic risk. And the final point I want to remind you is that I focused on radiosensitivity and hypoxia, but other aspects will be important. You can't just keep adding another multimodality treatment. You can't add, if you've got radiation plus cisplatin, you want to add hypoxia modification, you want to add immunotherapy. The future of radiotherapy is biological optimization, the right combination to the right patient at the right time. Thank you.
Thank you very much, Professor West, for that very insightful lecture. And now we have got a question in our chat box. Professor West, is there any place for de-escalation of radiotherapy dose with regards to the oropharyngeal cancers that are P16 positive, that are the tumors that are HPV related, since they are known to be more radiosensitive? Is there any place?
I think that's a very interesting question. And I think de-escalation is a difficult subject. For a low-risk breast cancer, I think de-escalation of the dose, yes. Would I advise de-escalation of the curative radiotherapy? Possibly not. But avoidance of cisplatin, that might be an option. So I think I would be reluctant to start by reducing the dose. It wouldn't be the first clinical study that I would do. Dose escalate the ones that are more resistant. Okay.
Thank you very much, Professor West.
Dr. West, can I ask one more question? What is the current thinking about the dose rate in brachytherapy and external beam radiotherapy? Effect of dose rate, low dose rate versus high dose rate in brachy as well as external beam radiotherapy?
For breast cancer?
No, whatever, because the dose rate earlier they thought in brachytherapy, low dose rate is better, but after the chart, this.
Yeah, yes. So, well, I know in the cervix, the move is all to use high dose rate. My personal opinion, I did write an article with Dr. Susan Davidson, who was based at Manchester. And my feeling from reviewing the literature was that you get more toxicity with high dose rate versus low dose rate. But the difference was not significant. But, and this was a number of years ago when I reviewed the literature, the long-term toxicity always seemed to be just a bit higher with high dose rate. That's a very personal opinion.
But in the SBRT and so on, when you use triple F beam, you are using very high dose rate. Is there any biological difference comes in there?
Well, dose rate effect, low dose rate is sparing, isn't it? Are you talking about the biological differences between high dose rate and low dose rate? You will get sparing as you lower the dose rate. So what's your thoughts on that?
No, the thing is, when you, the SBRT, when we are using very high dose, whether we are following the 5R principle is the thing, no? Because the timing or very short time interval with high doses. But when we use the high rate within short period of time, we can deliver this one. That's why I thought we are using the.
Oh, flash. Are you talking about flash irradiation?
So, yes, fractionated, but still we use the very high dose rate. That's why in the.
Yes, I'm not quite sure what question you're asking there. Sorry.
Okay,
so there's interest in flash irradiation where you give massively high doses in order to spare healthy tissue.
Okay, thank you.
Thank you very much, Professor West. It's very early in the morning and you have been joining with us about 10 minutes earlier than scheduled, and it's been a pleasure having you, and it's an honor and privilege to have you with us today. And it'll be lovely to see you in Colombo probably next time, hopefully for our next annual academic sessions. Thank you so much for joining with us from London.
Okay.
Thank
Bye.
you.
Thank you for having me. Thank you.
Thank you. Next up on the schedule is the last plenary session of the day. May I now take the privilege of introducing our next guest speaker to the audience. Dr. Graham Collins is a consultant hematologist and lymphoma lead clinician at the Oxford Cancer and Hematology Centre, United Kingdom. He is the national chair for the Hodgkin and T-cell lymphoma study group and also the founder of the Oxford Lymphoid Disorders Study Group. His main interests are in testing new therapeutics and biomarker strategies in lymphoma, and he is the chief investigator of a number of investigator-initiated and commercial studies. On a personal note, it gives me great pleasure in saying that Dr. Collins has been a pillar of strength to me. Whenever I have a difficult case, I would always turn to him, and he has been humble enough to promptly respond to me all the time and help me in difficult cases. Ladies and gentlemen, Dr. Graham Collins.
Well, very many thanks indeed for asking me to come and speak to you today. It's a great honor to be with you. My name is Dr. Graham Collins, and I'm a hematologist at the Oxford Cancer and Hematology Centre in the UK, and I chair the National Hodgkin Lymphoma Study Group. And I've got the pleasure of speaking to you today on early stage frontline classical Hodgkin lymphoma, balancing individual risk. I think it's a fascinating topic. It's actually quite a complicated topic now, but I hope that I can guide you through the relevant pathways. These are my disclosures. And let's start off with a case. So this is a case of a 23-year-old woman who works in customer relations for a bank. She presented to her GP with a 4-month history of cough, not responding to inhalers. And she also had a similar length history of quite significant arthralgias and marked fatigue. She'd lost over 1 stone in weight, and she now weighs 65 kilograms, and the GP requested a chest x-ray and blood tests. On examination, she had no lymphadenopathy or abdominal masses. A chest x-ray showed a mediastinal abnormality, which I'll show you shortly, and a CT confirmed a mediastinal mass. She was slightly anemic and had a sort of inflammatory picture on her bloods: white cell count 12, platelets 550, very high ESR at 140, and a CRP markedly raised at 120. Her other biochemistry was normal. And this actually wasn't her pathology, but it illustrates her pathology. You can see on the left these classic Reed-Sternberg cells, binucleate, embedded in an inflammatory and rather fibrotic background. The CD30 strongly stains the membrane, and in this case, the CD15 is also positive, as it is in about 70% of cases, and it's usually a cytoplasmic, sort of more granular type of staining. So the pathologist reported classical Hodgkin lymphoma of nodular sclerosis subtype. And this was the imaging. You can see the chest x-ray on the left with the widened mediastinum, and the CT scan on the right with the anterior mediastinal mass. Now she then had a PET scan, and the PET scan confirmed quite localized disease. Now this actually surprised me, because I've said before to my trainees that I'm not sure stage 1B Hodgkin lymphoma actually exists, but it certainly does. This lady is living proof, and there we have it. So stage 1B classical Hodgkin lymphoma, she had significant weight loss, and her ESR was also very raised. So she is an early stage unfavorable type. So how would we treat her? Well, it used to be very simple. Hodgkin lymphoma early stage treatment used to be simple, but it's not really anymore. One of the complications comes with the different ways of classifying favorable and unfavorable. There are 3 or more different ways. The 2 main ways that are used, at least in the UK, are the German Hodgkin study group GHSG or the EORTC classification system. You can see that they all incorporate ESR, they all incorporate bulky disease. The EORTC incorporates age, and I must say I think that's sensible, because I think older patients do have a worse prognosis no matter what stage they have. And they also have a slight difference in terms of nodal areas. So the German Hodgkin's group have 3 or more nodal areas as meaning high risk, and the EORTC have 4 or more nodal areas. The other thing the German Hodgkin study group does, which I like, is to include extranodal lesions. Not that makes it stage 4, obviously, but extranodal spread contiguously from an involved lymph node. I tend to use the German Hodgkin's study group classification a little bit more in my everyday practice. Now, in terms of early stage favorable disease, but when I say it used to be easy, again, the Germans have come to our help with a brilliant study, the HD10 study. It's quite old now, published in 2010. And they compared 2 different ABVD schedules, 2 cycles versus 4, with 2 different radiotherapy doses, 20 gray versus 30 gray. And they showed very convincingly that they were all basically the same. So 2 ABVDs with 20 gray involved field radiotherapy became the standard of care. It's very little treatment, really, and it led to a 5-year freedom from treatment failure of over 90%. So very good results with relatively little treatment for early stage favorable disease. For unfavorable disease, the HD11 reported, and this was a similar study in some ways. It compared ABVD with BCOP, and it compared 20 gray radiotherapy with 30 gray radiotherapy. Now, the optimal treatment arm there was thought to be the ABVD times 4 with 30 gray radiotherapy. The one arm that did significantly worse was the ABV times 4 with 20 gray radiotherapy. The BCOP arms did the same, but obviously BCOP is a more intensive treatment than ABVD. So 4 and 30 became the standard of care. And again here, the 5-year freedom from treatment failure, not quite as good, 85%. So still pretty good, still curing most people with relatively light treatment. But of course, everybody is getting radiotherapy in these protocols. Now, what's really made things more complicated, and I would argue interesting, is the advent of response-adapted trials. And this has now really been incorporated into the standard of care of many protocols. Now, the first study to report was our very own UK RAPID study. Now, this took patients with stage 1A, 2A, no bulk. So we didn't use the favorable, unfavorable classification. This was 1A, 2A, no bulk. Patients had 3 cycles of ABVD and had a PET scan. Now, it's not really an interim PET because most patients didn't get chemotherapy afterwards. So 3 cycles of ABVD and then a PET scan. If the PET scan was positive, as it was in 25% of patients here, then a fourth ABVD was given, followed by involved field radiotherapy. However, if the PET scan was negative, and for this trial that was defined as a Deauville score of 1 or 2, patients were randomized to no further treatment or involved field radiotherapy 30 gray, which was deemed at the time the standard of care. And essentially what the study showed is if you omit the radiotherapy, you do see a small but significant increase in the relapse rate. So if you look at the per protocol analysis, the 3-year progression-free survival with radiotherapy was 97%, but without radiotherapy was just below 91%. And that did not exclude a 7% inferiority, which is what the trial was designed to do. So omitting radiotherapy does slightly increase the relapse rate. These are the survival curves. Interestingly, though, the authors wrote that although the non-inferiority margin was exceeded in this study, the results suggest that radiotherapy can be avoided for patients with a negative, or at least for the majority of patients with a negative PET. So it's really quite a sort of positive spin on what is essentially a negative study. This didn't prove what it set out to prove, but clearly most people still are being cured with chemotherapy alone. Just after the RAPID, the LISA H10 study, so not HD10, this is H10 study, was reported. And this was a slightly larger study. This did split patients into favorable and unfavorable based on the EORTC criteria. And here they randomized patients to a PET-guided versus a non-PET-guided approach. And you can see that for the early favorable, the non-PET-guided was 2 ABVDs, followed by a PET scan, which wasn't acted on, then a third ABVD and involved node radiotherapy. So this is a smaller field, significantly smaller radiotherapy field size. Whereas those that were PET guided, if you had a negative PET, you had 4 cycles of ABVD. Whereas if you had a positive PET, you had 2 cycles of escalated BCOP and involved node radiotherapy. But of note here, if you were PET negative, you had no radiotherapy. So it's a similar sort of study testing whether the omission of radiotherapy in an interim, in this case it is an interim PET negative scan, does not lead to an increase in relapse rate. That was what the study was asking. And for the favorable group, the 5-year progression-free survival clearly showed that if you omit radiotherapy, your relapse rate is increased. And actually there was a 12% decrement in the progression-free survival at 5 years for those who had radiotherapy omitted. So really a very large drop in disease control. Still, the majority of patients are cured, however, but there is a clear PFS benefit, at least, for radiotherapy from this study. A similar result to the RAPID study, but perhaps a little bit more dramatic. Now, in the unfavorable group, the standard arm here was 4 ABVDs and involved no radiotherapy, whereas if you're in the PET-guided randomization, you would have a total of 6 ABVDs if your interim PET was negative. And that's important to remember, 6 cycles of chemo here if your PET was negative. Whereas if it was positive, you had escalated BCOP DAC, again, 2 cycles and involved no radiotherapy, exactly the same as with the early favorable group. Now, for the unfavorable group, there was a very small increase in relapse rate if you omitted radiotherapy in the PET negative patients, but it was only very small. But remember, these patients who were PET negative had 6 cycles of chemotherapy. And of course, the pattern of relapse was different from the favorable patients. The pattern of relapse here is more commonly outside of what would have been the radiotherapy field. So 6 cycles of chemotherapy maybe is more important in this patient group, particularly if you're going to omit radiotherapy. And these were the survival curves here for the early favorable group. And listen to how the authors report this. They say that in the favorable group, combined modality therapy results in better early disease control. And whereas in the unfavorable, it may be less clinically relevant. And treatment with chemotherapy is only defensible in individual patients. And so, this is a much more negative spin on the results of this study. So it's interesting how both studies had fairly similar outcomes, but quite different conclusions written by the authors. Now, in terms of escalation, what happens in those patients who are interim PET positive? Well, remember they had 2 cycles of escalated BCOP-DAC and involved node radiotherapy at 30 gray, and they had very interesting results here. So they showed actually that in the control arm, the 5-year PFS was a rather disappointing 77%, but in the BCOP arm, remember this is only 2 cycles patients are getting, then the 5-year PFS was 91%. Now this is really the only data that I'm aware of that shows that escalation with an interim PET after 2 ABVDs shows a significant progression-free survival advantage and a borderline significant overall survival advantage. So I think that at least for early stage disease, if you start with ABVD, then escalation with an interim positive PET is quite important, accepting, of course, that the escalated BCOP will be associated with more toxicity. And these are the survival curves showing the really quite impressive PFS advantage for the escalated BCOP PET-guided approach and the borderline overall survival advantage. So we have the rapid studies, we have the H10, but now we have HD17. And this is, as I've said in the title here, the new kid on the block. Now this comes from the German Hodgkin study group. And by this point, they were using escalated BCOP, 2 cycles followed by 2 cycles of ABVD as their standard of care for early unfavorable disease, and all patients were receiving radiotherapy at the end. So the HD17 was asking a fairly similar question to RAPID and to H10, but it was just using a different chemotherapy backbone. So they were asking, can you safely omit radiotherapy if your end of chemotherapy PET, so this is not an interim PET, this is an end of chemotherapy PET, is negative? And they again randomized between a standard combined modality treatment, 2 escalated BCOPs, 2 ABVD with 30 gray involved field radiotherapy versus a PET guided arm, where if you were PET negative after that chemotherapy, you had no radiotherapy, whereas if you were PET positive, and this was a Deauville score of 3 or 4, then you had 30 gray of involved node radiotherapy. Now, they had incredibly high 5-year progression-free survivals. Remember, this is early unfavorable disease, and the PET-guided approach was non-inferior. So this is the only study that I'm aware of in early stage Hodgkin lymphoma where omitting radiotherapy does not increase your relapse risk. But of course, that comes at the cost of every patient having 2 cycles of more intensive chemotherapy, escalated BCOP. And look at those 5-year PFSs, 95%, 97%, extremely good results, underscoring the fact that escalated BCOP is a better chemotherapy at disease control for Hodgkin. Of course, there's the toxicity risk, but it certainly is better at controlling the disease. So really, we have a menu to choose from now in early stage Hodgkin lymphoma. And I don't really think there's a particularly right way of approaching this. So we could stick with the HD10 or HD11 approach and give 2 ABVDs and 20 gray involved field radiotherapy to all patients. I mean, that's got a very high chance of cure. But of course, you're submitting everybody to radiotherapy with the associated late effects. And the HD11 approach, as I've mentioned, 4 ABVDs and 30 gray involved field radiotherapy. And if it's difficult to have access to PET scans, that is a perfectly reasonable approach associated with high cure rates. Or we could adopt a rapid approach, and for stage 1A, 2A, no bulk, we could give 3 ABVDs, do a PET, and if the PET is negative, give no radiotherapy, and if it's positive, give a 4th ABVD and give radiotherapy. So that's a reasonable approach, which is followed by many centers. Or we could go with the LISA approach, the H10 approach. In this approach, we would be escalating patients if they were interim PET positive to 2 cycles of escalated BCOP and radiotherapy, whereas if patients were PET negative, if we follow the H10 study, we would still be giving the early favorable patients radiotherapy after the ABVD, but the unfavorables we would be giving 6 cycles of ABVD. Or indeed, we can follow an HD17 approach for early unfavorable disease and give every patient 2 cycles of escalated BCOP, 2 of ABVD, do a PET scan. If it's negative, no radiotherapy. If it's positive, radiotherapy. The downside there being that every patient gets escalated BCOP, but only 2 cycles. I should say that in the UK and some sites in Europe, we've replaced the procarbazine in escalated BCOP with dacarbazine in an attempt to try and reduce gonadal toxicity. Now, we don't really have good data for that, but there is a rolling audit looking at outcomes, which is actually being presented at ASH this year on an oral presentation. And certainly the outcome results look as good as escalated BCOP. And there is some suggestion it may be less toxic, but that's not being looked at in a randomized way. The other benefit I would point out of HT17 is it's over very quickly. 2 cycles of escalated BCOP takes 6 weeks, and then you've got your 8 weeks of 2 cycles of ABVD. So how do we integrate this, into a pathway? Well, we've attempted to do this in Oxford. This is taken from our classical Hodgkin lymphoma frontline pathway. The complete one also has advanced stage, but I've just taken the stage 1, 2, no bulk pathway here. Bulk patients we tend to treat on advanced protocols. And we split people into early favorable and unfavorable. And we usually use the German Hodgkin's criteria, although I do put age in here as a criteria as well. And we then discuss these options with the patient. So if it's early favorable, we would usually go down an ABVD approach, give 2 cycles. Now we give 2, not 3. Remember, rapid was 3 and then a PET, but it just makes it easier for everybody to remember 2 ABVDs and a PET scan. If the PET is negative, then we will individualize the risk depending on how extensive the disease is, whether they're a smoker, whether it's a man or a woman, depending on sites of disease, etc. And we would consider radiotherapy. If the patient's going to get radiotherapy, they may get a 3rd cycle of ABVD or they may not. We might just go for 2 ABVDs and 20 gray radiotherapy. Whereas if the PET scan is positive, they'd go down an escalated BCOP DAC route. I should say, though, we do, on the whole, our default in the early favorables is still to try for radiotherapy unless we think there's a very good reason not to. So we involve our clinical oncologists very early in this discussion. And we're very clear with patients that if the radiotherapy is omitted, the relapse rate is increased from between 7 to 12%. That's what the data from the trial seems to suggest. And if the patient's early favorable, we discuss an ABVD and an escalated BCOP DAC approach. If we really want to avoid radiotherapy because of the sites of disease and other factors, and if the patient is adamant that they want a very high cure rate, irrespective of the toxicity of the treatment, then we would usually advise an HT17 approach and go down that bottom pathway, escalated BCOP ABVD, and only radiotherapy to PET positive lesions. Whereas if they're, perhaps fertility is a very important thing for the patient to preserve, and they're a bit happy to sort of accept slightly less toxicity, but also with a slightly less good disease control rates, then we would usually suggest an ABVD approach. And if the PET scan's negative, we would go with the 6 cycles of chemo, just like the H10 standard arm. Well, not standard arm, but the H10 interim PET negative arm. But we would generally give AVD rather than ABVD following the RATTLE study, which seemed to say that you could easily lose the bleomycin. For both those early favorable and unfavorable, if that PET scan is positive, we would escalate based on the H10 randomized data. So that tends to be how we integrate it. And I would say it is a discussion with the patient. So consultations with newly diagnosed Hodgkin lymphoma patients are really quite long now. I usually spend some time in the consultation trying to work out what the patient's priorities are. Is it cure at all costs? Is fertility a really important issue for the patient, particularly if they're a woman? If it's a man, it's easier to preserve fertility. Are they really keen to spend not much time in hospital, in which case ABVD is probably preferable? Do they need to get back to work, or do they need to continue their university studies quickly, in which case maybe the HT17 approach is more suitable because it's quick? So there's all these factors that come into play when discussing this with the patient. And usually we can come up with a plan that we both agree is in the patient's best interest. But as I say, and I would point out this again, we involve our clinical oncologists early, and most patients would get a separate consultation to weigh up the risks and benefits of radiotherapy, particularly if they're not going down the HT17 approach, because most patients getting escalated BCOP DAC don't need radiotherapy at the end, whereas with an ABVD first approach, the issue of radiotherapy is more important, particularly if they're early favorable. I hope that's clear. So what's happening next in early stage Hodgkin? Well, the RADAR study is soon to open. This looks very complicated, but essentially it's the RAPID study. But what we're doing is comparing an ABVD platform with an AVD brentuximab platform. So we're seeing if bringing in brentuximab to AVD can improve outcomes in early stage classical Hodgkin lymphoma. And we're actually hoping for an increase in PFS by 5%, 90 to 95% by incorporating BV, and to target the burden of radiotherapy more appropriately by increasing the PET negative rate. There are also some very interesting translational studies bolted on. Now, something else we're doing in Oxford is one of my colleagues, David Cutter, who is a clinical oncologist, an academic clinical oncologist. He's supervising Rebecca Shacker, who's a PhD student, to try and develop a decision support tool. So the idea would be if you have a patient in clinic with, let's say, early stage classical Hodgkin lymphoma, you would have the computer open and you would have a little calculator on there. You would put in their age, gender, sites of disease, chemotherapy, and any proposed radiotherapy dose that they would need. It would then sort of churn out the output of what the progression-free survival benefit is of the radiotherapy, what the cardiovascular disease risk is for that patient, the second cancer risk, the stroke risk for that individual patient. So it's to give individualized benefit and risk of adding in radiotherapy to early stage Hodgkin lymphoma patients. And that work is ongoing and could be really helpful in helping our patients and indeed the clinicians making these, what can be really quite tricky, individualized decisions for early stage Hodgkin lymphoma patients. Now, I thought it might be helpful just by ending with a few examples, just to talk through the sort of decisions that that we face in clinic and the risks and benefits that we would discuss with the patient. So this is a 24-year-old man with right axillary disease, stage 1A. Patients are non-smoker, have early favorable disease. So there are 3 questions that I'll talk through. So how many cycles of chemotherapy would you give, and indeed what chemo? Well, this is early favorable disease, so I wouldn't give escalated BCOP. I would give ABVD. So ABVD, I would start with here. I would give 2 cycles and do an interim PET, just as I do with all my Hodgkin patients now, really. And what's the benefit of radiotherapy here? Well, again, if you follow the H10 study, then omitting the radiotherapy might increase the relapse risk by up to 12%. So there's a potentially significant benefit. What are the risks? Well, actually, I would argue they're very low. This is a man, so there's no significant breast tissue in the axilla in a man. There is in a woman, but not in a man. You might irradiate a bit of lung, but the patient's a non-smoker, so it's going to be a very minimal increased risk of lung disease later in life. So really, I would be really suggesting radiotherapy in this patient. I mean, I would be referring to my clinical oncology colleagues, but I would be laying the path and suggesting that radiotherapy should be standard here. So actually 2 and 20 for this patient would be very reasonable. I would, though, do a PET after the second ABVD and escalate if there's still PET positivity, which is very unlikely in this situation. How about example 2? Now, this is, again, a young 24-year-old woman. She's a smoker. She has bilateral neck and axillary disease, and she also has upper mediastinal disease. And this is clearly early unfavorable. There's several sites, really quite a few sites of disease here, making her early unfavorable. I haven't put ESR or anything down, but we know simply from the number of sites that this is unfavorable. So how many cycles of chemo would you give, and what chemo? Well, this is early unfavorable. So either escalated BCOP, 2 cycles, and then 2 cycles of ABVD, or start with 2 ABVD and plan her interim PET after your second. And really either, as I say, are fine, and I would have a discussion with the patient. If the patient wanted cure at all cost, I would suggest an HT17 approach, whereas if other factors such as fertility preservation, staying out of hospital, a lower burden of acute toxicity, then I'd be suggesting an ABVD approach. And if the interim PET scan was negative, I would give 4 cycles of AVD. Whereas if the interim PET scan was positive, I would suggest 2 cycles of escalated BCOP DAC and radiotherapy. And I would also at that point suggest we might want to preserve her an ovarian cryopreservation. You can't really collect stimulated eggs after 2 cycles of chemo, but you can collect an ovary and preserve that. That is safe to do. Now, radiotherapy, there's not that much benefit of radiotherapy in early unfavorable disease, apart from if you have PET avid disease after your HT17 approach, whereas the risks in this patient are really considerable. There'd be a lot of breast tissue, bilateral axillary disease, so that might increase her breast cancer risk to almost 1 in 3. And she's a smoker, so any lung tissue, she would have a quite significant increase in lung cancer. There's also, of course, mediastinal disease, which would increase her breast cancer risk, lung cancer risk, and cardiovascular risk. So I would not be keen on radiotherapy in this patient. Now, of course, those are the two extremes. What about something that's a little bit more nuanced? Well, here we are, a 35-year-old man, non-smoker, stage 2A, right neck, so angle of jaw to supraclavicular. Now, that's all one site. So it's quite a big lot of neck disease, but that's still one site. And upper mediastinal disease, that's 2 sites of disease, non-bulky, ESR, etc. Normal, so this is early favorable disease. Now, again, it's favorable, so I'd start off with ABVD rather than escalated BCOP. I would do an interim PET after 2. And what are the benefits of radiotherapy here? Well, again, it's early favorable disease, so potentially quite a high benefit of radiotherapy, but this is where the risks are a little bit higher, aren't they? So we'd be irradiating quite a bit of the carotid arteries. That would slightly increase the risk of stroke later in life. There's upper mediastinal disease here. Now, it depends a little bit how far down that disease goes, how much of the heart and coronary vessels would be irradiated. That would affect his cardiovascular risk. And of course, with quite a bit of the neck being irradiated, he's likely to become hypothyroid at some point, which is more of a pain than a real problem. But again, there are reasonable risks here with radiotherapy. So it would be a discussion with the patient involving your clinical oncologists and judging whether for that particular patient in front of you, they would be keen on radiotherapy or not. So I hope that helps steer you through some of the intricacies of the early stage classical Hodgkin lymphoma pathway. Thank you very much for listening, and thank you again very much for asking me to come and speak to you today.
Thank you very much, Dr. Collins, for that very interesting presentation. Is Dr. Collins with us live? He's not there. Right. All right. So I think we can probably post your questions on the online chat. So probably we can forward the questions to Dr. Collins. He would be able to probably answer them via email, or we can provide his email also to our audience, those who are interested in asking questions. You can contact him or emails and ask your questions. Now it's time for the lunch break. So we will now take a 45 minutes break for the lunch before the free paper session. We will be right back at 2:15 p.m. Let me remind you that we have a very distinguished panel of judges for free paper and scientific poster presentations this time. The best free paper and the poster presentation will walk away with valuable gifts and certificates, and we will be announcing the winners shortly after the next session. So stick around. And your lunch will be served at the Orchid restaurant. And another small reminder that there will be a raffle draw sponsored by Sioka Private Limited. Please make your way to Sioka store in the lobby and fill in your entry forms for the raffle draw. For those who win the raffle would be gifted with very valuable prizes, and so let's take the lunch break. Thank you.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing NutriCan. Special nutrition specifically formulated to help prevent severe weight loss, known as cachexia, in chronic disease patients such as cancer. NutriCan is enriched with high energy for improved rehabilitation, high protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins and 10 minerals. NutriCan is strawberry flavored. Colby science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing processes and quality assurances. We will continue to give the best to help your life.
Amart Holdings, bringing back happiness in lives. Amart Holdings.
Thank you.
Welcome to Amart Holdings Private Limited, one of the leading healthcare service providers in the country. We partner with world-renowned healthcare pharmaceuticals and chemical manufacturers to bring latest technology, products, and services to Sri Lanka. We provide high-end genetic diagnostic services, personalized treatment plans for different types of cancers, best quality pharmaceuticals for affordable prices, and we facilitate foreign medical treatments from well-known hospitals in Singapore, Malaysia, India, and around the world. For further information, visit www.amartholdings.com. Amart Holdings, bringing back happiness in lives. Selinco Healthcare Services proudly presents a revolution in cancer treatment. Introducing the tomotherapy treatment system.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing NutriCan, special nutrition specifically formulated to help prevent severe weight loss, known as cachexia in chronic disease patients such as cancer. NutriCan is enriched with high energy for improved rehabilitation, high protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins and 10 minerals. NutriCan is strawberry flavored. Kalbi science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing processes and quality assurances. We will continue to give the best to help your life.
Amart Holdings, bringing back happiness in lives. Amart Holdings. Welcome to Amart Holdings Private Limited, one of the leading healthcare service providers in the country. We partner with world-renowned healthcare pharmaceuticals and chemical manufacturers to bring latest technology, products, and services to Sri Lanka. We provide high-end genetic diagnostic services, personalized treatment plans for different types of cancers, best quality pharmaceuticals for affordable prices, and we facilitate foreign medical treatments from well-known hospitals in Singapore, Malaysia, India, and around the world. For further information, visit www.amartholdings.com. Amart Holdings, bringing back happiness in lives. Zelenko Healthcare Services proudly presents a revolution in cancer treatment. Introducing the tomotherapy treatment system.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing NutriCan, special nutrition specifically formulated to help prevent severe weight loss, known as cachexia in chronic disease patients such as cancer. NutriCan is enriched with high energy for improved rehabilitation, high protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins and 10 minerals. NutriCan is strawberry flavored. Kalbi science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing processes and quality assurances. We will continue to give the best to help your life.
Amart Holdings, bringing back happiness in lives. Amart Holdings. Welcome to Amart Holdings Private Limited, one of the leading healthcare service providers in the country. We partner with world-renowned healthcare pharmaceuticals and chemical manufacturers to bring latest technology, products, and services to Sri Lanka. We provide high-end genetic diagnostic services, personalized treatment plans for different types of cancers, best quality pharmaceuticals for affordable prices, and we facilitate foreign medical treatments from well-known hospitals in Singapore, Malaysia, India, and around the world. For further information, visit www.amartholdings.com. Amart Holdings, bringing back happiness in lives. Selinco Healthcare Services proudly presents a revolution in cancer treatment. Introducing the tomotherapy treatment system.
Introducing science-based nutrition for the first time in Sri Lanka. Introducing Nutrican, special nutrition specifically formulated to help prevent severe weight loss, known as cachexia, in chronic disease patients such as cancer. Nutrican is enriched with high energy for improved rehabilitation, high protein with BCAA to stimulate muscle repair and strengthen immune function, omega-3 to enhance the chemotherapy efficacy and improve cardiovascular function, high fiber for improved digestion and better nutrition absorption, DHA and EPA to reduce cellular inflammation and improve brain function post-chemotherapy, 11 vitamins and 10 minerals. Nutrican is strawberry flavored. Kalbi science-based medical nutrition formulations are developed adhering to the highest standard of manufacturing processes and quality assurances. We will continue to give the best to help your life.
Amart Holdings, bringing back happiness in lives. Amart Holdings. Welcome to Amart Holdings Private Limited, one of the leading healthcare service providers in the country. We partner with world-renowned healthcare pharmaceuticals and chemical manufacturers to bring latest technology, products, and services to Sri Lanka. We provide high-end genetic diagnostic services, personalized treatment plans for different types of cancers, best quality pharmaceuticals for affordable prices, and we facilitate foreign medical treatments from well-known hospitals in Singapore, Malaysia, India, and around the world. For further information, visit www.amartholdings.com. Amart Holdings, bringing back happiness in lives. Selenco Healthcare Services proudly presents a revolution in cancer treatment. Introducing the tomotherapy treatment system. Zelenko Healthcare Services proudly presents a revolution in cancer treatment. Introducing the tomotherapy treatment system.
කවරේ එකකින් කාවත් හොඳයි ටයිමින් එහෙම බලන්න ඕනොත් එහෙම නිකන් සයිඩ් සපෝට් එකද කවරේ දැන් ටයිම් බලන්න ආරම්භ වලට එහෙම කෙනෙක් සයිඩ් සපෝට් එකට આવත් හොඳයි නවාට මගේ ටයිමින් එක දෙන්නද විනාඩි 6 දී වරක කවුන්ට් ඩවුන් එක ඔව් විනාඩි 6 දී ඔව් එකක් ගන්න ඔව් විනාඩි 7 දී දෙකක් ගන්න අක්කි නිදා ගන්නකොටත් මං කන්නද තාම මේක තියාගෙන කවුරු නිදියනවා නම් ගහන්න ඕනේ පටන් ගන්නකොට ගහන්න ඕනේ මේ වරුව ටයිම් කරන්නේ ඒක කොහොමද ගහන්න ඩෝල් ගයි හරි මෙහෙම කරන්න ලැබුණේ හරි මම අර rules and regulations ටික කියනවනේ initially මම ඒ ටික කියන්න හරි ඊට පස්සේ ඔයා කරන්න first oral present කියන එක ඔයා ඕකින් කරන්න හරි එතකොට නම් Good afternoon, everyone, to the last session for the day. As the Sri Lanka Cancer Research Group, we are very happy with the number of abstracts we received this time. I think we received the highest ever when we consider the last few years. So the idea of the Sri Lanka Cancer Research Group is to provide a platform for budding researchers in oncology to develop their skills in research, as well as present them to a selected audience. So I think as a researcher, it's not only that you need to develop your skills in research, but an essential part is presenting your research in a concise, precise manner. So this is a ideal opportunity for them to practice their presentation skills. And I hope the audience gathered here and those of you who join us through the internet to provide to be attentive as much as possible and to ask relevant questions and to encourage these presenters who had done quite a lot of hard work to get here. Just to refresh the mind of the presenters of the rules, everyone is given 7 minutes to present. You will hear a bell at the end of 6 minutes and 2 bells at the end of 7 minutes. And I would urge you all to wrap up by 7 minutes, otherwise you will be penalized. There will be 2 additional minutes for questions. And again, I hope the audience would make use of this opportunity to clarify doubts and ask questions. And I'm sure the presenters would welcome them. The marking scheme is clear cut. We will share with you later. And there is the prize, the SLCO prize for the best oral presenter will be awarded at the end of the presentations. So can I ask Dr. Buddhika Somawardana to welcome the first presenter, please?
Yeah, without further ado, let me invite I.N. Ekanayaka to present her paper on prevalence of BRAF V600E gene mutation in thyroid cancer patients in Sri Lanka, the implications in disease management. Over to you.
A very good afternoon to all of you. I'm Nadishani Ekanayaka from the Faculty of Science, University of Colombo. Let me take you through our abstract on the prevalence of BRAF gene mutation in different types of thyroid cancer patients in Sri Lanka in relation to implications in disease management. To give you a very brief overview, thyroid cancer is the most common endocrine malignancy, currently having an alarming increase in its rate of incidence worldwide. In Sri Lanka, it is the third most common cancer among females. And to give you a look at the statistics, in 2018, there had been 8.1% of female thyroid cancer cases, and within 2 years, this had gone up to 8.7%. So if you look at the issues with the existing treatment and diagnosis methods, in diagnosis, the inconclusive test results from the fine needle aspiration test can sometimes lead to undertreatment of high-risk malignancies and also the overtreatment of low-risk benign conditions. While in therapeutics, some patients are resistant to the existing treatment methods and some show cancer recurrence. So in order to address these concerns and to better manage thyroid cancer, the novel approach is to understand its molecular genetic basis. And this involves identifying specific gene mutations which are related to thyroid cancer onset and progression. So these specific mutations can serve as molecular markers for the disease, which help in diagnosis, prognosis, making predictions about the disease progression and in therapeutics. So if you look at the molecular alterations in thyroid cancer, there are several gene alterations recognized, out of which BRAF mutations, and in particular, the BRAF valine to glutamic acid 600 mutation is the most prevalent. It is known to be associated with aggressive clinical behavior, reduced response to radioactive iodine therapy, loss of thyroid differentiation, and the poor overall survival of the patients. So the aim of our study was to determine the prevalence of this particular gene mutation in Sri Lankan thyroid cancer patients. This was a first-time study. And under the methods, first we obtained ethical clearance which was granted by the Institute of Biology, Sri Lanka, following which data and samples were collected using an interview-administered questionnaire, and samples were the formalin-fixed paraffin-embedded thyroid tissue blocks of patients who had undergone thyroidectomy. And from these samples, DNA was extracted and an allele-specific PCR was separately carried out to amplify the wild type and, if present, the mutant allele of BRAF gene. And finally, the data was statistically analyzed using SPSS. To give an overview about the samples, in total there were 76 wax blocks obtained, out of which 26 were diagnosed as follicular adenoma or benign tumors and 50 were malignant. The proportions of each subtype of the thyroid cancer was comparable to the local prevalence of each subtype. So under the molecular detection, DNA was extracted and then allele-specific PCRs were carried out separately to identify the wild type allele and the mutant allele. Moving on to the results, we found out that the prevalence of this particular mutation is significantly high in our study cohort. However, when we compared for the presence between the malignant and benign groups, there was no significant difference. And to show the overall genotype distribution, most of the individuals were heterozygous. That is, they had both the wild type allele and the mutant allele. And the absence of the mutation was seen in both the benign group as well as the papillary thyroid cancer subtype. There was one individual without the mutation, without the wild type allele in the papillary thyroid cancer group. We also looked at the risk factor associations, and this was the overall age category distribution of the individuals. And as you can see, malignant tumors were quite prominent between the ages of 41 to 50, while follicular adenoma was prominent in the preceding age group. Overall, there was a higher incidence of tumors between the age of 31 to 50 years. When we compare the mean age at thyroid tumor onset between malignant and benign conditions, there was no significant difference. When considering the gender, there was a very clear female preponderance, and however, between the malignant and benign tumors, there was no significant effect of gender. We also looked at the family history because this disease is continuously increasing and to check whether it has a familial basis. However, most of the patients were not having a family history, and out of the patients that did report having a family history, most were having first-degree relatives. And when we checked whether there is an effect of having a family history on the occurrence of a malignancy and whether the positivity of this mutation is associated, there was no significant correlation. In addition, we also checked for the associations between the body mass indices of patients with the risk of thyroid cancer because previous literature had suggested one. And we did see a prominence of the obese condition in our study cohort. However, when we compare the mean BMI value of the malignant subtypes with the benign subtype, there was no significant difference. In conclusion, based on our results, we can say that the prevalence of this mutation is significantly high in Sri Lankan thyroid cancer patients. Most are heterozygous, but since its prevalence was not significant in malignant subtypes when comparing with the follicular adenoma benign group, it cannot serve as a diagnostic molecular marker based on our results. However, it has the potential to serve as a therapeutic marker, that is to be targeted in therapy, because most of our patients have the mutation, and also there are small molecule BRAF inhibitors available for clinical administration, which have been approved in some countries. And in relation to risk factors, with overall thyroid tumor onset, there is a female preponderance, and most are aged between 31 to 50 with obese condition, while obesity is also prominent. As the way forward, we can go for increased sample sizes and check for this mutation at initial diagnostic stages and during treatment. Clinical studies are essential to check the impact of this mutation in disease progression and for targeted therapy. Finally, it is highly recommended to make use of these molecular markers to assist diagnosis and treatment. These are the references that I used, and I would like to acknowledge these individuals without whom this study would not have been possible. Thank you very much.
Thank you very much, Ms. Ekanayake, for that nice presentation. We have 2 minutes for any questions from Ms. Ekanayake regarding the presentation.
You in the beginning you said that you wanted to do this to have the better therapeutic options to offer. Then why did you did it among the benign cases?
Actually, this was like part of my study for the abstract submission. I focused on the therapeutic side for this particular presentation, but like my study was based on, and like I looked at the prevalence overall, how it is distributed, because it had not been tested initially.
And have you checked the obesity and hypothyroid state?
Hypothyroid, no, sir.
Because hypothyroidism also you may get.
Yes.
Malignancies or for benigns as well?
Benign as well.
So, in your sample, your title is basically the BRAF mutation in the Sri Lankan population. Can you tell us a little bit about your sampling technique to show that this sample actually can be generalized to the Sri Lankan population?
So actually, I considered information was obtained from patients reported from January to October, reported at the National Hospital Kandy, which is one of the major hospitals in the region, and patients are from many regions are coming for treatment there. So it was not restricted to patients from Kandy, the study sample. And since I considered an extensive time period and considered all the wax flux of patients who had undergone surgery during that period, I think it is applicable.
Thank you very much. Thank you, Ms. Ekanaka, for your presentation.
Next, it will be a dosimetric comparison of conventional and intensity modulated radiotherapy in patients with locally advanced left-sided breast cancer receiving post-mastectomy adjuvant radiotherapy. Presented by Nuraj Joseph from Teaching Hospital, Batticaloa.
Thank you for the opportunity. This work was actually performed by Mr. Dinesh Amaladasan, the physicist, who unfortunately for personal reasons is unable to attend, and I'm presenting on behalf of my team. So indications for post-mastectomy radiotherapy, tumors more than 5 centimeters or with skin and chest wall involvement, more than 3 involved lymph nodes, and in patients with 1 to 3 involved lymph nodes and closed margins less than 5 millimeters, they are at intermediate risk of developing local recurrence, and they may also be offered post-mastectomy radiotherapy. The benefit is that it reduces the risk of local recurrence and therefore leads to an improvement in survival in high-risk patients. Our current radiotherapy technique is a 3D conformal technique comprising of 2 glancing fields with a matched supraclavicular field. But there is recent interest in intensity modulated radiotherapy, and this is being increasingly used, particularly in randomized controlled trials of modern breast cancer fractionation. So this figure illustrates the dosimetric comparison. And you can see on the left is a 3D conformal plan. It's just 2 glancing fields, so quite a bit of the lung gets irradiated to a high dose. And the whole treatment volume here gets the same dose. On your right is the intensity modulated radiotherapy plan. This is your area where you want to target your dose of radiotherapy to the chest wall. You can see the high dose region is very tightly controlled. There is less of lung getting high doses, but it results in a low dose bath. So you're actually redistributing dose. You're giving lower doses to larger volumes of tissues, but reducing the amount that gets a high dose. So the objective was to compare the dosimetric parameters between 3D conformal radiotherapy and inverse planned intensity modulated radiotherapy in left-sided breast cancer patients receiving post-mastectomy radiotherapy. We selected left-sided patients because this is where the irradiation of the heart comes into consideration, and long-term toxicity of post-mastectomy radiotherapy is high in left-sided breast cancer. So this was a radiotherapy planning study. We selected 10 patients with left-sided breast cancer, planned to receive radiotherapy to the chest wall and supraclavicular lymph nodes at the teaching hospital of Batticaloa. So we compared the two radiotherapy techniques. The 3D conformal technique was a standard two glancing fields with a matched anterior supraclavicular field. As we would do normally in clinical practice, optimization was done by adjusting beam weightage and wedge angle. For IMRT, we selected a 5-field equispaced inverse plan technique, and the dose was 40 grain, 15 fractions over 3 weeks because this was nodal irradiation. This was in a group that needed nodal irradiation. The comparative variables were PTV coverage as defined by conformity index, that is the volume receiving the prescribed dose divided by the volume of tumor receiving the prescribed dose. So it's a measure of how the additional volume that is required to irradiate to achieve, to treat the tumor volume. Then we also compared mean lung dose, mean heart dose, and integral body dose, because that is a measure of the low dose bath, and that was derived by multiplication of the mean body dose with body volume. And we did the Wilcoxon sign rank test because this is a paired group. And yeah, so these are the 10 patients. There was a bit of wide variety in the treatment plans. My radiation oncology colleagues will appreciate that some of them did quite well with 3D conformer technique, but some were optimized better in the IMRT plan. So going to the dosimetric comparison, conformity index was definitely improved with IMRT. The mean lung dose was, however, higher, which meant that an additional volume of lung gets irradiated to lower doses. There was a slight reduction in mean heart dose, but that was not statistically significant. An integral dose also was higher. So it means that in our quest to achieve better dosimetric precision in the tumor volume, we are actually irradiating a large amount of tissue to lower doses. So the issues with conventional radiotherapy is that you get areas of low dose and areas of high dose, and this dose conformity isn't great, and it's quite challenging to achieve the therapeutic targets of maximum dose less than 110, and lung and heart toxicity in left-sided tumors are also an issue. So we normally do optimize it using field-in-field techniques, but inverse plan IMRT is a better way of doing it. However, we have to consider the higher integral dose and as well as the higher lung integral dose. The implications of these are use of IMRT may increase long-term lung toxicity, and since a larger volume gets irradiated to lower doses, this could potentially lead to a higher incidence of second cancers. And we need to follow these patients up for a long time to determine this fact. So in conclusion, the impact of the low dose bath needs to be considered when switching from 3D conformal radiotherapy to IMRT. Thank you.
Now we have 2 minutes for any questions.
No, I would not recommend. I would not recommend inverse planned IMRT yet, because the low dose bath is of significant concern. Forward plan IMRT, where you use field-in-field techniques, is probably the way forward. Yes, definitely IMRT will improve dose conformality. You can achieve your, for the tumor volume, you achieve a better coverage. But since this is a curable cancer and you're only looking to reduce the risk of recurrence, long-term toxicity has to be kept in mind, and we have to be certain that IMRT is safe, and this data does not seem to suggest that.
I don't think you have enough patience to answer this question, but just out of this, you think that there is a group that you can identify where IMRT might be more useful than 3D CRT?
So I think there is no doubt that IMRT will improve tumor coverage. But in terms of low dose bath, it was increased in all patients. So that is something that you'll have to factor in.
For the site, I mean, obese people, whether the IMRT is better.
Yeah. So certainly with 3D conformal techniques, if the thickness is less, and certainly if the patients are obese, you struggle to achieve your dosimetric constraints. And that IMRT will be more suitable in those patients. But again, the issue is toxicity and the potential toxicity due to irradiation of a larger dose, a larger volume to a smaller dose. It might be less than in an obese, than in it's a body, depending on the body composition, the integral dose will be less, but still it's higher with IMRT in comparison to 3D conformal radiotherapy. I don't think VMAT will improve the low dose bath significantly, because you're still giving in different directions, and the amount of lung tissue that gets irradiated will still be the same. Yeah. It may potentially increase as well.
I think we need to move on now.
Thank you very much, Dr. Nurad Joseph, on that very nice presentation. So let me invite the next presenter of the free paper session to the podium, Ms. K. Sindhuja, from the Department of Molecular Biology and Biotechnology, Postgraduate Institute of Science, Peradeniya. She'll be presenting on clinical pathological analysis of adrenal tumors, a 5-year retrospective study in 3 tertiary care hospitals. Over to you, Ms. Sindhuja.
Very good afternoon, one and all present here. I'm Sindhuja, reading MSc in Department of Molecular Biology and Biotechnology, Postgraduate Institute of Science, Peradeniya. Today, I am presenting my findings under the topic Clinicopathological Analysis of Adrenal Tumors, a 5-year retrospective study in 3 tertiary care hospitals. Adrenal tumors can be cancerous or benign. A variety of tumors ranging from benign simple cysts to aggressive carcinomas arises from the adrenal glands. In certain types of adrenal tumors, it is difficult to predict clinical and malignant behavior purely on histology due to their rare presentation. Our objectives were to describe the clinicopathological characteristics of patients, population with adrenal tumors in Sri Lankan setting, to describe the treatment received by these patients and the treatment outcome, to correlate clinicopathological characteristics with treatment outcome, and finally, we are correlating the incidences with other countries. And we have followed descriptive cross-sectional study, and we have analyzed the spectrum of adrenal tumors in 3 tertiary care hospitals in Sri Lanka: National Hospital of Sri Lanka, South Teaching Hospital Kurunangala, The data were collected from 5 years request forms and histopathology reports of all adrenal specimens. And we have found 44 adrenal incidences and 43 patients were, the tumors were resections, and the tumor incidences ranged from 11 years to 80 years. The median age was 45 years. Male to female ratio, we found 1 to 2.4. 98% were unilateral tumors and 57% right-sided. One bilateral metastasis from renal cell carcinoma, 2 ganglioneuromas, and 2 metastasis deposits. And all over the tumor size range from 10 millimeter to 140 millimeter, and we found 51 millimeter mean size. And this is our spectrum of adrenal tumors, which we have found in Sri Lankan studies. And 41% of adrenal cortical adenoma, 30% pheochromocytoma, 11% adrenal cortical carcinoma, 9% myolipoma. And we have specially focused on pheochromocytoma, and we have found 13 patients. The more pheochromocytomas found in the age group between 31 to 50 years. The females were preponderance. 7 patients were clinically diagnosed, and 11 patients we have found 40 millimeter in size and above. The 3 patients we have found the PAS score 4 and above. These are some of the microscopic images which we have in the pheochromocytoma. Especially they have stain by hematoxylin, eosin stain, synaptophysin stain, chromogranin, and S100 stain. Followed by pheochromocytoma, we have focused on adrenal cortical carcinoma. We have found 5 patients, which is also very rare cancer. And we have found here 2 females were preponderance, 1 functional tumor, 2 tumors we found about 100 millimeters, and 1 tumor we found with R2 resection. And this is also adrenal cortical carcinoma, microscopic image with hematoxylin and eosin stain. And our conclusion, we have found, we are concluding the predominance were females, and histological subtypes and peak occurrence was in 4th to 5th decade, which were correlating with the similar studies. And adrenal tumors were the commonest one. The majority of the resected tumors were 4 centimeter and above in size. And finally, we have found the mean size of pheochromocytomas were relatively larger when compared with the similar studies in Asia. These are some of our references we have used in our studies. Thank you. Thank you so much for the oncologist, the College of Oncologists, which they have given wonderful chance. Thank you.
Thank you very much, Dr. Sindhuja, for sticking to the time, and let us shoot some questions to her.
What sort of percentage of adrenal tumors when diagnosed undergo surgery? Because
yes, in our studies, we have found 1 biopsy. So like 98% we have got resections and 1 were with.
No, what I am asking is when in the imaging, when you get the adrenal tumors,
yes,
not all are undergoing resection, no, depends on the stage and all. Whether you can generalize these findings for the females are a little bit predominant here.
Yes. When we have collected our data, and it was predominant in female as well, it was all when we were considered, all were in the resections.
Was your study based on histological reports in the lab, or did you do actual survey of admissions and discharge?
Yes, our study basically based on the request forms and histopathology reports.
So it was confined to ones which have been subject to either biopsy or surgery?
Yes.
The outcome.
Yes.
So did
yes,
you do that? Because if
Yes, ma'am.
your information is just from histology reports, how did you correlate
ma'am.
with the outcome?
In future, we are following this research for finding out the we are going to correlate with the tumors with the other studies also, with the treatments and treatment outcome.
So you are retrospectively looking at their outcomes from their clinical records. So how do you look for the outcome of the patients?
Is after once we have completed with this clinical pathological research, and we are going to check the patients, and we are going to follow them with the treatments and what is their outcomes.
And you don't know whether you'll be able to follow all these patients because some of them might have defaulted. If it's an adenoma, they may not come for follow-up. So you will have lots of issues in continuing this study. Have you thought about it?
Yes, ma'am. I would like to follow these studies for a few more years. Because I'm focusing on Sri Lanka, these studies, because and also neuroendocrine tumors, and how these patients, because that is which these tumors are very rare, and now it is increasing last few years. So I'm going to follow these patients and going to find out the treatments and their outcomes.
I think we can move on now. Thank you very much.
Thank you.
Next, it will be AMJ Seniviratne from the Postgraduate Institute of Medicine, Colombo, to speak regarding knowledge, attitudes, and practices regarding medical nutrition therapy among doctors at National Cancer Institute, Maharagam.
Yes. Good afternoon, everyone. So our study was to find out knowledge, attitudes, and practices regarding medical nutrition therapy among doctors at National Cancer Institute, Maharagama. So in the background, malnutrition is something common among cancer patients, and according to literature, 40 to 80% of all cancer patients are estimated to be malnourished during the course of their disease. So nutrition is a part of multidisciplinary management of cancer patients, and it is one of the main responsibilities of doctors to treat cancer patients, to identify malnutrition among cancer patients, and to direct them for appropriate nutrition therapy. Therefore, knowledge, attitudes, and practices among doctors play a major role to achieve this. But however, current studies show unsatisfactory knowledge and underuse of medical nutrition therapy among doctors treating malnourished cancer patients. So when it comes to the Sri Lankan context, cancer has ranked as the third leading cause of death according to Annual Health Bulletin 2019, and a Sri Lankan hospital-based study on disease-related adult malnutrition has revealed a 31.8% of prevalence of malnutrition among our oncological patients. Therefore, the cancer is a burden to our country, and on top of that, if these patients become malnourished, the burden becomes double. So we have a main center for treating cancer patients, National Cancer Institute, Maharagama, including a medical nutrition unit. And there are more than 300 doctors working in it, including postgraduate trainees. Therefore, since there is no published local data at the moment related to the knowledge, attitudes, and practices among our doctors treating our cancer patients, we thought it's worthwhile studying on this. So our main objective was to assess knowledge, attitude, practices on nutrition therapy among doctors treating cancer patients at NCIM. And the specific objectives were to assess the knowledge on diagnosis of malnutrition and indication for nutrition therapy, to identify the attitudes on nutrition therapy, and to identify practices influencing implementation of nutrition therapy. So therefore, we conducted a descriptive cross-sectional study within a 2-week time period using a pre-tested self-administered questionnaire which had 4 domains, including socio-demographic data of the participants, assessing the attitudes on importance of nutritional status of the patients, and the nutritional support, and assessing the ability to identify malnutrition and indication for nutrition therapy. For this, we gave 2 case scenarios and assessing barriers preventing nutritional therapy. So study participants, we included doctors working at NCIM who actively handle patients and involving either screening, diagnosis, treatment, or follow-up of patients, because at any of these stages, it is possible to detect malnutrition and refer them for appropriate nutritional therapy. So we considered their working units, and most of the working units were fulfilling our criteria, but we had to exclude some doctors in some working units like blood bank, laboratories, IT, planning and quality control, and statistics units, since these doctors were not handling patients much. So we calculated our sample size using this formula, and the sample size came as 273. And we collected data using Google Forms shared in NCIM, the hospital doctors' social media groups. And data were analyzed, and the normality of the data were assessed graphically as well as using normality tests. And the data were analyzed using SPSS 21 software. So we'll come to the results. So characteristics of our participants, we had 273 participants, and out of them, majority were medical officers, which was 190, and 63 were trainees and 20 were consultants. And out of them, majority, 60% were females. And when it comes to the years of clinical experience in oncology field, 138 had more than 10 years of experience in oncology field. And when it comes to the patient exposure per week, 167 were seeing 50 to 100 patients per week. And 36% of our participants has had some sort of nutrition education during their medical career. And we also queried about the self-confidence in diagnosing malnutrition. And 81% was confident in diagnosing malnutrition among their patients. But however, this confidence, self-confidence was not statistically significant with their age, designation, or duration of the oncological experience. And we assessed the knowledge of our participants, and 203 participants achieved the correct diagnostic approach based on the first case scenario we have given, and only 101 participants correctly identified when to start nutritional therapy based on the second case scenario we have given. And considering all, we gave a knowledge score to all our participants with a maximum score of 15 and divided them into 2 groups with a knowledge score more than 10 and with a knowledge score 10 or less than 10. And this is how the knowledge score was distributed among our participants with a mean score of 10.57. And 37% of our participants had a higher knowledge score, which was more than 10. And this higher score was associated with the fact that they have received previous nutrition education, and it was significantly associated with their designation. And when it comes to the knowledge score among designations, the consultants, the median knowledge score was 15, and for trainees it was 11, and for medical officers it was 9. And the differences in pair-wise comparison, consultants to medical officers and trainees to medical officers, it was statistically significant, but between consultants and trainees it was not statistically significant. And we'll go to the attitudes. 97.8% strongly agree that nutrition affects prognosis. 70.3% strongly agree that all patients should undergo nutrition screening. But however, when it comes to actual practice, only 2.2% referred more than 75% of their patients to the medical nutrition unit. And we queried about the identified barriers preventing them referring patients for nutrition therapy. So 233 stated lack of clear local guidelines on nutrition therapy as the main barrier. And 35 stated that lack of knowledge among doctors. So in conclusion, there's a need to bridge the gap between identification of malnutrition and referral for nutrition management. And there's a need of setting up local guidelines for nutritional management in cancer patients. And there's a need of continuing medical nutrition education and training doctors who are treating cancer patients. These are our references, and thank you.
Now we have 2 minutes to ask any questions.
You have given 2
Yes, sir.
scenarios.
2 case scenarios.
Whether those are validated to do this study already, or you have designed? You have given that.
We have designed. Yes. Yes, that was actually we gave we gave the questionnaire to the doctors who are working at oncological unit, not in the National Cancer Institute Maharagama, through our contacts, and we validated like that.
Current study indicated the knowledge level is poor. What are these current studies?
There are no studies done in Sri Lanka, sir.
There was a statement saying current studies indicate that their knowledge is poor.
Yes, sir. The studies done in other countries, they have stated that around 20% of knowledge. Yes, European countries and UK. Yes. Oncology, only for the
Thank you very much, Dr. Seneviratne, for that interesting presentation. Let's move on to the next speaker, Dr. DGH Harindra from National Cancer Institute, Maharagama, will be presenting on a study on whole breast radiotherapy with ultra hyperfractionation at the National Cancer Institute, Maharagama.
Good afternoon, everyone. I'm going to present a study on whole breast radiotherapy with ultra hyperfractionation, that is 26 gray in 5 fractions at National Cancer Institute, Maharagama. During COVID-19 pandemic, ultra hyperfractionation reschedule was practiced for right side whole breast radiotherapy in 2 units at the Cancer Institute, Maharagama. The objective of this study is to further characterize and determine the effects of this practice. All female patients assigned for this treatment from June 2020 till mid-September 2021 were included. Data on patients' age, radiation sites, tumor bed boost, dates of radiotherapy planning and delivery, mean radiation dose to the CTV, PTV, lung, heart, and maximum dose were obtained. Patient potential side effects like skin erythema, ulceration, chest pain, and shortness of breath were recorded. Data were compiled using Excel format. Descriptive statistics were used to characterize the findings. We have 45 patients were planned for treatment. Age range from 33 to 88. A majority of them were less than 60 years. 18 patients were treated with whole breast radiotherapy with boost, and 16 were treated with without boost. And 4 patients were treated with whole breast radiotherapy with boost and with SCF, and 7 patients were treated with whole breast radiotherapy with SCF without boost. Almost half of the patients had tumor bed boost of 9 gray in 3 fractions. Mean lung dose with boost was 4.68 gray, and without boost was 4.27 gray. Additional SCF radiation did not change mean lung doses. Average mean cardiac dose was 0.67 gray. The CTV coverage range 95 to 103. Maximum dose, that is global max, range from 104 to 110%. Treatment delay was observed 3 to 164 days, the mean of 36 days. 30 patients had been completed radiotherapy up to mid-September. None had chest pain or shortness of breath. As a side effects, erythema was observed in 12.5% without boost, and that is 45% for 5 with boost. Erythema with moist ulceration was observed in 6.25% without boost and 22%, 73% with boost. As conclusion, ultra-hyperfractionated radiotherapy to the right breast is a feasible and safely adapted cost-effective radiotherapy practice in our center. Treatment delay can be reduced with this practice. Thank you.
Now we have 2 minutes for questions.
In our study, only we have planned for the right side breast carcinoma patient. We haven't included any left side breast patients.
How about the long-term toxicity? Are there any evidence, like in evidence-based practice in literature survey?
In our setting, we have just started at the end of 2020, and so we are currently at the follow-up of this patient. At the moment, we haven't seen any.
Any other similar studies which have found or done in the past?
In past forward,
in UK, yeah.
Yeah, they have mentioned that late normal tissue toxicity has they have observed, and then we are yet to observe the because we have a small time period of after the treatment.
Were you able to analyze the reasons for these delays? There had been like more than 160 days of a delay in radiotherapy commencement in some patients. Any reasons for?
Yeah, we usually have some more than 3 months in waiting list in Maharagama, but some patients, staff non-patient can they have taken early dates, and others have usually have 3 to 4 months waiting listing.
In your topic, you were saying that the particular method is ultra-hyperfractionation being studied. Do you think your method is the best form of studying? I mean, there has to be a contrast, and I mean, there should be a comparison study, not just a follow-up study.
Yeah, we have to compare with actually that the currently we are traditional method 40 grain 15 fraction, and we have to compare with the traditional one, and yes, we are collecting the data actually, not yet finalized. So yes.
Mike?
Yeah, in main study they haven't included, but they have considered in fast forward they are taken into in pathologically in one disease they have treated. So we have analyzed the addition when so SCF radiotherapy given whether the lung dose is increased or not, and that mean lung dose does not change with the addition of SCF radiation.
Yeah, I must congratulate you and your team. Like, it's the practice changing study. However, it's not an easy study, but it's timely adaptation. So I must admire that the efforts that you have taken.
I think we can move on now. Thank you very much, Harindra. Next, it will be the topic will be 30-day mortality assessment following systemic anti-cancer treatment during COVID-19 pandemic, quality improvement from an audit cycle, presented by N.T. Imbulgod.
Give time for the judges to select the winners. We will be having the raffle draw.
Mm-hmm.
So good afternoon. So this is the study's a 30-day mortality assessment following systemic anti-cancer treatment, which coincidentally happened during the COVID-19 pandemic. It is a quality improvement study from a complete audit cycle. And this study was done at District General Hospital Vavnia, where we established, newly established outpatient oncology unit. Just an introduction. The concept of 30-day mortality. 30-day mortality after systemic cancer treatment is a measure of unsuccessful outcome and a pointer to where treatment should have been avoided. And in the UK, the National Confidential Inquiry into Patient Outcomes and Death has set important benchmarks on this since 2014. And this was the pivotal study in 2014 in the Royal Marsden Hospital. And since then in the UK, all hospitals in the NHS have to do a 30-day mortality assessment following all systemic anti-cancer treatment. And I sort of felt that this was an important importance of this audit in Sri Lanka as well in our setting to assess what happened if this is a deaths within 30 days of chemotherapy, and also because we have public funded system like the NHS, and a significant proportion of the healthcare budget in Sri Lanka is spent on palliative targeted therapies without audits of 30-day mortality. So materials and methods. So this study was conducted as an audit cycle. So audit cycle 1, deaths within 30 days of systemic anti-cancer treatment was recorded prospectively for 8 months from August 2020. And data on following were collected: cause of death, treatment intent, age, performance status, type and line of therapy, delays in treatment, and impact of the pandemic, as it coincidentally happened during the pandemic. And audit cycle 2, so after assessing the data from audit cycle 1, we made certain improvements and we went on to audit cycle 2. So audit cycle 2 was the same things recorded for prospectively for 4 months from May 2021. So just to recap the timing of the COVID-19 pandemic and the study period. So as you can see, so the first audit cycle 1 is between August 8 months. At that time, if you just concentrate on the lower green graph, where we can see active cases were actually very low during the first phase 1 of the first cycle, audit cycle 1. And you might remember at this time there were lots of COVID restrictions, travel restrictions were in place. And then from the second phase of the studies after April, the restrictions were lifted and there were higher increased number of cases in Sri Lanka. This is just the backdrop of the study in Sri Lanka regarding COVID-19. And so the demography of the patients here, so in the audit cycle. So there were 121 patients who had chemotherapy in the first cycle, and 49 had chemotherapy in the second cycle. A total of 170 patients received chemotherapy during this 1-year period. And the 30-day mortality of the audit cycle 1, 30-day mortality following systemic cancer treatment was 9%, which was basically 11 patients out of the 121 patients who received chemotherapy. And so there were no deaths in the adjuvant or neoadjuvant setting. And among the deaths, 63% of patients had first-line palliative treatment, and progression of disease was a cause of death in 63%, and 23% had chemo-related deaths. And targeted therapy was used in 36% of patients among the deaths. So treatment intent. So as I said before, all patients. There were no deaths in the adjuvant or neoadjuvant setting, and 97% of patients had treatment in the palliative setting. 3% had treatment in the radical setting, but had unfortunate disease progression while on radical treatment. So cause of 30-day mortality. Disease progression was the commonest cause of 30-day mortality, which was 64%, and chemotherapy-related in 23%, and others such as massive pulmonary embolism was the cause of death in 9%. And so this is this, and then the causes chemotherapy. So I said the percentage that had chemotherapy-related causes of death. So among the causes of death related to chemotherapy, 34% had neutropenic sepsis, 33% renal failure, and 33% non-neutropenic sepsis. So analysis of lines of chemotherapy, majority had first line chemotherapy and some had second line and very few had third line chemotherapy. And this is, you have to think of the timeline. This was a period when there was COVID restrictions were in place. So patients presented quite late during this period. And contribution of COVID to 30-day mortality in this kind of COVID. So late presentations due to fear of COVID was mentioned in 73% of patients. Quarantine delays was mentioned in 18% of patients, and no contribution from COVID of the mortality was in 9% of patients only. And steps to, so at the end of third cycle 1, we analyzed this data of mortality, and we took the following steps to reduce 30-day mortality further. So regularization of, so we had telephone follow-up clinics during this time, during the pandemic, and the telephone clinic services was regularized by introducing a standard acute oncology service telephone assessment questionnaire, and then development of ETU protocol to prioritize and directly contact oncology team immediately on admission within 6 weeks of treatment, and incorporate assessment of COVID-related toxicity to each clinic telephone encounter with patients, and reassurance of safety precautions taken in the hospital. And also self-reflection by oncologists on better selection of patients for palliative chemotherapy. And knowledge cycle 2, mortality was reduced to 0.4%, and there were no deaths due to chemotherapy toxicity, and among the recorded deaths, there were no delays due to COVID. So the cause of mortality in the second cycle was COVID pneumonia in one patient and disease progression in the other. So in conclusion, an audit cycle leads to improvement in 30-day mortality and can be recommended for practice nationally. And this study was done in a very small center, and COVID-19 contributed to mortality by late presentations.
Thank you very much, Dr. Nadine Bulgoda. Shall we have, do we have any questions from the audience to the presenter?
From when you are assessing the 30-day mortality? After completion? No.
No, 30-day mortality after any systemic cancer treatment. That is whatever chemotherapy, so if a patient died, so we assess the deaths. So we assess the deaths and assess if a patient dies.
But for example, if you are giving 3 weekly chemo, first chemo we are giving.
So I'm answering, just give me a second. Okay. So once we assess the death and then check back, did this patient die within 30 days of any chemotherapy?
Okay, right.
Yeah, so it can be any cycle.
Some people are undergoing third-line treatment.
Yes.
So there were groups who were treatment naive and the people who had treatment earlier.
Yeah.
So did you made any concessions for these?
Sorry, I didn't get the question.
Well, you had some cohorts which are treatment naive, and the other cohorts which had treatment and third line, you mean?
Yeah.
Okay. So do you think that there is some form of activity of those conditions on this 30-day mortality?
Yes. So, if you're having third line, you would expect to have increased mortality in the third line setting, that was seen in the international studies, like the study of O'Brien in the Royal Marsden. That's why my study is a bit different, because as I said, in this setting, the COVID pandemic, patients presented really late. So what happened was, it's actually a very different, result actually from the Royal Marsden, because 30-day mortality is much more common in third line. In our setting, what happened was patients came with poor performance status 2 or 3, and that they hadn't had any chemo, and they were chemo naive, and they came late presentation. So there was a need to give some treatment for this patient, and that is why there was this increased 30-day mortality in the first line setting. And I did reflect that and reduce the chemotherapy and assess performance status more in the second audit cycle.
Compared to the data from your literature surveys, where do we stand, like 10% versus?
Yes, good. It's very interesting. So the Royal Marsden initial study had a 30-day mortality of 8.4%. So this is the 9% is actually quite good. But then that was in 2014. But nowadays in UK, the mortality is lesser. It went down to 3%. But now it's again rising because of the introduction of immunotherapy. And so you give immunotherapy even with poor performance status and like that. So it's again rising to about 9%. But in my study, only chemotherapy was given and very few targeted treatments were given.
So you yourself said that because of the COVID, there were a lot of restrictions for patients to come to hospital. So how would you know that because they didn't get chemo during the previous 30 days before death due to your audit cycle, your interventions having an impact on it, or the COVID actually physically preventing them from coming to the hospital?
Yeah, true. So it's difficult to say that. So basically, because during the second audit cycle, patients were able to come more because there were less COVID restrictions, there were no quarantine delays. So that definitely contributed to having to the less contribution from COVID in the second cycle. So I cannot say clearly that my interventions caused this. Definitely, yeah.
Thank you very much, Dr. Nandini Imbulgoda, for that very interesting paper. Now, it concludes the free paper session, and I must congratulate all the presenters today for their nice and hard work being presented at the SLCU, and I must thank them for selecting this forum to present their work. And until our panel of judges would be ready to announce the winners of the free paper session and the oral paper session, we have an interesting event coming up. So before that, I must introduce the panel of judges to our audience. We have Professor Narada Varnasurya, a senior consultant pediatrician from the University Hospital KDU, Dr. Yasantha Ariratna, consultant clinical oncologist, and Dr. Krishanti Rajasurya from Teaching Hospital Jaffna in the panel of judges. And while we are awaiting the winners, names of the winners, let's give some time for the raffle draw by Sioka Private Limited. Let me invite our president of the SLCO, Dr. A.J. Hilmi, up on stage, and our secretary, Dr. Sachini Rasnaika, up on stage to present our for the raffle draw. Yeah, can somebody from Sioka bring the box of raffle up on the stage so that Dr. Hilmi can. So yeah, the winners. Okay, so there are very precious prizes for the winners of this raffle draw. The first winner goes away with a stay at Shangri-La Hotel, Hambantota, right, with the family. All right. Okay, the second one means a stethoscope, and the third one means a blood pressure monitor. So yeah, so quite interesting gifts here. Yeah, let's choose the third prize first, sir. Yeah. So this is quite interesting. Dr. Nurad Joseph has won the third prize.
I think he needs to monitor his blood pressure, so quite appropriate.
Let's select the second winner. Thank you, sir. This is Dr. J.N. Marasinghe who goes away with this stethoscope. Is he here with us? Can somebody else? We have to draw again. Oh, so only the people who are present in the audience are eligible for the prizes. All right. Thank you, sir. Is Dr. Praveen Taranga here with us? So unfortunately, he's not here again. So we'll have to draw again. Dr. Asanka Rajapaksha. So he's quite lucky there. So here we choose the first prize, yes. So Dr. Damayanti Piris wins the first prize. Is she here with us? All participants. You wait on. Thank you very much. Now, let us invite Dr. Krishanti Rajasuriya on the stage to present the certificates of participation for our oral presenters of the free paper session. So let me invite the first presenter, Miss I.N. Ekanayaka, to have her certificate of participation. And Dr. Nurad Joseph. Miss K. Sindhuja. Miss A.M.J. Seneviratna. Dr. D.G.H. Harindra. And Dr. Naduni Bulgare. And let me invite Dr. Yasanta Ariyaratna on the stage to present the prize for the best oral or best poster presentation. Thank you very much, Dr. Krishanti Rajasuriya. For can we have Dr. Yasanta Ariyaratna on stage to present the best prize for the best poster presentation? So this is named after our late consultant oncologist, Dr. Sarat Abekon. So the winner of the best poster presentation wins Dr. Sarat Abekon Memorial Prize. And let us see who this goes to. So we have had 29 poster presentations this time, and the winner is the 29th poster presentation. 28th, sorry. It goes to Siddharth Vijayasekara. And I congratulate Dr. Siddharth Vijayasekara on this poster on endometrial cancer outcomes in Sri Lanka. Thank you, sir. And let me invite Professor Narada Varnasuriya up on stage to present the gift for the best oral presentation of this time's free paper session. So the winner of the best oral presentation goes away with the SLCO prize for the best oral presentation. And the winner is Dr. Naduni Bulgoda. So she presented a very interesting audit on and free paper on 30-day mortality assessment following systemic anti-cancer treatment during the pandemic. And let me invite Dr. Hilmi, the president of the SLCO, to present tokens of appreciation to our panel of judges. Dr. A.J. Hilmi presenting the token of appreciation to Professor Narada Varnasuriya. And let me invite Dr. Yasanta Ariratna to have his token of appreciation. And also Dr. Krishanti Rajasuriya, who is the editor of the SLCO. And you all can view all these poster presentations online on our website. And thank you very much. Dr. Hilmi, so that concludes the sessions 2021. So we are extremely thankful to all our distinguished speakers who spent their time and effort educating us today. And let me also congratulate all the presenters of the free paper and poster presentation. So tomorrow we'll be having the second day and the final day of our annual academic conference 2021. So we will be back tomorrow for the final day of our annual academic conference live from Colombo from 9:30 a.m. onwards. So enjoy the rest of the day. Thank you very much.